Naresh Rai sir, Arpita ma'am, Shruti ma'am, and Vandana ma'am.
या कुन्देन्दुतुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा। शुक्लां ब्रह्मविचारसारपरमाम् आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीमभयदां जाड्यान्धकारापहा। हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थिता वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदा।
Thank you, respected teachers. We are happy to share that we are live streaming our CME on the YouTube for the benefit of all. The link is being shared on the WhatsApp group of the participants. Now I invite Dr. Naresh Rai sir, President, Rajasthan chapter of IAPM, and the chairperson for today's CME for the welcome address.
Welcome all the delegates, guest speakers, and all the members of organizing committee. This is a second activity of Rajasthan chapter of IAPM here. We had a IAPM quiz for undergraduates in SMS Medical College, and this is CME in which we have we have focused on bone and soft tissue pathology or bone and soft tissue tumor. We are also having a state conference in Mahatma Gandhi in coming few days, and I'm sure that because in fact it is third or fourth or fifth revival of Rajasthan chapter, because one revival we did in 99 in Kota, then there were few conferences and then again it slept. Then in 2009 again we revived in Kota. 2014 we also had a national conference of Indian Academy of Cytology in Kota. And here again, last year only the chapter has been revived, and there are many active members. woman power, who was, working very hard to keep the chapter revived and keep activities going on. So I welcome all of you. Thank you.
Thank you, sir, for your enlightening words. Without any further delay, I would like to invite our first speaker, Dr. Parul Gupta Modi, Associate Professor at Department of Radiodiagnosis, SMS Medical College. Her areas of interest include musculoskeletal radiology and cross-sectional body imaging. She will be presenting her talk on bone tumors, a radiologist's perspective.
Good morning, everyone. At the outset, I would like to thank the organizers of this prestigious CME for inviting me to deliver a lecture on evaluation of bone tumors from the radiologist's perspective. So as with the pathology, we also deal with formulating a diagnosis using various modalities that are available with the radiology. So the gamut of modalities that are available, as you all would be knowing, includes radiograph, CT, MRI, and combined PET-CT, PET-MR, which is a domain with nuclear medicine and radiology together. So among all these modalities, it's the radiography in two orthogonal planes as per the American College of Radiology that should formulate a diagnosis in up to 80 to 90% of the cases. Only in certain conditions, the role of CT, MR, and other modalities come, and of those also, MR is important because it helps not only in diagnosis, but also in surgical planning. So, dealing predominantly with radiography, which is our primary imaging modality, it's always an inverted pyramid approach. So we, first of all, always consider age, absolutely important in formulating a diagnosis. Then we evaluate which bone is involved, and within that bone, its longitudinal positioning as well as transverse positioning is important. After we take care of this age and location, we come to evaluating of the aggressiveness, which is actually considered as the primary domain of the radiologist. By aggressiveness, we mean that we want to evaluate whether it's a malignant lesion or it's a benign lesion. And then come the other features like matrix, size, number. So beginning with radiology, as a rule of thumb, we follow that if the age is more than 40 years, it's usually the malignant tumors that the patient is dealing with, namely the metastasis, myeloma, and then lymphoma or other primary sarcomas of the bone. And in less than 40 years, it's usually the benign tumor unless we see a malignant aggressive kind of picture on radiograph that the patient in the second decade of life could be having either Ewing sarcoma, osteosarcoma, or in the second to the fourth decade could be having surface osteosarcoma or chondrosarcoma. The second thing to evaluate is the location. So we have to deal which bone is being affected. So as you all know that we have got different bones, either it is a flat bone where predominantly we will find the red marrow. So sternum, calvaria, ribs, innominate bone, and vertebra will have a greater predilection for involvement by myeloma or metastasis. Also, certain tumors like chondrosarcoma, GCT, they have a predilection for flat bones. As far as long bones are concerned, usually we consider all tumors generally benign, and among the malignant tumors, they are either Ewing's or osteosarcomas. Then sesamoid is also a favored site for involvement by GCT and ABC. Coming to their positioning within the bone. So if the long bone is involved, we try to evaluate whether it is involving the diaphyseal area, metaphyseal, or epiphyseal. Usually most tumors involve metaphyseal area, so you only have to remember if the lesion is involving epiphysis, it has to be either GCT, chondroblastoma or clear cell chondrosarcoma. And diaphysis would be involved by all small round cell tumors, or fibrous dysplasia usually will not have a pathology asking for this diagnosis because it's usually a radiological diagnosis. And SBC, osteoid osteoma, usually we diagnose it radiologically itself. Transverse positioning of the tumor is equally important. So if we feel that the tumor looks cystic, but it is placed centrally, it is likely to be SBC. Versus a cystic tumor which is placed eccentrically would be ABC. Similarly, for chondrogenic tumors, if it is placed centrally, it is likely to be enchondroma. Versus eccentric, that would become a chondromyxoid fibroma. Among the fibrous, the central involvement is by fibrous dysplasia versus eccentric, which is non-ossifying fibroma. And among the malignant tumors, the small round cell tumors and chondrosarcoma tend to involve the central axis versus osteosarcoma and malignant fibrous histiocytoma that will have an eccentric positioning. So when we combine both the age and the location, the differentials are narrowed to a great extent. So even before starting radiology per se, we actually reach to a narrow differential diagnosis. Now let us come to the main radiology part of the X-ray. So here we basically evaluate the aggressiveness of the lesion, and for aggressiveness we evaluate the margins of the lesion and the zone of transition. So what is the difference between the two? Margin is if you hold a pencil and you try to make a clear line around the tumor and you are able to do so. So that means it's a well-defined margin. Versus a malignant aggressive lesion which will have an ill-defined, indistinct, blurred, and you're not able to make a line with the pencil. What is zone of transition? Zone of transition basically refers to how we are basically differentiating between this lesion and the normal marrow. So if this border, besides being well marginated, shows a distinct density difference, so we call it as narrow zone of transition, versus a lesion where we are not able to make out where the normal marrow has started, that will become a wide zone of transition. After evaluating the margin and transition, the second most important aspect is evaluating the periosteal reaction. So it is understandable that when the lesion grows, it grows towards the surface of the lesion and our body tries to control this lesion. So that will happen by the upliftment of the periosteum, and it will give a solid kind of periosteal reaction. It will try to contain the pathology. So it will have a solid periosteal reaction in benign lesion. Versus a tumor which is very aggressive, the body is not able to control. So either it will have lamellated kind of onion peel reaction, or it will still grow and it will have sunburst kind of a pattern or an interrupted periosteal reaction, which is basically the most aggressive form. So since the tumor is growing out, it will have cortical destruction, and then this will extend into the soft tissue. So all the malignant lesions will have some kind of a cortical destruction or extension into the soft tissue. And then tumor matrix, though it's a separate evaluation itself, but among, suppose we are making a diagnosis of osteosarcoma, a tumor which shows a dense matrix is more likely to be low grade versus an osteosarcoma which does not show osteoid type of matrix. The size and number is important. Larger the size, generally considered to be malignant, but we have seen cases of fibrous dysplasia where it would be very elongated. And number of lesions, generally, more the number of lesions, it's benign, but mets and myeloma are known to be numerous. So the pattern of bone destruction, as classified by Lodwig, for everyone to understand is, when we see a lesion which is geographic, you can make out that yes, there is a lesion distinct from the normal density of the bone, versus a lesion which looks that there is a lesion, but you are not able to make out where the normal marrow has started. And this is, in total, you are not able to find out a well-defined lesion, and it is seen to be associated with all features of aggressiveness. Let's see each one by one. So type 1 means geographic lesion, well-defined margin. Now this well-defined margin, if you take a dark pencil, it is having a sclerotic rim. Sclerosis, good, implying benign. Then this is a lesion which is geographic. You are able to make out a line with the pencil, but definitely this is not a dark line, no sclerosis. This is also benign, type 1B. This is a lesion which is distinct. You can make out that it is called a narrow zone of transition. You are able to make out this as a lytic lesion. You are able to make out a line, but here, somehow the margin are indistinct. So this is a quasi-malignant GCT type of appearance, where the margins are indistinct, could be representing a focus of aggressiveness at this point. The type 2 and 3 are what we call as moth-eaten or a permeative reaction, where a permeative type of destruction where we are not able to make out a distinct single lesion. We are not able to make out where this lesion is ending and the normal marrow is starting, more so with the permeative pattern, and usually these lesions are associated with aggressive type of periosteal reaction, as you see here, as an interrupted periosteal reaction with the soft tissue, with areas of cortical destruction, or a sunburst type of periosteal reaction with an osteoid type of matrix here. Now let us see some of these cases. What do you think? This is a geographic lytic lesion. Very well you can make a outline. You see sclerosis. So what is it likely to be? It is likely to be benign, type 1A. Narrow zone of transition. Look at this lesion. This is lytic sclerotic, mixed pattern. But where is the normal marrow? Maybe here, maybe here. So this is a aggressive type of lesion, wide zone of transition. Look at this lesion. Yes, this is geographic. You are able to make out, but this cannot be made with a single thin pencil. So it has got irregular margin, slightly wider zone of transition, but look here, there is cortical breach. There is interrupted periosteal reaction. Now, these are to show various types of periosteal reaction. This is the most aggressive variety where you see certain lamellae. These lamellae are called as onion peel skilling, and when the tumor outgrows there will be interrupted periosteal reaction, also called as Codman's triangle. This is to show sunburst type of periosteal reaction. Coming to the tumor matrix, basically radiographically we deal with three types of matrix, either osteoid or chondroid or non-mineralized. So both will appear dense. Dense means more white on X-ray. So how will we differentiate between osteoid and chondroid matrix? So osteoid matrix is generally more denser but ill-defined. So it will be a fluffy, amorphous, cloud-like appearance, versus chondroid, which will be smaller in size, better defined outline, so they will give an appearance of ring and arc or a popcorn or a punctate type of reaction. And then there is a non-mineralized matrix which can be evaluated further on MR. That is, we can tell whether it is fat, whether it is blood, whether it is fluid or fibrous or generally soft tissue. Then soft tissue extension we have already discussed. If it extends outwards, that means it is highly aggressive tumor. Multiplicity, more and benign, but again, can be seen with metastasis myeloma also. So to summarize, radiography is the starting point. It is quick, low cost, easily available, and will formulate a diagnosis in 80 to 90% of the times. Two orthogonal planes, very important to assess the Lodwig classification and the tumor matrix. So we reach to a diagnosis whether it is aggressive or non-aggressive, whether it is single or multiple, when we do multiple X-rays as in form of skeletal survey. And finally, to tailor the cross-sectional study. So we know that this is the pathology, and we have to, if we have to evaluate further, what modality and where it has to be done can be tailored. So what is the role of ultrasound? You must have heard. Sound waves cannot penetrate bone. We cannot assess bone on ultrasound. But what can we assess? We can assess the soft tissue. So soft tissue, whether it is cystic solid, compressible, vascular, and also for taking FNAC or biopsy samples. What is the role of CT? CT is equal to X-ray, but taken in all the three planes. So if you take X-ray from all the three planes, complex anatomy like innominate bone, skull, vertebrae can be very well evaluated on CT. Whatever you see good on X-ray, you'll see better on CT. So here you see that there was some kind of a sclerosis, periosteal reaction, some kind of marrow involvement, not very clear, but here you see that definitely there's cortical breach, definitely there's periosteal reaction, and we can also see some soft tissue. So CT, C calcification, C cortex, and related to calcification, periosteal reaction, best seen on CT. The other role of CT would be in systemic staging. So a patient of osteosarcoma can have some lesions in the chest, so we can see for metastasis in the chest. Also, for surgical planning, MRI is the best modality, but sometimes patients can have contraindications to MR, like patients who are even terrified of lying down in MR for long, or having pacemaker, or very obese patient who cannot go into the gantry can be subjected to CT for surgical planning. Also, there is increasing role of intervention with radiology on CT. So here it is a case of osteoid osteoma, and it is a routine procedure, radiofrequency ablation at our institute. We also do microwave and cryoablations. Let us see this example. So this was a radiograph of PNS, and you see that there is a sclerotic lesion also basically completely occluding the right maxillary sinus, involving a part of the zygoma, but you're not able to make out where normal marrow. So it is a wide zone of transition lesion, likely to be aggressive, and this patient was then subjected to CT, and we can very well see the involvement as well as the osteoid type of matrix. The patient had a chest X-ray, and we could see some rounded lesions which were found to be metastasis on the axial CT. Now, coming to the role of MRI. MRI is basically without radiation, so very effective in evaluating especially pediatric patients or oncology patients who need to have repeated imaging. It has got good diagnostic help, especially for evaluation of non-mineralized matrix, where we can confidently say that this is osseous lipoma, or it is a bone infarct, or even fibrous dysplasia. Even chondroid matrix is very well evaluated on MR by its phenomena of high T2 value, so it gives a light bulb kind of a phenomena. Surgical planning best done with MR, because not only the physis, but the joint involvement and the neurovascular bundle involvement is best assessed on MR. Restaging, very helpful, avoids radiation also, and we have started this routine procedure of whole body stir and diffusion weighted imaging, especially in children of LCH or leukemia, lymphoma, and sarcoma for evaluation in conditions where we could not subject this child to much of radiation on PET-CT. The role of MR also lies in patients who are symptomatic and X-ray do not show any lesion. Because for X-ray to show any lesion, about 30 to 50% of the bone loss has to be there. So all patients who are symptomatic should be subjected to MR. And in MR, we basically do two types of evaluation. One is the structural evaluation, where basically we subject the patient to T1, T2, fat SAD, and a contrast enhanced image. And we do a functional evaluation also, where we do diffusion weighted, perfusion weighted, and spectroscopy, which tells us about the functionality, how much aggressive the lesion looks. So let us see this example. I have time? I hope I have not overshoot. So this is one lesion where we see that there is involvement of the humerus, a lytic lesion. It does not have a narrow zone of transition, definitely, but it is involving epiphysis. There is some kind of a cortical breach. So based on the X-ray itself, it is an aggressive lesion. Involving epiphysis, so I have only three things in my mind. GCT, GCT, chondroblastoma, not the age, and then clear cell chondrosarcoma. My diagnosis is there on the X-ray itself, but again, the surgeon asked for the MRI, and we saw this is what is called as light bulb phenomena. This chondroid matrix has actually completely lit up. And we are also subjecting the patient to contrast, and we see that this was actually the necrotic area, and the dense cellular density was around the lesion, and so any biopsy should be taken only from the periphery of the lesion. This was one patient where X-ray was no abnormality detected, but the patient had pain. So this patient was then subjected to MRI, and we did found an area of altered signal intensity involving the body, the pedicle, and the transverse process. And finally, upon CT guided biopsy, even CT could not show this lesion very well, but we just did a biopsy from this patient, and this turned out to be metastasis from some unknown primary. Now look at this lesion. On X-ray, this is definitely aggressive lesion, cortical breach, soft tissue, wide zone of transition, indistinct margins. This patient was subjected to CT by some outside, and it did not show any significant matrix. No great information could be achieved with CT. But when MR was done for this child, we found that this tumor is crossing the physis. This definitely affects the surgical planning. This is the T2 weighted image, this is T1, this is T1 post-contrast, and this is to show diffusion weighted images. This is DWI, which just looks like T2, but everything else is suppressed, and this is ADC, which is just the opposite of DWI. So anything which is black on ADC map which is having high cellularity, high density. So suppose you are not able to give contrast to this patient, just a DWI image will tell which is the viable area and where the biopsy should be taken. So let us see this case. This is again a child with predominantly diaphyseal involvement, aggressive type of periosteal reaction, wide zone of transition. So what is the information that I'm trying to get on MR? I am trying to evaluate where, till what point the marrow is involved. I'm not able to say that correctly on X-ray. Also, the soft tissue are very blurred, which are very well seen on MRI. So the soft tissue involvement, to what extent, whether it is involving neurovascular bundle or not, is imperative for the surgeon, oncosurgeon to know. Now this was a case which showed an aggressive type of periosteal reaction. I was not able to make out whether it is involving marrow. It was a surface kind of round cell tumor. What is the soft tissue involvement? This patient was subjected to MR, and we definitely saw on DWI restriction. So this was aggressive lesion, and this actually turned out to be a small round cell tumor. This is a classic appearance of an osteosarcoma. This is an osteoid type of matrix in a child, child of second decade, around 17 years, aggressive type of periosteal reaction. But whether it is in crossing physis, involving joint, involving epiphysis was pretty not clear. So this patient was subjected to MR by the surgeon, and definitely we picked up the skip lesion. We saw that it is crossing physis, going into epiphysis, also involving the joint. This is to show the DWI. Again, the viability of tissue was assessed on DWI itself. We did not subject the patient to contrast. So this is another case. This was a surface osteosarcoma, pathology proven. And this is to show an interrupted type of periosteal reaction. Again, this is contrast image, this is DWI, and this is to show that we do CT-guided biopsies for these patients. Lastly, I'll end my talk with the hybrid imaging, which is a domain with nuclear medicine and radiology. You can say it's a one-stop shop because we are doing functional evaluation, whole body evaluation, and local evaluation. But these are not available everywhere. These are very costly also. So we still have, at the state cancer, we have PET CT with us, but PET MR is in its infancy, and that would be the best modality ever available. After radiograph, again, to say so. I'd like to end my talk, and thank you very much. If there are any questions, I'm happy to take.
We can have a quick round of question and answers, if any.
T2, T1. Ma'am, you want to know how to identify T1, T2? Yeah. So ma'am, basically T1, you can always check whether you see the fat as bright. Begin with the subcutaneous fat because the bone marrow can be infiltrated, so you cannot rely on the marrow fat. So it's imperative that you always start with the subcutaneous fat. Subcutaneous fat will always be hyper, even if there is some sort of paniculitis or whatever. So you will always, you begin with the subcutaneous fat. Subcutaneous fat will also be bright on T2, but how will you differentiate between the two? Either you have some fluid filled structure, which you do not have in the extremity. So what we do is, you look at the pathology. So pathology will always be iso intense to muscle. Muscle is one thing which is available with us. Versus pathology on T2 will always be hyper intense to the muscle. I wonder if I have any. Generally, ma'am, we have been doing fat sat images more for a quick thing. So maybe you find it difficult, but you can also have people doing T1 fat sat for you to confuse. So yes, maybe after seeing a lot of cases, you can make out, but always remember pathology, water increase, bright. That is one thing to always remember. And DWI and ADC can be very well seen. They will have a very bad kind of a spatial resolution. Only the pathology will stand out. Everything else cannot be seen distinctly.
Thank you, ma'am, for this impressive lecture. As Dr. Parul ma'am has to leave early due to PG exams, I request Dr. Devki Keswani ma'am and Dr. Hema Udawat ma'am to felicitate her with a small gift as a token of gratitude. Thank you, ma'am. Our next talk will be on grossing and reporting of bone tumor specimens in surgical oncology by Dr. Bharat Rekhi sir, Professor, Department of Pathology at Tata Memorial Hospital, Mumbai. Sir is one of the founding members of ABSTP and the current vice president. Also the secretary at the Indian Academy of Cytologists and also the editor-in-chief, Journal of Pathology and Microbiology.
किस नाम से? सर कोई प्रॉब्लम नहीं. Good morning, everyone. At the outset, I'd like to thank immensely Dr. Rai, Professor Rai sir, and Dr. Bhargav for inviting me. Uh, I would like to mention that, you know, we always say bone is hard in its consistency as well as in dealing with the tumors. Because I do these tumors, you know, there aren't too many, because when we do as bone and soft tissue, you know, soft tissue tumors are so many, more than 100. But I can tell you, and I think from our experience in bone pathology across the world, we've seen an osteosarcoma can be a difficult diagnosis and it has high stakes. So bone is hard, and thank you Dr. Bhargav and Rai sir for taking up the challenge to have a CME on bone tumors, which is not a very frequent choice, but aligns very well with the aesthetics of this place in Rajasthan, who has a history of orthopedic oncology, and really very happy to be here. The previous speaker, Dr. Parul, has very nicely set the stage, and I echo from the words of one of the very renowned bone pathologists, Dr. Unni, who said that the best image in pathology, and this is coming from a pathologist, is a plain radiograph. So just goes to show how radiology is important. And on a lighter note, I joke that, you know, bone and soft tissue pathologists are half radiologists and maybe 1/4 oncologists. So on that note, taking further from the radiology perspective, we'll move towards the grossing and reporting what we do in bone and soft tissue tumors. Here again, to have two words to share with you. We have moved from an era of radical resections, major resections, and now we're in the world of limb salvage. And what goes behind every patient, what an oncologist is trying to do, is balance the oncological and functional outcomes in a patient. So it's very important that we know this philosophy behind what we do, and that's a very important part of a MDT, which is imperative in bone and soft tissue tumors. So you not only remove the tumor as much as possible, which is important from oncology perspective, but also restore the functional ability of a patient. And that is wherein lies the aspects of excisions, how we attribute margins in those, and then this takes further how our oncology or surgeons take up the challenge for reconstructions to restore functional outcomes in those patients. So this just goes to show how important margins are, how we attribute, you know, towards the resections. Very nicely, we are able to furnish details which are very important from the clinical perspective. So grossing bone tumors can be challenging because of the inherent anatomical characteristics, the types of surgeries, the nature of the tumor, the unfamiliarity, and that is they are rare tumors, because on a big perspective you can see not all pathologists have access. Of course, soft tissue everybody comes across in their career, but bone tumors mostly in the centers where there is a very active oncosurgical practice is where pathologists are able to receive and have to handle these challenge. And again, there's a unique method of handling post-treated specimens. And when I say I have examples of classically osteosarcoma and Ewing sarcoma, how we handle those resections. So what is very important is a good bone saw. It's mostly electrical, but you know, people, so it's centers which do not have, people have been trying to use the mechanical, but electrical gives you very nice, you know, the resection cut surface. And again, the other important point is fixation. I can't emphasize how important fixation in pathology at large and also in bone tumors, because we are in the world of not only immunohistochemistry, but also molecular. So if you have a very heavily acid decalcified specimen, you have no chance that you can handle this case. Even if, you know, sometimes your surgeons say, oh, I'll give you the entire specimen and you can deal with it. And you are at the back of your mind dealing with some translocation positive sarcoma, maybe Ewing's, or some unusual tumor in bone that we are seeing of late. So if it's a heavy decalcified specimen, trust me, none of the molecular test is going to work. So we have our policy at TMH that we don't take acid decalcified specimens hugely that are for molecular testing, be Ewing sarcoma or any of the new fusions. So what we've been doing of late for the smaller biopsies at TMH is a bone marrow kind of a recipe that we have, the AZF fixative, that we have the acetic acid, zinc chloride formalin, and that has been working well. We use 10% nitric acid for the major resections because, you know, you have other choices like formic acid or EDTA, but it takes a while. And we have our turnaround times, and everybody has that challenge. So you can't have a specimen forever. It takes a lot of time, the EDTA, and also it's very, very challenging. But it's very important that, so we came to a bridge that we can at least save a slice from a major resection in EDTA if we want to go for molecular testing, if we are anticipating. We've not been very successful to do so, but that's my suggestion for centers who are doing and who want to embark on doing molecular testing. So what is the purpose of grossing? Important specimen, we all know we have to furnish a report. So we have to classify the diagnosis in terms of its benign, intermediate, or malignant. So we don't have something like borderline. From the radiology perspective, I was just about to ask the question also from Dr. Parul, but in the interest of time, I think, and she had to leave. We have terminologies of late, coming up in our JCs as locally aggressive tumor, and that's not what I as a pathologist can give, because we have to classify very accurately, even in those intermediate, and the classic example is giant cell tumor of bone, which can recur and rarely metastasize. So you have a benign counterpart tumors like osteoid osteomas, which we hardly see because they're ablated now. You have enchondromas, again, small lesions might not be biopsied. Intermediate lesions are quite often, and the locally aggressive classic example is a giant cell tumor of bone. Chondroblastomas, of course, are benign tumors, which is a bit contentious because you have malignant variants also of chondroblastoma. But at this point in time, it's a benign tumor. In malignant, we know the classic example of chondrosarcoma and osteosarcoma. And there can be, even though there are limited number of these tumors, there can be a challenging because all these tumors have their different phases. Once we've made a diagnosis of a sarcoma, we have to grade it. So osteosarcomas conventionally are high-grade sarcomas. You have to put a classifier if you're dealing with a surface or a central, because those are low-grade sarcomas, parosteal. But periosteal surface osteosarcoma or juxtacortical high-grade transformation or a sarcoma is going to be high-grade. Why it is important? Because it influences the treatment. Because low-grade osteosarcomas are going to be, the candidates for resection, but high grades either will receive neoadjuvant chemotherapy at the upfront or will be having adjuvant after excision. So it's important that we grade. Chondrosarcomas, of course, in terms of their grades 1, 2, and 3, do not have too much of the treatment management, aspects in terms of grade 2 and 3, because those are high grade, in contrast to grade 1, which can be curated, but high grades have to be resected. Chemotherapy is very contentious role in high-grade chondrosarcoma, so these are not very chemosensitive tumors. So that's again a very important point to know when we have to differentiate a chondrosarcoma from a chondroblastic osteosarcoma, because osteosarcomas are chemosensitive generally, even though chondroblastic is not so, but chondrosarcomas are generally non-chemosensitive tumors, except very few in which it's offered, but it's not a lot of success. So diagnosis, then sarcoma grading, and establish the extent of tumor involvement, especially in marginal resections. So ideally it has to be a 2 centimeters, which is not always possible, but most of the times we do receive resections with a clear 2 centimeters margin. In contrast to soft tissue sarcomas, which have 1 centimeters. But there is a lot of discussion about in soft tissue sarcomas, especially for large size specimens, where the oncologist cannot achieve our 1 centimeters, and the concept of qualitative margin with a nice fascia, which might not be 1 centimeter, but a nice clearance is still acceptable in soft tissues. In bone, it is 2 centimeters ideally. Then, like I said, we have to evaluate the post-treatment response in terms of the neoadjuvant chemotherapy that is offered in osteosarcomas and Ewing sarcomas, and it has a very, very crucial role in further, how the prognosis is going to be and how adjuvant treatments can be offered. We also have to furnish the information related to the nodes, lungs, skip lesions on radiology that they can pick up and that can influence the type of resections they will go further. And also rarely we do see fluid specimens like, you have a case of osteosarcoma and patients got pleural effusion, and we have to mention, or figure out whether there are tumor cells, and sometimes we do salpeter in those situations, but actually is not a very useful marker. So just bringing the same cartoon, because I think it's more for reinforcement, as Dr. Parul mentioned, we know lesions which occur where. There's a number of lesions, and it's good to have an idea and know that tumors like giant cell tumor of the bone are predominantly epiphyseal. They go close to the articular surface. They're mostly in adult patients, but in the pediatric patients, if you're seeing a GCT, it's mostly metaphyseal. So, depending upon the epiphyseal plate closure and, the age, you can have certain tumors that can straddle in terms of their location. Osteosarcomas, chondrosarcomas are mostly, metadiaphyseal destructive tumors, and we know certain tumors are very site-specific. I'm just adding towards what Dr. Parul mentioned, like adamantinoma in tibia, and that's a cortical-based tumor. Again, you have fibrous dysplasia, which again occurs in the diaphysis, and it's kind of a leave me alone lesion. Generally, they don't do anything for fibrous dysplasias until they are causing some deformities. And similarly, it's osteofibrous dysplasias causing any deformity. It's at the time when they intervene, and adamantinoma, the next level, is going to be removed as a malignant tumor. We don't see osteodostomas too often because these tumors are now picked up on radiology and they're ablated. So I always treasure one of my slides of osteodostoma with that little nidus that you see, very typical appearance of osteodostomas, because they can pick up on imaging and they right away go for ablation. Similarly, small chondroblastomas are also being ablated because they are trying to see, and there are many other techniques. It's very good to know also when you interact with your the oncologists in JCs, that the kind of the treatments that are coming in, how it has changed the practice, how it's influencing what work we do. So I think it's all a very, very important team effort. Now, as pathologists, we not only report, we also think why it happens. And I think if you know the why, then you know what you're seeing, why you're seeing so. And I'm just bringing this point again, why do we see a very, lytic lesion or a very well-defined or a geographic lesion in benign tumors, and we see this lot of reaction that we see in the more sort of moth-eaten or destructive lesions or permeative lesions that we see mostly in malignant tumors. But we need to know also there's a caveat in our country. We have tuberculosis. We don't miss out on infections that can clearly mimic Ewing's on imaging. Of course, they have a nuance of the fat involvement in the inflammation tubercular lesions in contrast to Ewing's, but again, the ball is in the court of the pathologist. For those round cells, are they lymphocytes or are they Ewing sarcomas? A huge difference, and it can be a challenge. Now, when we talk about these lesions as permeative or forming codments, triangle, or lamellated, which again, we always like onion peel appearances, Ewing sarcomas, you can see also in osteosarcomas, if you know why. So, what the tumor does is it destroys the bone, and how the bone responds is the periosteal reaction. So if you have a malignant rampant tumor like osteosarcoma, it will, lead to an interrupted, destructive, sunburst, whatever name you want to call that, a very irregular periosteal reaction. In contrast to benign tumors, which will occur over a period of time, cause a nice lytic lesion, a geographic lesion, and with a thick, margin, because it's a benign tumor, it's not destructive. So that's why it's important that we know the image, the way a tumor appearance on imaging, why it happens. And I think that's very important for pathologists to question. A very classic example I think you all can associate with this first, can I quiz you? What could be the first image? Anybody for the postgraduates? You look at this very typical, well-defined geographic lesion in the epiphysis. This is an chondroblastoma. The second is, whenever I'm seeing a slide with my residents, and I kind of like to blind myself and I say, oh, is this tumor in the young female and in the radius location? Because that's the most common appearance of a GCT, and we see a lot of GCTs in our country, giant cell tumor of bone. Now that's what I think was mentioned. You sometimes might not be able to appreciate the lesion like Ewing sarcoma on imaging, plain radiograph, because they are very imperceptibly blending in this, like this is the lesion, but you see a big soft tissue component, and it's very wide zone of transition, diaphyseal lesion, destructive, lytic sclerotic. And then you can see this lamellated periosteal reaction in lymphomas and Ewing's, because over a period of time, these cells, lead to these layers of periosteal reaction. In contrast to osteosarcomas, which are very, very destructive, like lead to those sunburst appearance. That's an example of a Ewing sarcoma. And the other, anybody wants to take a chance? Very typical appearance. It's called rings and arcs of calcification in chondrosarcomas. You can see, and again, why does it happen? Because you have these tumors come as very lobulated chondroid areas, and these have these calcifications which show up as lobulated bright on T2. It's a, like, I love that word, light bulb sign, you know, it's just lights up. And I used to, always used to say, oh, it just lights up, you know, the myxomas, the chondrosarcomas on T2 weighted images. And then you see these rings and arcs of calcification in cases of chondrosarcomas. In contrast to, you will see more perhaps flocculent kind of calcification, irregular in osteosarcomas. You see more like popcorn-based calcification, again very rounded in chondroblastoma. So kind of the calcification of the matrix is also important to appreciate on imaging. That's again an example of a very destructive looking sort of tumor, and that's a osteosarcoma with this irregular flocculent calcification. And you see this more again destructive tumor, so you can think this is more like a lytic lesion, but it's still very destructive. You know, this is a telangiectated osteosarcomas because these don't have too much of matrix, and these are almost similar as giant cell rich osteosarcomas, and they look very lytic and destructive lesions. That's a classic example of a surface-based. You can appreciate really tons of this ivory kind of, you know, matrix on the surface, and that's in parosteal osteosarcoma, a candidate for resection. Only if there is a high-grade transformation, there will be adjuvant treatments offered. Brings me to the type of specimens that we handle. So it's very important, again, we know, and it's been seen that who does the biopsy, and you know, in a lot of fora, the oncologists like to stress upon that point. As much as we say that, you know, bone pathology should be reported by bone pathologists, it's not that they are very genius, but they just see more cases, they have more experience, they interact more. Similarly, the biopsy done by the surgeon is very important because the track that they will, you know, they will plan their resections further with the diagnosis, how they're going to go further. So J needle biopsy has been very successful, including the evidence from our center in about 90% cases. So, you know, it's not like I want more tissue. It's good to have 4 cores of a representative, well-fixed tissue, and that's enough for you to make a diagnosis. You will still see some of the oncosurgeons across the country who believe strongly on open biopsies, and none of the pathologists, you know, will say no to that, right? So we always want to see more tissue, right? But that's not the norm, because, you know, it can lead to contaminations, and we see botched surgeries as a result of failed, you know, curetages for osteosarcomas, and it definitely influences the patient's management because they have to go further for very major resections, which these patients might not want. So open biopsies are only in cases if, you know, you have your 1 to 2 J's, you know, failures of the J needle biopsies after discussion. So we all the time have this stress of chondrosarcomas on, you know, small tissues, and I want to really know how many people handle that. So that's one area where you can ask for an open biopsy, because, you know, low-grade chondrosarcoma is a very imaging-based diagnosis, or we call it atypical cartilaginous tumors in the long bones. So the type of biopsies is very important, and we can't ask all the time for more, especially in osteosarcomas, but of course you can ask for more tissue if you're suspecting a chondroid tumor, and don't shy away. Don't get in the stress if you are being, you know, on your head, the surgeon is, tell me it's a enchondroma or a chondrosarcoma. There is not too much of fuss. You can ask for more. They can even curettage those specimens, depending, of course, upon, again, how big the lesion is. Excision biopsies, wide resections are mostly planned for sarcomas because they want to ensure margins. And again, like I said, we're in the world of salvage. We have to save the limb, so we go for the, as much as possible for malignant tumors, the resections with margins. So I always feel that we don't always think about as a pathologist, but also we think about how our report is going to lead to patient and how our surgical colleague is going to handle. So if you align this thought process, it makes you very, you know, self-worthy. And then you don't have to say, call me a clinician, I'm a pathologist. You do feel like a clinician, right? And as a part of the team, you are a clinician. So once, you know, the most of the resections, like I mentioned, are candidates for the excisions are in cases of sarcomas. They go for radical resections like amputations or disarticulations if there's a big, large tumor that is, you know, they can't achieve good margins. There are multiple lesions, so that's a choice only if there are multiple skip lesions and there's a big, large tumor, botched up surgery, and they can't save the lip, so they have to go for it. So that's the last choice, but you don't want to leave the tumor, so they have to, you know, go for the amputations. Then, like I mentioned, we have to deal with the specimens of neoadjuvant post-treated specimens in cases of high-grade osteosarcomas, Ewing sarcomas, and of late we are seeing some unusual specimens like extracorporeal radiotherapy, treated specimens, so the ECRTs that they do again for limb salvage. They take out, they have a diagnosis of Ewing sarcoma, they will take out some shavings, They might take out the bone and then they irradiate and put it back. Again, just to ensure that they can have better on-call functional outcomes in those patients with high-grade diseases. The landscape of giant cell tumor in diagnosis and management has changed drastically over a period of time, and that has led to us having some very interesting specimens which we didn't have. So you might not see a very hemorrhagic giant cell tumor resection specimen now, but you might see a very osteosarcoma-like appearing specimen of giant cell tumor because it is treated with denosumab, and that's been a magic bullet. Of course, it's not curative, it just helps in better surgical clearance to the oncologist. So I'll just come to that detail about GCT specimens. So like I mentioned, the fixatus is of paramount importance. At least 6 hours your biopsies should be in the AZF, that's what we do. It's important that we don't always, and that's a very favorite line for the, and I'm not judging our residents, they do fabulous work. Gray white specimens, multiple bits, that's it. It's important, I think, if you can mention that you're seeing a cartilaginous areas which looks like glistening, or you have more hemorrhagic specimen, which you will see in GCTs or ABCs, in contrast to, like I mentioned, more glistening areas in the chondroid tumor. So it's important that we separate, describe and also separate specimen tissues which are soft and which are resilient like cartilage and hard like bone. And the bones you can ask for decal, and the other tissues you can, send for your formalin. Also the soft tissue, because again you can do molecular testing. You can't do on the bone which is decalcified, the tissues which are decalcified. So separation is very important, describing individually is very important, and not missing out on any tissue, because we had, my earlier colleague, Dr. Jambekar, we used to, kind of say that, let's ensure our tissues are fixed. So once we had, we told the residents that please separate the bone and soft tissue, and what it led to was the bone tumor bits were discarded, and it was like a big thing that, oh, we didn't say to remove it, just separate and process it differently. So again, communication is very important, that we're dealing with the people who are grossing. Coming to wide excision of long bones, it's important that we orient the specimen in terms of sutures, like, if they have been sutured, of course, in bone, we have the landmarks that we can figure out. If it's a soft tissue mass, which a bone tumor, which is completely obscuring, and I'll share with you in a specimen like that. So it's important that, you can have an oriented specimen. Measurements are very important. Soft tissue skin, important. The measurements are very important, because again, it's not only a tumor diagnosis, you are also justifying the resection, again, thinking from an oncologist perspective. And in grossing room, we have an access to the imaging also. So all the time they do the resections, they can always have a look at the images, the radiographs, and figure out that, and then you don't have to go back that they had some satellite lesion, they had an individual additional lesion, and that is what led to justification of this major resection. So it's important before, you're grossing a wide excision, you know the radiological appearance also. Not missing out on the external aspect, taking the margins before you actually go for the tumor sampling, which is again very important. And the cut margins are by transection, that's called the shave margin, and clearing all the bone, these tissues. So you take the margins before, you take the shave margin, and then you actually go for the main specimen that, we take a cut with the bone saw. So the bare bone is now bisected in a coronal plane to expose the maximum area, and it should be very important that it's, in a very smooth. So that's why the electric saw is good, because it gives you a nice uniform cut. In contrast, if you're doing manually, you will see a lot of serrations, and then you might not appreciate the tumor very well. So exact size, again, site is very important, because you have certain tumors with their proclivity for epiphysis or metaphysis or diaphysis, involvement of the cortex and medullary cavity, both cortical breach if it is there, it just kind of aligns towards, what is seen on imaging and what you can justify that resection on your grossing. The soft tissue involvement, the involvement of the articular surface and the joint space as well, because again, these will all be influencing the resection that they have undertaken. I can't overemphasize again on the size of the tumor, because again, we always say, there's a big gray white tumor described, but the size could be missing. It's very important that we measure the size in 3 dimensions: color, appearance, and consistency, and also the extent of spread. So more than gray white, the world, I always say in the grossing meets, we need to think beyond the gray-white world. You have hemorrhagic areas, you have, cartilaginous areas which look glistening. You can have myxoid areas, you can have necrotic areas. So it's always important that we describe, because it's a communication between the grossing person. It's best if the reporting pathologist is also grossing, but can't happen in all the centers with high volume. But it's very important that there's a communication in terms of the report, grossing, towards what the pathologist is going to report finally. So taking further towards, engrossing after these margins and after these descriptions, which are of very, very paramount importance, we take the main specimen sections, and we have to ensure that we sample enough, the articular surfaces, the margins, and also the biopsy tract, because we have seen in terms of our experience that we haven't seen those tracts contaminated, but we do ensure and take a section from the biopsy tract in that resection if there is tumor. Now, coming towards the challenge of wide excision of the flat bones, which includes ribs, skull, scapula, examine the gross surface features. Flat bones are cut transversely. They are useful for assessing pleural and lateral soft tissue margin and the level of involvement if multiple ribs are excised, particularly in the tumors which could be like chondrosarcomas occurring in the chest wall. So again, you have to take the soft tissue and bony cut margins, preferably inked and radial. So if the tumor is close, you go for a radial margin. If it's far, you go for a shaved margin. That's a very basic, the marginal concept that we follow in oncology specimens. Pelvectomies, it's again important. That's a very major resection which a oncosurgeon undertakes, and it's a huge procedure. So we don't want to mess on that, right? So it's good to know whether they've done a total hemi-pelvectomy, depending upon the type of tumor confines, and they decide that they want to go for a type of hemipelvectomies, which could be type 1, that includes ileum is resected. For type 2, you will see a periacetabular region resected. Type 3 is ischiopubic, and type 4 is sacral. Mostly the 4 will be for tumors like chordomas or chondrosarcomas occurring in the sacrum. That's a very interesting example of a sacrectomy specimen of a 9 centimeter sized tumor. Any thoughts what this could be? It was a poorly differentiated chordoma. Now, bringing this point of these margins, we see a lot of the tumors at our center. Our average size for soft tissues is 8 centimeters, which is very contrasting towards the Western world, because our patients present late and we are a referral cancer center. So you can't always demand for your 1 to 2 centimeter sized tumor, right? And this is what I was trying to mention. You have this chondrosarcoma, very thin fascia, and that's very important in grossing. We ink this surface, reinforce ink. You won't see your 1 centimeter, but still this is at least a marginal resection, if not wide, because you're seeing this nice fascia. Now what happens sometimes is, with these major resections, the person grossing or the residents, again not judging them, they cut and this fascia falls apart, and that could lead to a false positive and freaking out the oncosurgeon. So at the time of grossing itself, it's good to paint this surface and ensure that we take a section from this. This is very typical chondrosarcoma, right? I don't think the pointer should be using this one. So very typical chondrosarcoma. This is the fascia, and you don't see 1 to 2 centimeters, you can't demand in this big specimen, but still it's at least a marginal or if not wide. And you can see this, they've tried to resect as much possible, and this is the entire ink surface. So ensure that you can reinforce the ink on a close margin and sample that tissue importantly. Coming towards amputations and disarticulation, these specimens should be preferably grossed in fresh state after studying the clinical history and plain radiograph for an accurate localization and extent of tumor. Because again, that's not the choice for sarcoma. It's only in situations when there are, like I said, multiple lesions, skip lesions, so you need to justify the specimens also. And if you've missed out on anything, your oncosurgeon will ask you, did you sample those areas? And you don't want to be embarrassed. So the type of the amputations will be below elbow, above elbow, shoulder disarticulation, below knee, above knee, hip disarticulation, and radial amputation of toes, depending upon the location of the tumor, depending upon the type of and the grade of the specimen. So you can see all these amputations, the major resections are based on the type of the grade and also the extent of the tumor. Study the plain radiograph for the site, location, bone and soft tissue involvement, any skip lesion, distance from so sometimes, we have these specimens which are very challenging with their implants, so it can be very difficult. And the resident will say, I can't just cut this, and we don't want them to cut this. So you take support from your onco surgeon who has dealt with that specimen. It's always good to collaborate even in the grossing room. So we ask them that we can process the closest margin if you not the entire. And of course, in amputations, you don't have many margins. You just have one margin. So again, in amputation specimens, they're not expecting you, because they've already done a radical resection. You just have to say one margin, the cut surface. So exact measurements, external appearance, and margins, very often redundant, like I mentioned, because it has gone beyond the plane of resection that they could share. So again, safe. Again, goes to show importantly that we also take sections from the biopsy tract, because that could be one of the reasons that it's contaminated with the tumor, and that led to this major resection. All right. So like I mentioned, there is no rocket science in this. So you gross the specimen just the same way in terms of your cuts, which can be, but again, you have to ensure that your cuts are proper, especially when the pelvectomy specimens. So oblique and sagittal cuts in certain cases, like I said, difficult pelvic sections, detailed external appearance, skip lesions, lymph nodes, don't miss out on any area, especially in these major resections. Actually, overall also you don't miss out. And again, I think not all margins, you take only the radical, the closest margin, not missing out also on the neurovascular cut margin and lymph nodes, if any. So that's another thing when I say that, and it's a bit of a, thought process, that the confidence of the grossing person lies in the type of knife, the size of the knife he or she chooses. And I see sometimes, they have a big specimen, they're using a scalpel. So I would again suggest that, once you've done your resection entire with the bone, so go for the bigger knife, that it will help you to have a smoother surface, and then you can, that en bloc specimen, you can actually take nice further subcuts, rather than just trying to have a big chunk with this scalpel, which will actually cause more sedation than actually a good section in your pathology blocks. So evaluating the pre-operative chemotherapy specimens in Ewing sarcomas and osteosarcomas, it can be, there can be effects which are systematic and local. And it's important to know again, because they might know that there is a size of the tumor on pre-op imaging, which can change because, of the fixation and the effect of the treatment. And we're seeing more of these specimens, because even in soft tissues, they are doing a lot of limb sparing surgeries. And I think it's very, very important that we sample enough tissue, and we sample it in a certain way. So gross examination is performed, as I mentioned. You take the coronal section for exposing the maximum area. 5 millimeter thick slab section is obtained for a local, the longitudinal section with a bone saw, and the entire specimen is sectioned grid-wise and labeled with the various articular surfaces and the margins. So again, why are we doing this entire exercise? Because it's important. In osteosarcomas, there are 4 grades of chemotherapy, and it's known that more than 90%, if you have a response, that's called good responder, and less than 90% is a poor respondent. Ewing sarcoma is a very, very chemosensitive tumor, so we only settle for 99 or 100% more to classify as good response than actually call as something not good or poor response. And now we're seeing this post-anisomatoid giant cell tumors and ECRT specimens, where actually we're not looking at the percentage, because that's another thought process. You're not looking at the percentage response, and it's not a chemotherapy. You're just evaluating how much is a giant cell tumor residually seen. So coming towards a very important point of decalcification, like I said, AZF fixative is good for a small size specimen, about 6 hours, and larger bits or tissue sections can be sampled into slices, and they can be prepared and cut and kept and fixed in 10% buffered formalin plus nitric acid, and then decalcified. Now that's not the very ideal practice, because in the interest of to save time, but if you are anticipating molecular studies, I would really suggest go for saving a section with EDTA, and keep checking the decalcification process, because over decalcification is not only useless for molecular but also for interpretation for the pathologist. So you have to ensure that there's adequate decalcification. It can't be an over or an under decalcified tissues, because in both instances it's difficult and you can't go back to the specimen. So once it's decalcified tissue, you can't really go back. You can wash with water and do your things, but it's going to definitely compromise the morphology. So ensure adequate decalcification, particularly in large resected specimens. Now coming towards more, live photographs than all the textural part that I shared with you, just to bring in the point that what we do, why we do, and how we should do it. You have this post-NSCT treated case of osteosarcoma. You can see it's all white because, I mean, when I see the slide, I now imagine, what for this patient, what our oncologists have done, See, we had years before, when there was such a poor response and osteosarcoma was such a bad disease, in 60s or 70s, and then chemotherapy just changed the, entire aspect of management. You can see this entire tumor is gone and you just see this osteoid. So this is 100% response in osteosarcoma, more than 95% response, which is a good responder for an osteosarcoma. And that's what we do. In my routine practice, we've tried to ensure that we make cartoons as samples, and when I'm seeing a specimen reporting for the post-chemotherapy assessment, I have an access for the gross on my computer, and that's the cartoon that we have ensured for all the dissections, and that's what we do. We sample the entire tumor is, drawn in a cartoon. Of course, we modify it towards the way I'm seeing and radiograph again is very important. So you have a radiograph access, you have a resection specimen, of course, post-chemotherapy, and then you have your carton, then you're seeing your slides, and that's what we do. So you will see, ideally, there should be a 2 centimeter size margin, which is ideal for a bone resection specimen. Now let's look what happened in this particular example. You can see all of this is osteo, and there's residual viable tumor here in one of the sections. So that's not a very perfect 100% response in this example. That's another case of a post-NSCT treated osteosarcoma, because you can see it's not very white now. You have more hemorrhagic necrotic areas, and you're seeing these residual tumor cells. And it can be difficult to actually evaluate. I still find it difficult to evaluate, and I like to do this exercise because it's a whole game changer. You don't actually value the osteoid, you have to look at the sarcoma cells in the post-chemotherapy resection. That's why parosteal osteosarcomas are not candidates for chemotherapy, because they are mostly with layers of osteoid and you don't see high-grade sarcoma cells, in contrast to conventional osteosarcomas, wherein you have to figure out and find out these residual sarcoma cells and again give the response. In this particular example, you can really see on gross, it's very necrotic, hemorrhagic, and led to 60%. This is a poor responder in contrast to the more gray-white area, more whitish area, ivory area in 100%, close to 100% response. That's an example of a Ewing sarcoma initial biopsy, this round cell tumor with MYC2, which is not a very perfect marker. We have now NKX 2.2 and your bells and whistles of EWSR1. But you just see with this marker and this correct perspective, you can see this entire tumor with this dust of nuclei. This is not viable tumor. This is 100% necrosis. In contrast to something like this, you can see really this big fleshy tumor overall with the soft tissue component, destroying the entire bone which we received. It's very unusual to see these specimens at primary resection, because Ewing sarcomas are generally dealt with chemotherapy, especially examples like this. This is what is more beyond your gray-white world, because you can embrace more colors here, and you see this more necrotic hemorrhagic areas. Again, we don't see these specimens more often because the landscape of specimens in GCTs has changed. It was a very old specimen of a giant cell tumor with, even for ABCs we don't see, because they're again treated with sclerotherapy and things like that. So we see more white specimens. So this is very old-time specimen of a giant cell tumor. We still get those cases if they have been botched outside and there's a difficult resection or a recurrence which they have to now handle. So this is a classic GCT. You can see this radiology, the lytic destructive lesion with soft tissue, and your morphology is in place. Now post-denosumab has come in towards how these tumors, they can be dealt better surgically. So it doesn't cure the disease, because the way the time denosumab goes off the patient, the tumor can come back. So it just halts the destructive or the osteoclastogenesis which happens underlying in a giant cell tumor. So this is what you see in post-denosumab treated specimens. You will see a lot of this fibroosseous reaction. And I used to get these cases referred as osteosarcomas, and I used to say, oh, when the surgeon says, my pathologist has called this an osteosarcoma, I'm not thinking this is an osteosarcoma. I said, did you tell your pathologist that you've treated this patient with denosumab? No, so how can they figure out? But now over the time we have seen, like we always find out ways, because there's very prominent fibroosseous proliferation of bone, tons of this bone, and spindle cell proliferation with fibrosis is a spectrum of the post-denosumab treated giant cell tumor of bone. In this particular example, you can still see some areas which are destructive, hemorrhagic, and this is a residual giant cell tumor. Now you can see on imaging, you see this very destructive lesion, very classic example of giant cell tumor of bone. lower end of radius, involving the articular surface, very well-defined lesion, sort of a narrow zone of transition. They can also have a blurred or wide zone. And you can see post-denosumab, the whole lesion has got sclerosed. So what it does is it halts the osteoclastogenesis, and there's a rebound bone formation that leads to lot of this sclerosis. And now they can resect it better. So it doesn't cure the disease, but it makes it surgically more amenable. That's why first examples of 27 cases of denosumab-treated giant cell tumors, just to see what we see on pathology. You can see, these residual giant cells. You can see this very fibro-osseous or fibromyxoid stroma, and most importantly is this woven bone that can mimic like a low-grade osteosarcoma. That's an example of a post-ECRT treated case of chondrosarcoma. Again, you don't see your favorite glistening surfaces in this, but you can see microscopically, and that's what we are looking for, bone permeation. You can see this host bone permeation by this chondrosarcoma, at least grade 2, which is difficult on biopsies. That's a post-ECRT specimen of chondrosarcoma. This is more like a classic chondrosarcoma. We see this glistening surfaces, right, and this little hemorrhagic areas. So it's more than a gray-white. Just to emphasize again, you're seeing more translucent, glistening surfaces in this chondrosarcoma. Another example of this destructive chondrosarcoma, metadiaphyseal, you can see a very glistening tumor with this metadiaphyseal and with this big soft tissue component really destroyed the cortex. You have a very interesting example. I came across this, you see again this very glistening tumor on imaging. It was a big bright T2, and that's what is the light bulb sign for this myxoid tumor, which was around the knee. And radiologically it was perceived and thought to be a chondrosarcoma. You won't believe, on cytology, I did take a chance in this context that this is actually sparing the bone, and it's more, in the synovium that we can imagine with this big soft tissue component. I took a chance to call this as synovial chondromatosis, and it turned out the same way on biopsy, even though they thought that, it still looks, it's big. So big is always not bad. Of course, size is important, but this example is a very rare case of a synovial chondromatosis, and you can see this very glistening tumor excisions. Twice the patient had this resection. They could never clear it well until I would call it chondrosarcoma. It didn't show even a malignant transformation. And what you see here is a very lobular pattern of these cells which are clustered. So malignant transformation in synovial chondromatosis is a rare phenomenon, and you will see this lack of this clustering and more pleomorphism and mitosis, which never happened in this very unusual case of. So again, just goes to show how imaging integrates, maybe rarely on cytology. I'm not prescribing cytology, and then it just mirrors towards what you see on biopsy, this clustering of this synovial chondromatosis. Now that's another example of all tumors which might not respond well. Of course, non-Ewing sarcomas in our center, you call any sarcoma, they treat the same way with the chemotherapy, but angiosarcomas can be really bad tumor. Again, very hemorrhagic necrotic tumor. This is a case with a prosthesis. You can see this, they try to, so if it's I won't say prosthesis, it's actually they're trying to fixation. It's called internal fixation. I'm not the oncologist, oncosurgeon here. So internal fixation for a pathological fracture, and then you can see this very hemorrhagic destructive tumor really filling the entire bone, and they might not respond very well. So we've seen actually success stories with the telangiectatic osteosarcomas, but the angiosarcomas are really bad tumors. That's a very rare example of a tumor in this 46-year-old gentleman who had this lytic destructive lesion. Any thoughts what this could be? You don't see a very wide zone of transition. You see this when you have the resection. So you can imagine that there was some diagnosis that led to this resection. It just mirrors towards what you're seeing on radiograph, right? A very lobulated gray-white tumor. This is not hemorrhage. This is gray-white tumor. This was a leiomyosarcoma intraosseous, and it was positive for caldesmon, desmin, and 25% Ki67. I don't know where the HEs went away. So this was a leiomyosarcoma. That's another example that all sarcomas in bone might not be osteosarcomas. This is a rhabdomyoblastic differentiation, and of late we're seeing these tumors again. They won't respond very well to chemotherapy. We know the TFCP and the EWSR positive tumors in the jaw area, which are taking up a lot of attention because they are very bad tumors. They can look very banal, but they are bad. We've seen also in extremity locations, and this was a tumor in the pelvis. You can see this hemipelvectomy that led to this 15.5 centimeter size tumor post-chemotherapy, very poor response, 66%. And this was actually a rhabdomyosarcomatous transformation or sarcoma. So now you will see in the 6th edition of, so rhabdomyosarcomas are more well classified with the fusions, including EWSR, TFCP2, particularly in the head neck location. that was a very unusual case that I came across in this ECRT specimen that they took. Prior to that was a diagnosis on cytology is Ewing sarcoma. And on biopsy, we went back to the cytology and classified that as an MNTI, which is the fourth case in the world literature of progonoma. And you can see it's not gray-white, it's not hemorrhagic, it's a black surface. We are just trying to share with you that you do see a range of appearances in this very unusual case of a progonoma that we saw in this limb. I have to thank our oncosurgeon for sharing this photograph. Dr. Ashish was a very well-known oncosurgeon for this case of progonoma that was finally operated upon. So again, once we've formulated a diagnosis of sarcoma, and osteosarcoma can have its several phases, I'm sure Dr. Shantveer will reflect on this presentation, and we need to grade the sarcomas. How we grade, just like in the differentiation score that we have in soft tissues, similarly we follow how much it resembles to the normal native structure. So if you have a tumor which is tons of osteoid, so paraosteal is a classic example of a grade 1 sarcoma. Periosteal will have more chondroplastic, so it can go towards grade 2. Then you have the clear cell chondrosarcomas are low grade, but they can be straddling between 1 to 2 grade. And conventional osteosarcomas, juxtacortical high grade, will go for grade 3. They are high grade classified. In bone and soft tissue, we generally club 2 and 3 together. I think in genitourinary, they have a different way. But in bone and soft tissue, grade 2, and so grade 2 can't be a convenient diagnosis because it's going to be treated as high grade. So make sure that you're not using it as a borderline. And in bone, we have defined tumors. So you don't have a paraosteal osteosarcoma, which is a high grade. It's a low grade, unless there is a high grade transformation that happens and it escalates to high grade and the chemotherapy sets in. So that's the staging of the, we not only identify the tumor, it automatically gets graded with the type of, tumor that we are furnishing. You won't have a rhabdomyosarcoma, which is low grade. You won't have a telangiectatic osteosarcoma, which is low grade. By terms of their type, they are high grade tumors. And then we further stage it as a part of this AJCC, wherein I think, again, size is important here. So you can read more about this AJCC classification and what it finally crystallizes towards your report. And we've had this, I don't too much harp on this synoptic reporting system, which is a new fad, but I think it's important that we furnish the important details. We don't become very verbose, or there's a lot of verbatim in our reporting, but all the clinical details. And if I think you think from the oncologist's perspective, you start thinking like that, you will know what all details you want to put. Okay, I don't shy away from using the word spindle cell or round cell morphology with a kind of joke in some oncology conference, because I'm trying to bring the point of, hey, I'm not seeing an osteosarcoma. It's a rare case of perhaps a fusion-driven or a rhabdomyosarcoma, but I don't make all the time of a classic osteosarcoma description as pleomorphic cells with a lot of osteoid, lacy osteoid, or so it's a clear-cut osteosarcoma. I will just go for a one-liner. So I'm not between this one-liner and a lot of detailing. I use what is adequate. And I think if you think judiciously from the clinical perspective, we know how much our report should include the description and how much, what shall I say, the content has to be important, how it's reflecting. And that's my everyday challenge, trust me. Not only the diagnosis, but sitting with my residents, trying to explain that, as there is a song, I think Lata Mangeshkar said that my voice is my identity, Kami Meri Pehchan. So I think our report is our reflection. We might embark on a lot of researches, projects and everything. Towards the end of the day, that's the one patient which we have to, whom, I won't say the word which again, I'm very sensitive, we don't use the word it and which patients, whom we are addressing. And if you think from that perspective, what components come in our report, how we articulate our report, which is scientifically correct and clinically viable, is the synoptic in my understanding. I am not into, the fad of the synoptics which is taking. So I have to share with you our thought process that we again collaborated as a group in the country of all these wonderful people. I've been associated in working towards having these reporting guidelines, and that was invited for us by Dr. Pai, Dr. Sanjay Pai, who was the former editor of IJC, and we put these reporting guidelines. It's again not a typecast in iron. It can, so you have this lot of literature, but we try to reflect what is possible in our country, and it's always, we are evolving. And finally, I wind up my talk encouraging all the enthusiasts in bone and soft tissue to join us association and bring more value to it. And thank you so much for your attention. I'll be happy to take any questions. Yeah, so that prescription I can email you, because I think that's a protocol that our team, the team of our technicians worked on for a while, and I'll be happy to email you, because I think as a part of our SOP, we don't actually reflect, but I can email you on an individual basis. That was a Hammersmith protocol by I think, Dr. Naresh, who was at TMH, and I think that led further towards having this AZF fixation, but the exact proportions I can email you. Yeah, yeah.
Sir,
Yes.
okay. Sir, we receive many resection specimens of bone tumors, and I just want to ask one thing. Whenever we give the margins, distances, then as per the Kawasaki guidelines, radiation oncologists always say that for fascia you have to measure it as 2 centimeter and skeletal muscle as 3 centimeter. That is adequate margins. So are they eligible for our reporting purpose?
I didn't get your question. Means,
If fascia is present on the margin, then can we take it as a 2 centimeter margin, equivalent to 2 centimeter?
see, you will give a margin towards what you are seeing. Okay, because if the resection is what you have got to yourself has 2 centimeters, it's ideal from the oncologist's perspective. But if you're seeing 1 centimeter, you will say it's a 1 centimeter sized tumor. If you're seeing a 0.5 centimeter, say it's a 0.5 centimeter size. So eligibility is not what we are getting, because I think we are furnishing, if I'm getting correctly what you're trying to ask me, is we furnish the margins grossly and microscopically what we are seeing. Okay, they might think that they have cleared it well, but the tumor confines, it's maybe a very, I can imagine a chondrosarcoma can be, involving the medullary cavity, although it can be seen very well on imaging, they can see the confines. But still, it could be certain tumors could be very extensive, and they felt that there was a good margin, although I have to say on record that with our imaging and clinical acumen, we don't do frozens for margins anymore. Okay, and 2 centimeters ideally in most cases, but for difficult resections, most surgeries, they might take less. So you have to mention what you are seeing. I don't get this point of
Sir,
eligibility.
if the margin is covered by fascia only and it is just nearby,
Yeah.
but they take it as equivalent to 2 centimeter, that is adequate margin for the
So-
radiation oncologist.
So
that
I
is
get
what-
your point of the soft tissues, and that's more like a Kawaguchi's concept of qualitative
Kawaguchi's,
margins,
yes.
right? So that's more like for the soft tissues, understandably, because you have a big specimen, you can't demand your 1 centimeter size. So even a thick buck of fascia around, but you can't call it a 2 centimeters in your report because you're not seeing it. It is a qualitative margin that is perhaps wide or marginal. But I can't call it 2 centimeters unless I see 2 centimeters.
Can I
But
get it, can I call it as adequate margin?
you will furnish that it's a free margin. The adequate margin will be who will judge the adequate margin will be treating oncosurgeon. So for them, they know. They are just expecting that, are you seeing tumor in that fascia? Is the tumor involving that fascia, or are you seeing the tumor on the surface? If the fascia that you have sampled is free of tumor, and there is no tumor obviously on the surface, they are taking it as a wide excision. It's equivalent. So it's called qualitative margin. Right? So we're not calling it as a quantitative 2 or 1 centimeter size. It's a qualitative margin. That's a Kawaguchi's concept. And there's a lot of discussion about these tumors. So as aspects, and I learned over the period of time that we can't demand that 1 centimeter because there could be a closed nerve or a vessel and a big tumor. They can't go further. So that's why I said you reinforce ink on those surfaces and make sure that you have processed. So if you see, obviously if you're seeing this fascia which is free grossly, but if the tumor is infiltrating into that fascia, but not on the surface, it's a marginal resection. So it's a marginal excision, but if it's free, it is equational to wide excision, but it's not 2 centimeters because 2 centimeter means you're actually measuring 2 centimeters. But I understand your point. It's a free margin, is it? So it clears you? Yeah. Any other question? Yeah.
Sir, I wanted to know, like, if you are taking a radial bony margin and if the inked bony surface is coming free, it is like free of tumor,
Right.
but the proximal marrow spaces are showing tumor. So will we consider it as positive?
So you mean to say at the resection surface,
Yeah.
in the marrow, the tumor is there?
So
But
at
not
the
in the
resection surface, if we are having the bony trabeculae and the outer part of which is inked, that is free. But
Right.
the immediately proximal marrow space is showing tumor. Then will we consider it as positive?
No, but what is this section? Is this the shave margin? That
Radial,
you're
sir. I'm asking about radial.
So radial margin, if you're seeing the, see, basics of a radial margin is if the tumor is not seen at the ink surface, it's free.
Okay.
Generally, we don't have radial margins in bone because,
Yes,
you know,
sir.
they're able to sample
Yes,
and
sir.
they don't shy away from taking, you know, they can really go further. But I can imagine rare situations that they actually could be very close.
Yes, sir.
So in bone, actually, that's more in soft tissues.
Yes, sir.
And I think again, so it's a very uncommon situation, but
Yes,
I can
sir.
understand it can happen because
Yes,
nothing
sir.
is impossible in science. So if your ink surface is free, it's a free margin in a radial.
So
That's the
like
basic
if it is
philosophy.
involving the marrow spaces,
So you say-
potentially it can spread.
So you say that it is involving the marrow,
Yes.
but you know the
inked surface is
yeah,
free.
so that can happen with round cell tumors, but again, those are not generally the cases because they are pre-treated specimens. I'm trying to see, I haven't come across a situation like
Okay,
this.
sir. Yes.
Have you seen, Shantvi, something like that? That you have a tumor with she's saying marrow is positive, it's a radial margin and bone, and marrow is positive. I haven't seen something like that very often. Yeah. But I can imagine that can happen. So you describe, see, sometimes I agree, it can be difficult. So you can articulate, okay, that I'm seeing that the ink surface is free, but the tumor is infiltrating the marrow. And again, it's not one thing that works for a patient, it's the entire context of radiology, of the clinical, and sometimes, you know, you're fretting over a margin. Actually, they have taken a decision with the patient.
Yes.
The other part of this is that we don't prescribe things of management on our report. So that's what I've learned over the period of time. I just forgot to mention that we don't say spindle cell tumor, kindly do the excision. That's not our forte. So we don't, especially I've seen for nodular fasciitis, so spindle cell tumor, low grade, you know, do the excisions. So we don't, we can say it's of a low malignant potential. You can't classify, spell out your limitation. Take another consultation. It's not, you know, talk to the surgeon or the who's operated. If you're really having a difficult time evaluating a margin, I always tell the residents, we don't work in isolation. It's always a collaboration. We can call up the treating oncosurgeon. Sometimes they want a certain margin for a conservative pelvectomy that they have done, and we are just looking at the tumor only. They might not want that, you know, because they've removed the tumor. So again, communication is very important. With the treating surgeon as a part of your report, you can articulate and discuss.
Thank you, sir.
Yeah. Any other questions? Thank you so much. Very good.
Thank you, sir, for sharing your expertise. Now, it's my pleasure to invite Dr. Naresh Rai, sir, currently Professor and Head, Department of Pathology, JNU Medical College, Jaipur. Sir is the former Senior Professor and Head at GMC Kota, former President, Indian Academy of Cytologists, and also the President of Rajasthan chapter of IAPM and Chairperson for today's CME. Sir will be delivering his talk on a very interesting topic, cytology of small round cell tumors.
Good morning to everyone. I begin with the paying homage to Queen of Histopathology, Dr. Anita Borges. This is a photograph in 99 when she came to Kota. Now, concept of small blue round cell tumor, because most of these tumors are undifferentiated in HNE section, they have very scanty cytoplasm, there is very high NC ratio and hyperchromatic, so they look like small blue because their size is just double the RBC, so they are called small blue round cells tumor. Mostly they are primitive blast-like. These cells are arranged in nest sheets and masses and composed of relatively monotonous round to oval cells. But most of these tumors will show some kind of differentiation, and a small percentage of case they will not show any differentiation. They will require ancillary technique, and up to 15 to 20% of cases, in spite of doing wide panel of IHC also, diagnosis may not be arrived. And I remember one case I sent to Dr. Anita, which was after doing about 10 to 12 IHC, she reported as undifferentiated small round cell tumor. Well, most of these tumors, round cell tumors, are occurring in the childhood, and many of them are related with the bone. So, in adults, FNAC is a well-established procedure, but experience in use of FNAC in is limited because most of the tumors just appear as small blue round cell tumor. But they are actually a heterogeneous group of tumors and seen in children as well as young adults, and some tumors may occur in adults also. Akhtar et al., Vekli et al., and Rajvanshi et al. They were the first one to describe the FNAC of small blue round cell tumor. And later on, random publication, and then even some books on FNAC of small blue round cell tumor. Though morphological features of most SBRCTs are defined, Mohammad Akhtar has defined and Layfield has defined very well in 1990s and 80s. The confident diagnosis can be given correlating with clinico-radiological features, but lack of differentiation in many make ancillary techniques essential. Some of the initial series was reported by Silverman et al. In 1999-91 with a very good histological correlation. Then Akhtar et al. Used electron microscopy and ancillary technique for half of the case, initial half of their cases. Later on, in latter half, as experience increased, it was possible to make a confident diagnosis on FNAC alone. Later, use of ICC and EM could be limited to a small proportion of cases where FNAC was equivocal or clinical presentation was unusual. So, with experience and with correlating with clinical, you can make a diagnosis, and when you have support of ancillary technique, then your confidence grows. Because many tumors have the same basic microscopic appearance, a definitive diagnosis relies on a combination of method, clinical features, IHC, molecular studies. A multidisciplinary approach has to be taken, taking into account the age, tumor size, mobility, anatomical location of the mass, and clinical presentation, that is rapid versus slow growth. Then radiological data, USG, CT, MRI, PET, CT to delineate exact site and extent. Then cytological interpretation using low and high power microscopy, recognizing the morphological patterns. Then histological correlation, and of course use of ancillary techniques. For cytological interpretation, you have to first see the size of the cells, whether they are small, large, or spindle cells. Then arrangement of cells, dispersed or cohesive. Uniformity of cells, monotonous or heterogeneous. Then pattern, dispersed, clusters, acini, alveoli, rosettes, tubules, nuclear molding. Most of the round cell tumors are showing dispersed pattern. Then cytoplasmic features, vacuoles, granules, inclusions. Then matrix, background features, lymphoglandular bodies, neuropil, collagenous, metachromatic, myxoid stroma, capillaries, necrosis, apoptosis. Now, why do we need a precise diagnosis? I think ask a medical oncologist. When we give a diagnosis of malignant small round cell tumor, how will respond? So, in spite of overlapping features of SBRTCs typically have diverse prognostic outcomes, thus warranting different clinical management. So, recent advances in molecular and cytogenetic techniques have identified a number of novel molecular alterations contributing to the diversity of these lesions. This state-of-art knowledge has enhanced our understanding of these diseases and guide the specific management. The exact diagnosis in such case is extremely important, as most of the small round cell tumors, although aggressive, are curable with their tailored chemotherapy. Various RCDs have their specific chemotherapy protocols. Now, the tumors are mostly seen in the children and adolescent, but they can also be seen in adults. In children and adolescent, many of the tumors are non-Hodgkin's lymphomas, Burkitt, ALCL, lymphoblastic lymphoma, leukemia infiltrates, Hodgkin's lymphoma rarely, granulocytic sarcoma, neuroblastoma, Ewing sarcoma or PNET. Now they are called as Ewing sarcoma group tumors. Embryonal rhabdomyosarcoma, Wilms tumor, retinoblastoma, desmoplastic small round cell tumor, poorly differentiated synovial sarcoma, small cell variant, small cell osteosarcoma, undifferentiated small cell hepatoblastoma, and LCH. In adults, mesenchymal chondrosarcoma, hemangioparasitoma, in non-Hodgkin's lymphoma, large cell lymphomas, DLBCL, ALCL, mantle cell lymphoma, small lymphocytic lymphoma or CLL, plasmacytic plasmablastic lymphoma, Hodgkin's lymphoma, small cell osteosarcoma, small cell or oat cell carcinoma, Merkel cell tumor, neuroendocrine tumors, olfactory neuroblastoma, alveolar rhabdomyosarcoma, malignant melanoma, small cell variant. So these are my statistics. I'll skip these statistics. These are from work from 1986 to 2000. So coming to small cell tumors, lymphoma, leukemia. What is the aim of FNAC in lymphoma? Because many people do not prefer FNAC in lymphoma, but I do not prefer even the core biopsy in lymphoma. In lymphoma, I like to have a whole lymph node, excision biopsy. So aim of FNAC in lymphoma, even in this area, is for initial evaluation of any lymphadenopathy, for providing a non-architectural cytological diagnosis and subtyping, and guide clinician for further evaluation and biopsy. For differentiation of lymphoma and non-lymphomatous SRBCT, this is very easy if you are using a air-dried Giemsa stain smear. Diagnosis of recurrent disease, non-surgical staging of disease, non-surgical diagnosis of few high-grade lymphoma when poor clinical state do not allow surgery, and providing material for ancillary technique, because the FNAC material is a very high quality for ancillary techniques. For interpreting lymphoma, you just have to see the population of the on the left side. Indicator on side. This is a heterogeneous population. This is a monotonous population, small cell. This is a polymorphic population with lot of giant cells. Within non-Hodgkin's lymphoma, this is a small cell population, monotonous. This is an intermediate cell population, intermediate grade lymphoma, and this is a high grade lymphoma. 8th edition of Anderson's pathology, the edition which was prevalent when we did MD in 1980s, described the and shows the photograph of imprint cytology of all the Rappaport subtypes. This is a 19-year male with mediastinal mass and pleural effusion. In both, these cells were seen. Non-Hodgkin's lymphoma, lymphoblastic, that is precursor B cell. ALL-L1 can be seen in blood film. It is frequently subleukemic, and if it has a lymph node, FNAC of lymph node will find. This is non-Hodgkin's lymphoma, lymphoblastic, that is ALL. And very often you will see lymphadenopathy in CML, which is abnormal, because lymph node in CML will either have lymphoblastic crisis of CML or myeloblastic crisis of CML. This is 8-year girl with lump abdomen. This is my first case of Burkitt lymphoma diagnosed in cytology. You can see the tingible body macrophages. This was in from 11-year female child with swelling in labia majora. This is a 3-year female child with retroperitoneal, extensive retroperitoneal lymphadenopathies. The tingible body macrophages gives a starry sky appearance in histological section that indicate a high cell turnover. Burkitt lymphoma is fastest growing human tumor, completes cell cycle in 1 to 2 days, and Ki67 proliferation index is approaching 100%. This is 3-year female child with FNAC retroperitoneal mass, the same case, and this is the typical translocation you will find in Burkitt lymphoma. So Das et al. Has reported the description of FNAC in lymphomas, and they have reported about 40 cases of lymphoma which were categorized as Burkitt type, constituting about 14.3%. And as per their study, FNA cytology was found to be quite reliable for arriving at a diagnosis of Burkitt type lymphoma. More than 50% of the cases were managed without resort to subsequent surgical biopsy. Exploratory laparotomy was avoided in 69% of the cases having abdominal tumors, because in India, you will find mostly abdominal presentation. And for diagnosis, if you had to do exploratory laparotomy, whereas in FNAC, the diagnosis of Burkitt lymphoma is very good, whether you use oil red O or not. But in histopathological studies, the 3 studies which I found, the percentage of Burkitt lymphoma reported was lower and comparable to China and USA. This is a painting by Vincent Willem van Gogh, Starry Night. Coming to non-lymphomatous small blue round cell tumors, particularly in children. Rhabdomyosarcoma shows cellular smear with varying degree of intercellular cohesion. Most of this description is from Akhtar et al. There are 3 types of cells based on the degree of apparent myogenic differentiation. The type 1 or early rhabdomyoblast is a blast-like primitive cell which have very little differentiation and very less cytoplasm. Then intermediate rhabdomyoblast, they are relatively abundant, pale staining, variably vacuolated cytoplasm and 1 or more irregular nucleus and occasional nucleolus. Late rhabdomyoblast, which include strep cells also, they have abundant grayish blue opaque cytoplasm. Cells vary from round to markedly elongated. Some of these cells have localized inclusion like grayish blue areas within the cytoplasm. Some of the intermediate and late rhabdomyoblasts are extremely large with markedly pleomorphic nuclei. Embryonal rhabdomyoblasts have frequent intermediate and late rhabdomyoblast. Alveolar rhabdomyosarcoma and monomorphic round cell rhabdomyosarcoma shows large number of early rhabdomyoblastic cells with variable scattering of intermediate cells and rare rhabdomyoblasts. This is mostly showing the type 1 rhabdomyoblast and some cells showing inclusion. This is showing one strep cell with multinucleated strep cell. Rest of them are type 1 or type 2, early or intermediate rhabdomyoblast. This is rhabdomyosarcoma showing abundant early rhabdoblast and late rhabdoblast showing glycogen and rhabdoid inclusion. This is pass stain. The late rhabdomyoblast shows glycogen. These are pictures showing multiple strep cells mixed with intermediate rhabdomyoblasts. Strep cells and tadpole cells. This is the strep cell. And you can see the glycogen vacuole very similar to Ewing sarcoma, but less in number, less in amount, and less in frequency. Coming to Ewing sarcoma oblique PNET, previously we used to differentiate between Ewing sarcoma and PNET. Cytology of Ewing sarcoma shows it was historically classified as Ewing sarcoma, atypical Ewing sarcoma, and PNET. The classical Ewing sarcoma shows high cellularity with uniform single mononucleated cells and tight clusters of variable size. They have scanty cytoplasm with punched out glycogen vacuoles and small blunt cytoplasmic tags. round nuclei with fine even chromatin and inconspicuous nucleoli. Then there is distribution of large light cells and small dark cells. The glycogen vacuoles are found in large light cells. Then occasional rosettes may also be seen in Ewing sarcoma, but PNET we used to differentiate with Ewing sarcoma with having irregular nuclei with coarser chromatin, less or absent glycogen, and more amount of rosettes with even neuropils. Atypical Ewing sarcoma had intermediate features. Differentiation between Ewing sarcoma and PNET was considered important in those times as PNET had poor prognosis. However, the difference is no more considered important as both considered member of same family having similar molecular alterations and have similar treatment strategy. This is my statistics of 14 year, 86 to 2000. This is by again first patient of Ewing sarcoma, Gyarsi. I still remember her name, 11-year female child with mandibular, swelling mandibular, and clinically they thought it is Burkitt's lymphoma, but African type presentation we do not get in India. And FNAC, I gave lot of hours to this because I was very naive in cytology and early, this was most earliest case, and it was Ewing sarcoma. The PS stain shows abundant intracytoplasmic glycogen. This is another case, you can see some rosette formation. Punched out cytoplasmic vacuoles. This one is showing light and dark cells, punched out glycogen vacuoles, and you can appreciate salt and pepper chromatin as well as you can see some rosettes. This is showing dark and light cells, 11-year male tumor from fibula and punched out vacuoles. Pass stain will definitely shows positivity and correlate with the punched out vacuoles in Giemsa stain. This 18-year female had left costal margin tumor and radiology showed that it was not involving the rib, it was in the soft tissue only. It was not involving lung, pleura, pericardium or even the superficial tissues or breast. And you can see the round cell tumor with punched out vacuoles. There is some neuropil also. This tumor was first described by F.B. Eskin, Frederick Eskin and Joan Rosaine in 1979 and named after his name, Eskin tumor. It is now part of the Ewing sarcoma group of tumors. Now, how you can diagnose, identify glycogen in a air-dried smear in a Diftwick? Glycogen can be easily identified in air-dried smear stained by Diftwick, MGG or Giemsa, etc. as punched out vacuoles. They are different from the lipid vacuoles of Burkitt lymphoma. Akhtar et al. Has done a comparison of Diftwick stain smears and electron microscopy and then found the exact correlation between the punched out vacuoles found in the Giemsa stain smear, air-dried Giemsa stain smear and electron microscopy, even the amount of glycogen. We have also correlated with PS stain in many of the tumors beside Ewing sarcoma. This is the first case reported as PNET and had a very long discussion with the, my senior, my professor, and when I showed that PNET is very well described in the Anderson that time, it is early 1990s, 95, 96. So this was a arm swelling and it had less amount of glycogen and more rosettes. Cell block was also made and pass positivity, not as the Ewing sarcoma cases. This was a recurrent case and it was very well worked out in Tata Memorial Hospital, and in Kota he was coming for FNAC, and I had done multiple FNACs of his multiple recurrences. Each time the tumor was re-excised and coming back, and by seeing his multiple recurrence and the grit of that patient, I recalled a character Khitin Babu in one of the story of Sachidanand Vatsayan Agge, titled Khitin Babu, who had multiple amputation due to accidents or otherwise and ultimately left with only trunk. Even that was also destroyed, and still he used to say, ये जरूरी नहीं था, it was not needed, ये बहुत जरूरी नहीं था life के लिए, and everything. This was again a case which I described in Ernest Fernandes' slide seminar, also Dr. Bharat might remember. This was a 45-year male. USG showed cystic mass lower pole of left kidney with solid periphery. IVP showed left renal mass. USG guiding FNACs were done targeting the solid areas. And it was reported as perirenal PNAD, a final diagnosis, but perirenal. In cytology, I reported it as PNET. There were light and dark cells, salt and pepper chromatin in light cells. And you see a very complex rosette formation with lot of intercellular cytoplasmic fibrils. Rosettes were too many. Tumor was operated, I mean nephrectomy was done, and in nephrectomy also I reported same, and then ISC was done, MIG2 was positive. It was reported as perirenal PNET, because it was not involving the renal parenchyma, it was in the capsule of the kidney. This is the typical translocation found in ES and PNET. I'll not go into this, as Dr. Bharat will tell you about that Ewing sarcoma and many related similar tumors can be defined molecularly, and they have different treatment protocols. Coming to neuroblastoma, the cytology shows small cells with high NC ratio, fine and coarsely granular chromatin without prominent nucleoli, and this chromatin has been described as salt and pepper chromatin. There are two types of cells, small cells 7 micron, round, dense nuclei with scanty cytoplasm. Large cells 10 micron, round to slightly irregular, somewhat vesicular nuclei, more abundant cytoplasm, and they have wispy cytoplasmic unipolar tags. They have neuropils, homorized rosette or pseudo-rosettes. You can see rosettes. This is FNAC from liver. Another case showing salt and pepper chromatin, lot of neuropil in the background. Again rosettes, neuropils. In a 2-year child with abnormal tumor, I saw that it is there because there were neuropils. It was small round cell tumor, but there were many components of larger cells, and it was diagnosed as large cell anaplastic neuroblastoma or neuroblastoma of high grade neuroblastoma, and you can see these cells. A few more cases like this were later on diagnosed. The 7-year female child. Usually they are elder than the typical neuroblastoma cases. If you recall some lymphoma by seeing these cells, you can see this unipolar cytoplasmic process, long process. Lot of neuropils. Normally these large cell anaplastic lymphoma do not have much neuropil, but fortunately I was fortunate in most of these cases that I found adequate amount of neuropil. There is a report, anaplastic large cell neuroblastoma and lymphoma are cytological twins, because they both large cell anaplastic lymphoma and large cell anaplastic neuroblastoma shows similar cytological pictures. You can see these large embryo-like cells and see how fine cytoplasmic tags. This is a recent case, nephrectomy specimen, which was clinically they thought it is Wilms tumor, but it turned out to be neuroblastoma. And this is a typical fish in complication. And rose window, which is very useful for those of us who are reporting neurocytopathology. For primary resectable Wilms tumor, FNAC is sometimes considered a relative contraindication due to the risk of tumor seeding a capsule rupture. However, for advanced tumor, a needle biopsy followed by chemotherapy is sometimes preferred. FNAC is useful even for unilateral tumors sometimes, which when we want to avoid inadequate preoperative chemotherapy in case of a non-Wilms renal tumor. These cytology slides are from squash smear taken from the surface of a Wilms tumor. They show blastomal cells and tubules. This is mesenchymal component, tubules, blastomal cells and tubules. Coming to retinoblastoma, they are closely packed cells, small uniform cells, rosettes and lumina, and one very important feature is tumor cell phagocytosis, though it's not a specific feature of this tumor. It is found in many of the small round cell tumors. This is metastatic retinoblastoma in a cervical lymph node. They commonly metastasize to CSF also, and many times you have to examine CSF for their metastasis. This is showing small undifferentiated cells, and this is something big like rosettes or floret, and many mitosis. Many rosettes, many mitosis, and tumor cell phagocytosis. Intraabdominal desmoplastic small round cell tumor of childhood I have never seen, I have never reported, and their bone metastases are very rare. But one thing very particular about this tumor is that it is immunohistochemically an infidel tumor because it presents as a multi-phenotypic pattern or multi-lineage differentiation, co-expressing markers of several different cell lineages and making it difficult to classify by immunohistochemistry alone, by simultaneously expressing markers for multiple, often conflicting cell lineages. So it can be positive for EMA, desmin, NSC, even cytokeratin, vimentin, and CD99, but usually it is negative for MSA and SMA. So, should we venture in classifying or subtyping the malignant small round cell tumor? Layfield et al. In 1999 did a logistic analysis of 59 cases of small blue round cell tumor and indicated following cytological features to be diagnostic of a specific entity. For Ewing sarcoma, it is scanty cytoplasma and cytoplasmic vacuoles, punched out cytoplasmic vacuoles. For rhabdomyosarcoma, it is strap cells or tadpole cells. For neuroblastoma, it is rosette. For Wilms tumor, it is tubules. And for lymphomas, it is lymphoglandular bodies. And this is one feature in air-dried Giemsa stain smear, which can easily differentiate at the outset, at the primary level, whether it is a lymphomatous small round cell tumor or non-lymphomatous small round cell tumor. Langerhans cell histiocytosis, though not a typical small round cell tumor, but it is a mixture of atypical Langerhans cells which have grooved or folded nuclei and abundant pale cytoplasma, along with numerous eosinophils, lymphocytes, and multinucleated Jann cells in a highly cellular smear. My first case of LCH I diagnosed in a submandibular lymph node, and he had nothing elsewhere. And you can see, even in the Giemsa stain smear, you can appreciate the grooves. And there is a mixture of lymphocytes, and eosinophil granules many times fades away, but there are eosinophils. Here are mitosis. Again, grooves are very clear. There is mitosis also, eosinophils, lymphocytes, some multinucleated cells. Nuclear grooves are better observed in a wet fixed H&D stain smear. These are various slides showing a variable mixture of Langerhans cells with other inflammatory cells and even Jandt cells. And here you can see, you can make out grooves in many of these. This is wet fixed H&D stain smear. Again, few slides of same LCH. Here you can appreciate eosinophils very well. This is Dr. Mohammad Akhtar, whose reference you will find in every chapter of oral. Now, how do we correlate pediatric neoplasm with histology? This is belong to my study of 1986 to 2000. I will skip this. Directly coming to focusing on the cytopathology or cytology only. Adult SBRCT. CLL is the one of the most common. Small lymphocytic lymphoma or CLL in bone marrow is one of the most common tumor recognized in PBF only. There is fair admixture of pro-lymphocytes. In FNA smear also you will find many pro-lymphocytes. They are arising from the proliferation center, small proliferation centers in the lymph node. Waldenstrom macroglobulinemia always diagnosed in bone marrow aspiration. They have lymphoplasmacytoid cells and mast cells. Mantle cell lymphoma once thought to be a low-grade lymphoma, but it's an aggressive one. And you can see the cells are intermediate. There is coarse stippling in the chromatin, and you can find some grooving or nuclear cleaves. One of the very important feature which is observed in cytology also, this is finding of non-tingible body macrophages or pink histiocytes. This is a classical pink histiocyte in mantle cell lymphoma. Mantle cell lymphoma can also sometimes spill to blood, in blood film. You can see atypical cells in PBF. Centroblastic lymphoma, all of these are now included in diffuse large B-cell lymphoma, but they have certain morphology. Diffuse large cell centrocytic centroblastic lymphoma, even this can also spill to blood film. You can see the peripheral nucleoli as well as the cleaving. The centroblast have multiple small peripheral nucleoli and centrocyte have a nuclear cleaving. This is one case of immunoblastic lymphoma. The large cell anaplastic lymphoma is another very important tumor found in children as well as in adults. And you can see these cells. By the background lymphoglobular bodies, you can say that it's a lymphoid tumor. And these cells, hallmark cells, they are called as hallmark cells because they are found in all subtypes of ALCL, even ALK positive and ALK negative tumors. There is Dunnert cells. Though Dunnert cell is a histological appearance, but even in cytology you can find sometimes. Embryo cell. Now these two cases I am describing, giving the importance of ability of cytology when you are using air-dried MGG smear to differentiate between lymphomatous SBRCT and non-lymphomatous SBRCT. This was a 17-year male sent by orthopedician for FNAC of soft tissue swelling right leg. X-ray had no bony involvement, and what I found are these cells. And you know what are these? Lymphoglandular bodies. Have you ever seen soft tissue lymphoma, primary soft tissue lymphoma? As it's extremely uncommon, so I advise USG of, this is in late 1990s, USG of abdomen and X-ray chest for any lymphadenopathy there. Radiologist did not found anything there, but he interrogated the patient and found this tumor, testicular tumor. And my fellow pathologist said, "Arey Naresh, ये तो seminoma है, तुमने lymphoma कर दिया." Then I went there and did FNAC from the testicular tumor also. And you see the similar cytology with very aggressive tumor, lot of mitosis, atypical mitosis, multinucleated cells. Background is studied with lymphoglandular bodies. So it was a non-Hodgkin's lymphoma, high-grade non-Hodgkin's lymphoma testis presenting as soft tissue swelling leg. This is showing cell-in-cell appearance. It's not a very specific appearance of any one tumor. And occludotomy was done, and in histopathology it was reported as high-grade non-Hodgkin's lymphoma of testis. This is another recent case, 64-year female with SOL occipital area. We received tissue for frozen. Air-dried MGD stain smears was poorly stained, so we did not saw this. We saw wet fixed HND smear and the frozen section. And as we had to report for within 20 minutes, we cannot wait for re-staining of Giemsa stain smear. We reported it as small round cell, malignant small round cell tumor. Then when the section came, this was the tumor. We were finding difficulty in reporting this tumor till we found this very beautiful perivascular cuffing. And then I asked the technician to re-stain that smear which was poorly stained that day. He re-stained it, and we found this large lymphoid cells with prominent lymphoglandular bodies. Don't confuse them with red cells. These are red cells, but these are lymphoglandular bodies. Lymphoglandular bodies only tell you that the aspirate is from a organized lymphoid tissue, whether it is a reactive lymph node, normal lymph node, or a lymphoid, lymphoma, wherever it is, whatever the location. And then we had IHC for this tumor. CD20 was beautifully positive, and even these cells which were cuffing the vessel. MUM1 was intensely positive. Was a primary CNS lymphoma. The perivascular cuffing, because we have not seen, I have never seen previously any primary CNS lymphoma. The perivascular cuffing is a typical feature. CD20 and MUM1 was intensely positive. BCL6 was positive. ALK focally positive. CD138 focally positive. GFAP, CD10, CD30, PEN, CK, AFP, and cytophysin were negative. So it was classified as primary CNS lymphoma, DLBCL, non-GCB type. Dr. Bharat will kind attention, 2012, when I had moderated the one-day CME on small round cell tumor, pediatric round cell tumor, and Dr. Bharat was part, and I know him since then only, and it's very pleasure to know him. Then even lymph node FNAC can give you plasmablastic or plasmacytic. I mean, this is one case where I did FNAC of lymph node, and it turned out to be plasmacytoma, and I asked him ki kuch aur pehle hua kya? Later on his son showed me bone marrow report of plasmacytoma, multiple myeloma. And PBF will have these Rayleigh formation. Bone marrow will have these beautiful, typical, classical plasma cells, but many times when a round cell presentation, plasmablast, it is difficult to identify these cells. Hodgkin disease, as in bone, they are very rarely seen. Just I'll pass on these cells. Nodular lymphocytic predominance. pituitary cell cluster can be found in Hodgkin disease cases, particularly in the mixed cellularity cases. These are various types of Reed-Sternberg cells. Now, lymphoma in bone can appear as a primary as well as a secondary tumor. So, lymphoma spreading to bone, the most common type of lymphoma to involve bone are aggressive non-Hodgkin's lymphoma, particularly DLBCL. It is important to differentiate whether it is primary or secondary. As far as prognosis is concerned, primary bone lymphoma, especially DLBCL, is considered to have a relatively better prognosis than to secondary bone involvement. Secondary lymphoma may have non-Hodgkin's lymphoma as well as Hodgkin's lymphoma. In non-Hodgkin's lymphoma, most commonly DLBCL, then some cases of follicular lymphoma, mantle cell lymphoma, and Burkitt lymphoma, the jaw presentation of African lymphoma, Burkitt lymphoma. Then T lymphoma are very rare in bone, but anaplastic large cell lymphoma can be found or can spread to bone. Hodgkin's lymphoma is also rarely seen in the bone. About 10 to 20% cases of Hodgkin disease, as the disease progresses in the later stage, may spread to bone. Primary bone lymphoma, again, B-cell lymphoma most common, TLBCL is the commonest. Then you can have follicular lymphoma, marginal zone lymphoma, Burkitt, B lymphoblastic lymphoma, lymphoplasmacytic lymphoma, and even SLL. In T-cell primary bone lymphoma, they are again very rare primary lymphomas. Most commonly ALCL, then peripheral T-cell lymphoma, extranodal NK T-cell lymphoma, and Hodgkin disease as a primary disease in bone is extremely rare. Bone metastasis in skeleton, the most common site is the spine, as you can see in this diagram. Back in 1986 probably, I saw examining pleural fluid cell count in Newbar's chamber, and I saw some appearance like falling coins. And I was not sure, then we made smear. I was sure that ये malignant तो है, but क्या है I didn't know. I went to HOD and HOD asked me to bring the book of pulmonary cytology by Jennifer A. Young. Later on in 1997 or 8, we met her in Ames cytocon. And there I started learning about small cell carcinoma, which have molding, nuclear molding, linear clusters, single file, Indian file, high NC ratio, salt and pepper chromatin. And these falling coins were actually the linear cluster, cell molded, nuclear molding. They are very high aggressive tumor, lot of mitosis, apoptosis. This is a typical small blue round cell appearance. And one of the feature, again, it is not very specific, paranuclear blue inclusions. This is salt and pepper chromatin. You can compare with this, seen like this in histopathology. And in 2003 cytocon in AFMC Pune, when I presented my paper on small cell, a series of small cell carcinoma cytodiagnosis, the chairman asked me, did you use IHC? At that time, I was perturbed that typical small cell carcinoma, typical smoker male, elderly smoker male with this typical X-ray imaging appearance and this cytology, why do I need to have ISC? Later on, our cytology knowledge, cytology expertise helped us in histopathology also in identifying a small cell carcinoma in histopathology in whichever side, whether liver biopsy or bone or whatever. And yes, we started doing neuroendocrine marker on this. Skeletal metastasis of small cell carcinoma are again very rare, and they indicate a poor prognosis. Germ cell tumors in bone are also very rare. This is one seminoma, atypical tigroid appearance and background lymphoplasmacytes. dysgerminoma from a 15-year female. PS stain, I mean, dysgerminoma, seminoma, and germinoma pineal gland. Recently, we diagnosed germinoma in frozen section with this. Non-lymphoid hematopoietic malignancy can also be seen as round cell tumor like myeloid sarcoma, most commonly M2, M5, infiltrating in skin, eye, gums, CNS. Then myeloblastic crisis of CML. This was 5-year female child with right retrobulbar swelling, and bone marrow showed acute myeloid leukemia, M4-5. In pre-molecular era, we used to think that FNAC using air-dried smear is advantageous over histology because immediate differentiation of lymphoma and non-lymphoma SRBC can be done by presence of lymphoglandular bodies. Then most childhood lymphomas are aggressive, high-grade, and diffuse character. So FNAC would give you a cellular characteristic better than histopathology because we do not require architecture here. Now the question is FNAC still relevant in the management of SBRCT in this molecular era? FNAC still remain relevant in the management of small blue round cell tumor even in the molecular era, but its role has evolved. Instead of relying on morphology alone, FNAC now serves as an initial minimally invasive procedure to obtain material for crucial ancillary molecular testing. And these are the relevance of FNAC of molecular era: rapid initial diagnosis, providing material for ancillary techniques, monitoring recurrence and metastasis, and triaging for complex cases and deciding what to do next. So the modern integrated role of FNAC in cytopathologist: pathologist synthesizes all findings, clinical imaging, cytology, histopathology, ISC, and molecular studies to arrive at an accurate diagnosis and guide the clinician most appropriate therapy. This is a publication from 2001 in Nature, exploring the use of ANN, artificial neural network, in diagnosing small blue round cell tumor. And surprisingly, 25 years back, they got 100% accuracy in diagnosing SBRCT and subtyping SBRCTs by using a artificial neural network. Thank you.
Thank you, sir. Next, we have Dr. Bharat Rekhi, sir, who will discuss the basic approach to bone tumors and update on the WHO classification. Also, after this session, we'll be having a group photograph. So I request you all to please be present at that time.
So thank you once again, Dr. Shruti, and his talk, because I think it's very inspiring to see that we don't not only see slides, we have a clinical perspective, but we also have our very interesting anecdotes from the people from whom we learn. And it's not just a display of your association of photographs or your publications, but your journey to understanding, respecting the people from whom you learn. So I think I really was very, very inspired by his talk, because the motives of the people whom he is been associated to learn, I very much relate and echo those thoughts, including the works that we embark on as a part of our team. So I'm now taking you to the meat of the, I think, my presentations about the approach to diagnosing bone tumors, and again challenging, thanking Dr. Bhargav and Dr. Rai for taking up this challenge. And I again begin my talk with a anecdote by Dr. Andrew Rosenberg in one of the sessions, very phenomenal bone tumor pathologist. So mentioning about the or quoting in this real pathology. This is actually real pathology, as much as we are getting obsessed with the artificial, with due respect to the updates of computational and bells and whistles. This is really real. This is hard and this is real. So we'll walk through the background, have a background, sneak peek, approach, value addition of radiology. I think I won't overemphasize, just skim through because we've had a lot about it. I'll share with you some newly recognized tumor entities which features as a part of the 2025 edition, some new immunohistochemical markers, kind of very good surrogates, magic markers that I like to call them, or NGS markers as Jason Ornick calls them, ancillary techniques, FISH, RT-PCR and NGS, which is mostly in soft tissue tumors, with my favorite case-based approach. So I think mostly are easy to diagnose bone tumors, and except some, as it's said, and sarcomas we know overall are rare. They can be diagnostically challenging with limited biopsies that we have to handle, and we have to provide information not only with diagnosis, even prognosis, and now even theranostics, because we are in the world of targeted therapies, and now we have certain tumors driven by certain agnostic markers, which is more in soft tissues, but it's kind of coming into the bone also in some ways, as much as we are looking for those low-hanging fruits for challenging tumors that are associated with dismal outcomes. We know that MDT is very, very essential in evaluation of bone and soft tissue sarcomas, and radiograph is, like I said, the best image. Even though every time I'm looking at a bone tumor and asking for a radiograph, I get PET scan, I get an MRI or CT scan, and it's always, what is it on the plain radiograph? And that's the starting point for any bone tumor. Be it pathology, radiology, or oncology, everybody wants to look at the first plain radiograph. We don't use the word X-ray, so it's plain radiograph, and that's what I learned interacting and writing these papers in some of the journals like Skeletal Radiology. So classification is based on the type of matrix. So we know that there can be predominantly bone-forming tumors and predominantly cartilage-forming tumors, or they can be small round to epithelioid to spindle cell. And that's where the morphological nuance is coming. The cytomorphological nuance is coming. As much as we say cytology is not for, primarily diagnosis of bone soft sarcomas, and Dr. Rai very nicely elucidated. And this nuance is coming in the 6th edition with one of my thought echoes that I proposed during that. And we classify tumors benign, intermediate, and malignant. Like I mentioned, you have a chondroblastoma or chondroma is benign cartilaginous tumors. Osteoidous tumors are benign. Osteoblastomas will be intermediate. Giant cell tumor is an intermediate tumor, and then malignants will be chondrosarcomas and osteosarcomas. I won't repeat these images because I know we have now understood what a tumor does and how a bone responds and how basic tumors appear on imaging. So we know the examples of GCT. We know how a chondrosarcoma looks. Mostly, it seems very easy that we've been a part of a CME and we spoke and learned. But the next day you are in your JC, you have a difficult osteosarcoma to handle. You have a difficult chondrosarcoma to handle. But I think we do get tuned towards how we can have an approach, if not being able to solve every case, which is our priority. So like we saw that, on MRI, you have mostly for soft tissue tumors. So plain radiograph is more for the bone tumors, and CT scan for cystic lesions we have ultrasound. But there are certain imaging nuances that, as pathologists I've learned with interacting with the oncologists across the country, that you have this multiple fluid levels that you see in ABC or a secondary ABC. It just kind of tells you on imaging, or the radiologist can help you that they are experiencing some fluid levels, which can be seen in both aneurysmal bone cyst and telangiectatic osteosarcoma. So the ball is in our court. they can't figure that out. Unless there is a cortical break or a soft tissue mass or a solid component, then they're starting to feel that it could be perhaps the telangiectatic osteosarcoma or a giant cell tumor with malignant transformation. So it's very important that the biopsy is done from the area which is more representative, because it helps in surgical planning and also tells the extension of the tumor and also the post-surgical follow. So PET CT has taken an edge over CT because it's useful actually in certain situations. Particularly we've seen over a period of time that in chondroid tumors which are difficult to evaluate on biopsies, and we do that torturous challenge in our routine practice, when actually very big centers have got away with biopsies and cartilaginous tumors like MSKCC. It's a radiology triage, so they will curate a low-grade chondrosarcoma only based on imaging, and there is where AI is taking a very big leap. Radiology, evaluation, chondroid tumors, AI is really helping, or empowering radiologists, if not replacing them, and that's the way, these patients are being triaged with imaging, and then the pathologist doesn't have that torturous, situation on a small biopsy. When we look for permeation, we'll never see that, and we have to tell whether it's a chondroma or a chondrosarcoma, even though the stakes might not be high. In cartilaginous tumor, it's good to pick up the high-grade sarcomas, but for the low-grade, you can shift the ball to the radiologist's court, if not in all situations, which we should not do. So in cartilaginous tumors, my very good colleague Nilesh Purandre, he's shown us again, with the evidence from the literature, that certain SUV values, now some people call them as silly useless values, but they are actually useful because SUV values can help or indicate that this cartilaginous tumor can be more aggressive. More than 3.1 is the call, but there is nothing cut and dry. But that's one way of, this SUV higher is associated with in a chondroid tumor, which could be actually more aggressive. More important is that in certain situations of dedifferentiated chondrosarcomas, they can figure out that you have this variable areas and the baseline SUV is lower. Now there is a suddenly high SUV, so there is some malignant transformation happening. Having said that, you can see these SUV high values even in inflammatory lesions. So it's just in a context like every morphology, every IHCs, but it's been useful in cartilaginous tumors, the PET CT, in terms of the judgment. Like I mentioned that, we're done away with the frozen that we used to handle. Again, a very, difficult situation that we had, because in a frozen section, imagine you have to tell Ewing sarcoma, the cut margin, when you have so many lymphocytes and so many round to polygonal cells, and you have to really pick up, it was again a very difficult task. But now here imaging has taken a lead. We've shown in our, thanks to our radiologists and our oncologists who've shown that MRI is very good in pre-op planning, and we don't get these frozens anymore of those scrape smears, scrape imprints to tell that it's a marrow involvement by Ewing sarcoma, because hematogones are a big pitfall, and we've had very occasional cases of the overdiagnosis. So we're done away with doing frozens on imprints of the Ewing sarcoma because MRI has taken the leap. So it's very interesting to know certain disciplines, how they have helped overcome the diagnostic challenges, both for us and for them. Like I always say, in a soft tissue sarcoma, you can't ask your radiology colleague to tell you what a diagnosis is. You can't bring every case in JC. You should know what cases are challenging and who can help in most. So I can ask my radiology colleague to tell me whether it's a pleomorphic sarcoma or a synovial sarcoma. It's pathology. But in cartilaginous tumors, yes, I have to take a lot of support. So we learn and pull out, strengths of each other. Now, trying to evaluate bone and soft tissue tumors, I always show in my presentations, be it cytology or pathology, is a good algorithmic approach in your mind, and you know the conceptually how things work. So whether it's a tumor or a reactive lesion. So our threshold towards seeing tumors is lower because we are a referral center, and not only tumors, malignancies, large sized, but at a community hospital, you will see certain reactive lesions that can be very freaking and challenging. And I say that they handle a bigger challenge in bone tumors because first of all, they are rare, and then the lesions can mimic. Myositis ossificans can absolutely mimic a sarcoma until, you've integrated radiology, which might not be there. So we need to know that there are certain cysts, parasites, inflammatory lesions, and even certain tumors. Now they are moved from reactive towards tumor. That is what I'm coming towards. Pseudosarcomas, as we used to call them, like nodular fasciitis or myositis ossificans. They are tumors because they are clonal and they have the molecular signatures as well. So once you've differentiated a reactive lesion towards a tumor or neoplastic lesion, you classify whether it's benign or malignant, and intermediate is something in the middle, which can be locally aggressive or rarely metastatic. And that's an example. Classic is giant cell tumor, because it can recur, it can undergo malignant transformation, and it can also be metastatic. Now, once we've formulated a diagnosis of sarcoma, that's the time we grade it. So, sometimes the reports come as low-grade tumor. Now, that's very baffling, because we always grade a sarcoma. We don't grade a tumor. We have to be sure that we're dealing with a sarcoma. In those situations, I use the word low malignant potential. That's better, because grading word means it's a sarcoma, but people still use that term. I have reservations, because again, it's not only the grade, then they'll ask you, what is the grade? So low grade is grade 1, and 2 and 3 are clubbed together as high grade sarcomas. The diagnostic challenges, and I have certain tips for you, here that I've learned over a period of time. If you have a situation of myositis ossificans versus an osteosarcoma, clinical history, imaging, your morphological clues. Now you have even the molecular motifs, because the same morphology, the same molecular motif of USP6 also is seen in myositis ossificans, and one can go for those if you have more posh and you have more NGS facilities. We don't at the moment have that. So we're mostly banking on clinical history, imaging, and certain morphological clues. Chondroblastoma versus osteosarcoma, we've seen, I still see this pitfall, because they can be very cellular, but it's the imaging that helps you really, and the clinical history, and again, so it's the pathological features. Fibrous dysplasia versus low-grade osteosarcoma. One is a leave me alone lesion, one is a major resection. So imaging is very important. It might not help you, because we know that fibrous dysplasia has this very peculiar ground glass appearance. These both can be lytic lesions. It can be multifocal, multiple lesions. So it can be it can be very challenging. So imaging is one aspect that one can. Further, its mutations, GNAS mutations are seen in fibrous dysplasia. MDM2 is seen in low-grade osteosarcomas. You have a surrogate MDM2 immunohistochemical stain, which might or might not be helpful. Ideal is go for the amplification. So that's, the stakes are high. You have to resort to molecular or the immunohistochemical techniques in some cases. Aneurysmal bone cyst versus telangiectatic osteosarcoma, it's cytomorphology. It seems quite unsettling for the pure histopathologist to say, what has got to do with cytology with bone tumors? Trust me, I've seen these examples of mistakes being happening, because imaging can be totally overlapping. Histopathological architecture as it's perceived, it's very similar. Fluid level, cystic areas, the devil is in the details, and that cytomorphology, which is very paramount importance. And you can see from one benign lesion to the highest grade bad tumor. So it's cytomorphology that bails you out. Giant cell tumor versus malignant giant cell tumor, it's morphology and imaging, because again, you can't ask your radiology colleague to tell me whether it's a malignant transformation. It is us who have to furnish this, because it can be very overlapping. Giant cell tumor can be very aggressive looking. It can have a solid component. It's got a spectrum of features that I will share with you, and it's a morphology, and it's still difficult for experts across the world. Chondroma versus chondrosarcoma, that's radiology, especially low grade, which is now called as atypical cartilaginous tumor in extremity sites, and chondrosarcoma in the flat bones, because what as pathologists you need in those cases is permeation or bone entrapment, not the juxtaposition of the bone to the cartilage. It's actually true permeation host to bone, which you can only see on imaging. You can't expect on repeat biopsies that it shows up. You still say it's a chondroid tumor, I can't, and then they can curate that, which is possible in those low-grade chondrosarcomas. Chondrosarcoma versus chondroblastic osteosarcomas, it's morphology, because if you are seeing a malignant cartilage in a pediatric patient, it's more chances to be a chondroblastic osteosarcoma than a chondrosarcoma, because as chondrosarcoma progresses, it becomes more myxoid, unless it's pleomorphic, which will be in adult patients. So in pediatric patients, malignant cartilage, more chances to be chondroblastic osteosarcoma, and more myxoid tumor in adult patients with your imaging, which is a very classic, because you see these rings and arcs of calcification on imaging in lobulations, or your popcorn calcifications more in chondrosarcoma. So morphology plus radiology, and that's one situation where this very otherwise useless marker can help you, but not perfect. SADB2, which will always be positive in osteosarcomas. If it's negative, it has less chances for a tumor to be osteosarcoma. Again, it's very rare, it's contentious. Ewing sarcoma versus small cell osteosarcoma can be very, overlapping features, and small cell osteosarcoma is kind of a entity which is not actually as a separate tumor, because it can be a spectrum of, of an osteosarcoma where you can see on a small biopsy a small cell component. But if you see carefully, they are not monomorphic. You will see this variation, and you might not see osteoid. You won't see osteoid in aneurysmal, the telangiectatic osteosarcomas or giant cell osteosarcomas or small cell. You can't expect. But this is a situation where SADB2 can be helpful, because SADB2 doesn't come in Ewing sarcoma. It comes in osteosarcomas, including its all types, mostly. Otherwise, it's not a very useful stain overall, as much as it took its, value, but over the period of time, all the pathologists across the world have agreed that SADB2 is actually not useful. I don't say anything is useless, because everything has its value. So this is one area where you can use this marker, but ideal will be molecular testing, because you go for EWSR. Again, that is not specific. EWS-FLI1 also might not be specific, but in bone, yes, it is, because this fusion, if you are seeing, it's not an osteosarcoma, it's going to be Ewing sarcoma. And then you have uncommon scenarios of vascular tumors and adamantinoma. So it's going to be a case-based approach. First case is a 40-year-old male with a painful gluteal mass of 2 months duration. MRI showed an ill-defined heterogeneity enhancing mass in left gluteal region. So you see MRI first coming in, as much as you want the plain radiograph for a tumor like this. But it's a gluteal mass, so it's a soft tissue. So MRI is good for soft tissue tumor. And this can be a diagnostic trapdoor or a pitfall. That was the biopsy I got. So you see a lot of, or you see tons of osteoid that you are seeing, in this magnification, and you see a very rich admixture of spindle cells with a lot of things happening. I call this like a Bale-Puri effect, very active, reactive process, and it's kind of freaking you out because you see a lot of this bone formation, right? So technically, if you're seeing atypia with bone formation, it becomes osteosarcoma, but it's not actually. You have to demonstrate really pleomorphic malignant cells around the osteoid to call something as osteosarcoma. I'll come back to this slide, but I just brought it because this entire frame shows the lesion in its totality. Let's see the components of this. So on one side, you're seeing this very active, reactive proliferation of these cells, which are spindle, and they look like kind of, for the cytopathologist, and I always say cytopathology is 40x of histopathology for the purists. You see this myxoid areas, and you see these branching blood vessels. You pay more careful attention towards other features like subtle myxoid. You're seeing a lot of plump cells, but you're not seeing pleomorphic or anaplastic cells, right? So you can see cells with enlarged nuclei, but you don't see those pleomorphic cells, and you're seeing agreeably a bone formation. You see a lot of extravasated RBCs. The other component is very worrisome. You're seeing these cells with a lot of osteoid formation. So do we call this osteosarcoma? Yes, it is possible, and it was almost about to be called as osteosarcoma. But I'm just bringing back to you this frame of putting the things together with a radiograph. This was a soft tissue mass, right? So you're seeing a soft tissue mass, and extraskeletal osteosarcomas, I still feel, is very contentious. And extraskeletal osteosarcoma there is no low grade, it has to be a high grade. If you see here, you see your favorite zonation. You are seeing this central area, and you're seeing the bone is forming at the periphery. Just like you're seeing in the soft tissue calcifying towards the periphery, even here on the CT, you can see this peripheral. Oops, I think this is, you need to use the pointer here. So, yeah. So you see this bone formation, you see this peripheral ossification, you see similarly. So this is zonation phenomenon that you're seeing, and there was a history of trauma that put the things together. This was myositis ossificans traumatica. These lesions still can, because in nodular fasciitis, we know that most of the times they can be 3 centimeters, but myositis can actually be 5 to 6 centimeter sized also. And this was one of the studies which I always feel sad about. We didn't publish. Of 112 cases of my student, Dr. Ekta, and we found that nodular fasciitis as a soft tissue mass, even now I can say about 60 to 70% cases is not actually unequivocally diagnosed the way we see it. And myositis ossificans was a part of this, spectrum of pseudosarcomatas was a major pitfall. You can see in 50% cases it was not called. We had 4 cases which were actually called as osteosarcomas, including a foreign referral from Iraq who had an amputation for a myositis ossificans. So how they were termed as suspect sarcoma, chondrosarcoma, favorer. So this entity is still fraught with major discrepancies, myositis ossificans. So make sure that you don't miss out on imaging, and certain morphological clues can help you. And this is what I'll share with you, the pearl of pathology here, is that you see this bone formation. This is the patient from Iraq, we had this case called as osteosarcoma because the mitosis are here and they just kind of freak you. There's a little nuclear enlargement. And I'll quote Dr. Oni, when we were talking together in one of the sessions and he was speaking on bone and I was speaking on soft tissue. He said, if you see mitosis in a suspected pseudosarcoma, just don't talk about that. So you just ignore. In contrast, if you will share accidentally this slide with a neuropathologist, so very sensitive about mitotic figures, they will just escalate it to high-grade sarcoma, which actually happened. So it's important that we use a morphological feature in a setting, and myositis and nodular fasciitis just ignore. What you need to be attentive towards is atypical mitosis or anaplasia that you will not see in pseudosarcomatous lesions, and you shouldn't be seeing that. So zonation or centripetal ossification favors myositis ossificans, and these are synonymous with the fibroosseous pseudotumor of digits. These are pseudomalignant localized self-limiting lesions in contrast to high-grade osteosarcomas, which have to be dealt with major resections and chemotherapy that I just alluded to. Case number 2, 14 years old male with a lytic lesion in lateral femoral condyle. You have a young patient. You might not be lucky to have these details in cases like this, but this is very important. Young patient, lateral femoral condyle and a lytic lesion. So what is this? This is another diagnostic pitfall or trapdoor. Very cellular tumor, again you see this, but I think for the experts here, it's a no-brainer. I'm just sharing with you because on a routine basis, one can actually get into a trapdoor for a lesion like this. Very cellular tumor, you see these cells which are like, really can be looking very worrisome. You see this pinkish areas that you might perceive that this is osteo, but actually it's a pink cartilage that you see in tumors like this. And you might not see your favorite chicken wire calcification as a part of this tumor. What is important is to see these individual cells have this pericellular calcification that actually causes this network of chicken wire calcification. And you see this chondroid areas with this pericellular calcification with this giant cell. So this is very typical for a chondroblastoma, which this tumor is, and it was called as chondroblastic osteosarcoma. It looks unbelievable, but yes, it can happen. You might not see in the smallest biopsies all the features that you want, including, but if you know the morphological features that you have this reniform nuclei that very nicely Dr. Rai showed as a part of the LCH, and then you see this pericellular calcification. You might not see giant cells because it's not like a giant cell rich tumor, but on a small biopsy you can see some diagnostic clues, but what is important is the radiograph. So osteosarcoma is not going to be, you see a chondroid based an osteosarcoma, it's not going to be pure lytic lesion, right? So which is the most important feature here. So it's important that we integrate, and then you can see this higher magnification. You can enjoy these coffee bean nuclei. So what is most important here is that we integrate these features in a radiological context. That's most important for a chondroblastoma versus a chondroblastic osteosarcoma. They can be challenged on limited biopsies, and I think like I said, you might not see all the features. You might see some hyaline cartilage, or which is looking more pink, and you might not have your radiographs. So that's the time actually you tend to use or abuse immunohistochemical stains, and we were trying to come up with some solutions because there were some P63 staining in GCTs and A1, A3 which can come. So something which is available in lab is DOG1. I think most of the labs have DOG1, and that's one of the useful markers that we've seen, and that's why we tried to publish this. So it shows its sensitivity in 84%, specificity in 100% cases of in a context of giant cell tumor, because chondroblastoma, because you won't see this happening in a giant cell tumor. Again, it doesn't come diffusely, so you have to be very careful about evaluating DOG1, because this is what you should take the staining as positive. You see this nicely granular to membranous staining. You can see focal or patchy areas. It doesn't come diffusely positive. And that's what we published in part of the spectrum of 36 chondroblastomas, including value of DOG1, which I still believe in for the labs who don't have the new magic marker, which I'm coming towards now. So that's what has taken the, swept the bone and soft tissue pathology with two magic markers as perfect surrogates, the histone marker, the H3K, H3.3K36M, which is for chondroblastomas, and G34W, which is for giant cell tumors. These are like almost perfect surrogates for the underlying mutations that these tumors have. And these are magic markers because they come diffusely positive in the tumor cells, even on the limited littlest biopsies in the entire spectrum. And it's actually led to expansion of the morphological spectrum of these tumors. And that's an example of this case, which was called as chordoma, because it was a paraspinal little soft tissue mass with this primary lesion in the vertebral, which is uncommon site for chondroblastoma. And you can see, yes, it does look like, because you have this little myxoid sort of areas which you can think that this is matrix. But if you see, the devil is again in the details. You are seeing this reniform nuclei and this little pericellular calcification. Chondroblastomas can be positive for keratin. So we did DOG1 and it was focally positive, but what was importantly positive diffusely here is K36M. And you can see it's positive in all the tumor cells and spares the osteoclastic giant cells because it's a marker for the tumor cells. And that's what you expect and see in chondroblastomas. They'll be diffusely positive for all the, I think, the littlest. And that's an example, I think I just kind of quickly missed to this. That's a classic example of a chondroblastoma with a secondary ABC. You can see, ABC as a component of chondroblastomas. And that's all what you might see on the biopsy, but you can see this K36M nicely highlights every tumor cells. It will not come positive in ABC. It will not come positive in GCT because, and this is the only tissue we had on the biopsy for this lesion, which actually, if you see on imaging, fits very well. You have this lytic lesion well defined for achondroblastoma. So everything coming together. You don't see our calcification. You can see just occasional giant cells. It spares the giant cells. It's very diffusely positive in all the tumor cells. And that was the extended spectrum that I was sharing with you in a case of chondroblastoma, which was initially called as chordoma. It was brachyury negative. That has even led to the contentious point that is chondroblastoma a benign tumor? And I just put this again forward because there are rare situations of chondroblastomas actually metastasizing. It's in the literature, and this was the first case of malignant chondroblastoma that I came across in my 18 years at TMH. And how it started, we had this case of this unfortunate patient who was actually diagnosed clinico-radiologically as an osteosarcoma. You can very easily believe, you see a lot of these atypical cells, and you see this pink matrix, and it was also SAT-B2 positive. But as a morphologist, I could spot nicely this area which resembled and reminded me of chondroblastoma. But how to prove this, right? So that was quite in time that we had this funded project, and I have to again acknowledge my student Vinayak, with whom we did this study on both K36M and G34W in chondroblastomas as well as in the giant cell tumor. So you can see this is a K36M positivity in the and all the chondroblastoma areas, which we thought morphologically sparing these giant cells, and this is DOG1. The malignant area similarly showed this K36M, and it was also positive for SAT-B2, which was sparingly negative in the chondroblastoma areas. So it was a sarcomatous transformation actually happening, and that's a very rare situation that chondroblastomas can undergo malignant transformation. It's one of the very few documentations, and it's kind of building. So if you see before the 2013 classification, chondroblastoma was called intermediate. Then the 5th edition, 2013 actually it was called intermediate. Then in the 5th edition, 2020, it was called purely benign. And we are still going to call this benign tumor because I think it's very rare to undergo malignant transformation. So this is a malignant chondroblastoma which can happen, but very rarely. 52 years old male with a recurrent malignant, recurrent mandibular tumor. So the situation morphologically here is a fibro-osseous tumor. That's another very contentious area, right? And this was called because head neck is a very prominent site for which tumor? If you have a fibro-osseous tumor in the jaw, which is the most common? Sorry? It's fibrous dysplasia, right? So it's a radiological diagnosis. This was called as fibrous dysplasia even on the pathology until this came record. And then, I was asked to review this case. What you see is a lot of this proliferation. Again, you're not seeing something high grade, but you see this pattern, the way in which this bone is it's a formation and destruction by this prominent spindle cells. So you have this formation with this little Chinese letter pattern that you would think for fibrous dysplasia, but you see this osteoblastic rimming. So there is a reactive process also. At the same time, it is so destructive. This tumor was so destructive until it recurred and even underwent a high-grade transformation, and this was actually a low-grade osteosarcoma. How we were able to make this diagnosis, even in the absence of the imaging, we use MDM2 IHC, and you can see all the cells are nicely highlighted by MDM2. So that's a good surrogate, if not perfect, because again I said, if it's a decalcified specimen, immunos, you just need to be lucky if your immunos work, but FISH won't work. It didn't work, but it was diffusely positive. I still didn't settle for very easily for an osteosarcoma because site is uncommon, but it's recurring until I saw that there was a high-grade transformation, which this patient had, was actually a high-grade transformation in a parosteal or low-grade osteosarcoma happening unusually in head neck location. 23 years old male with a lytic lesion in distal femur. So you see a lot of hemorrhage, you see certain cells, it's quite cellular. They take your attention. If you see in this magnification, certain cells are actually taking your attention. So you do see, you're tempted to call this as aneurysmal bone cyst. You have your favorite osteoclastic giant cells. It was called aneurysmal bone cyst until there was a recurrence. And you can see this is huge, right? So this can happen. And then, it can be very difficult how to handle this situation. So again, I intervened as a part of the opinion and tried to see what happened here. So if you see, it is understandably a giant cell rich tumor, but the devil is in the details. You see a lot of these pleomorphic cells, and I won't blame the initial pathologist because it wasn't in the recurrent lesion that you can see here. But if you circle back towards the initial lesion, there were, and look closely, you see these cells in the background of these giant cells, right? And this is what should take your attention, that you see closely in every ABC, because imaging can be very deceptive, overlapping. You don't want to ignore these background real McCoys here, and what takes your attention generally is these giant cells, and you have these fragments. So this actually was a telangiectatic osteosarcoma. On a good day, that's what a classic ABC will look to you. You see these fragments of wall-like. You see this blue bone. I think Dr. Unni has described this blue bone, or chondroid aura as it's called. And then you see these giant cells. You have the solid cystic. I have never made a diagnosis of a solid ABC, but you can expect a solid component in an aneurysmal bone cyst. So it's kind of a very overlap, but the devil is in the details of cytomorphology, and then you don't want to miss out. Because again, huge difference, because aneurysmal bone cysts now are not only curated, they are also candidates for non-invasive sclerotherapies, that our oncologists offer to patients like them, in contrast to any osteosarcoma that needs to be dealt with resection with chemotherapy. 78 years old male with pain and swelling left knee and had previously undergone a curettage with a cementing procedure. That happens with classically in giant cell tumor of bone. Looks very, you can see this cement, and then you see this very typical lytic lesion. Narrow zone of transition, so it seems very fitting for a diagnosis of giant cell tumor. And then this patient had a nodal lesion, and that's where you can say cytology has a role. So if you see this cytology, this is not a benign tumor, right? So you see even the multinucleate giant cells are very concerning. And then there are a lot of mitotic figures, a lot of ATPM, bizarre pleomorphism. I won't call this atypical, but this is a very bad looking mitosis, because to me, atypical mitosis is an indicator of anaplasia. You will see multipolar features, but this is frankly on a very usual day for a cytologist and the purest pathologist, a sarcoma on an FNA. So this lesion on one of the suspicious nodes was FNA'd, and this was actually, and I happened to see that, and then I saw what went in this case. So this was again another review case. It was giant cell tumor of bone. So was it transforming? And then we took several sections, and one of the sections additionally showed this nodule, which was malignant, and that was actually a malignant GCD. You can see this necrosis, and that same nodule you can see on cytology, on the histopathology. I think out of 12, 13 sections, one of the sections showed this. So here I value cytology, which prompted us to go back. You look what was missed, and importance of sampling enough in cases like this cannot be overemphasized. So this was a malignant transformation in a giant cell tumor. Chondroma versus chondrosarcoma, again, like I said, it's the bone permeation. You have to see this is the bone, the host one, it's permeated by the tumor and destroyed totally by the tumor. You don't see juxtaposition, or what I say, when the bone and cartilage are just back to back, it needs to be really showing destruction, and that can be very difficult on small biopsies. So you have to take support from your radiology colleagues. 33 years old male, ileal tumor. So you see here, a sizable tumor here, and you see chondroid, stroma, and that's atypia. That's what you can appreciate in a case like this. So flat bones have more chances to be being chondrosarcomas than even grade 1, because if we call this grade 1, they'll escalate easily to grade 2 because they have 2 excises, and this was actually a high grade, at least grade 2 chondrosarcoma, what I called. Again, imaging is of very paramount importance because both plain radiograph on MRI can help to see the confines of this largely destructive tumor that this had, and you can see here the bone destruction on the excision high-grade atypia. 70 years old male, femur biopsy. Again, age becomes very important, imaging becomes very important, your morphological nuances become very important. You see here frank atypia in the cells by multinucleation, and this is destruction. This is entire bone, the cartilaginous tumor is destroying. This is what is bone permeation or bone destruction. It's a grade 3 chondrosarcoma that we were able to, and you can see this was a resection called as grade 2 to 3, it was high grade chondrosarcoma. That was an interesting case that I came across in the pelvis, which is called a small cell osteosarcoma, because sometimes we tend to think mathematically. Somebody felt that this is a cartilage, you see these malignant cells, okay, and then you add up. So any cartilage malignant cells is a chondroblastic osteosarcoma. So patient was triaged on chemotherapy. There was a residual tumor, because you can see chondroblastic osteosarcomas, the osteosarcomas including mesenchymal or chondroblastic, they are given similar chemotherapy on the lines. The chemotherapy drugs are same as are for Ewing sarcoma. You have a context of a round cell morphology and you have a cartilage. So, the thought processes can range from mesenchymal chondrosarcomas, which are chemoinsensitive, to chondroplastic osteosarcomas, which are again chemosensitive, and Ewing sarcoma, because you have a round cell morphology. So it was, and the drugs can be very overlapping. Of course, the cycles are different. Chemotherapy regimen for osteosarcoma and Ewing sarcoma is different. So there was a residual tumor, there was a response. And 3 years later, the patient had an adrenal deposit. This came to our JC. And that was the time I was asked again to look back what happened. So I said, well, this is unusual, right? You have a morphology. What you see here, this cartilage is actually not a part of the tumor, but is indigenous, to the area from which the biopsy. So pelvic cartilage in this patient came up, and this kind of led towards somebody thinking as osteosarcoma. It's actually, and we've seen few examples of cartilage plus small cells is equal to mesenchymal chondrosarcoma or chondrosarcoma. No, because mesenchymal chondrosarcomas, you will see this hemangiopericytomatous pattern of the small cells, and then you see this chondroid areas in juxtaposition. I don't have a slide as part of this presentation, but there are morphological nuances here. And this was a round cell frank morphology, and I said, this is the time we need to go further. Let's triage this for SADB2 and EWSR1, and this was a EWSR positive Ewing sarcoma. You can see these, it's going just a bit faster here. I don't know for some reason. So, yeah, oops. So it was EWSR rearranged tumor, red-green split signals. Let me touch it here, yeah. And you can see these red-green split signals. So this doesn't happen in osteosarcoma. This was a Ewing sarcoma. That's an example of, yes. I think it was a pediatric patient. It can happen in both. Ewing's and osteosarcomas are in young adults and pediatric patients, so that didn't quite help out. Let me check if I remember, in contrast to this chondroid sarcoma. This was a pediatric patient for sure we had, yeah. So this was a case again, which I called a small cell osteosarcoma, but it was unsettling because on imaging they felt that this was a Ewing sarcoma, and I think on pathology we will all not want a marker on a tumor like this. Of course, it has round cells, so it was EWSR diffusely. You can see none of the signals is split, so all intact signals here. No separation, so it was negative. So it was a small cell osteosarcoma, which I feel is a very esoteric diagnosis because it's not a separate entity, but you can see this is a part of the spectrum. This was a very sclerotic tumor. You can see very destructive tumor and very epithelial, because you see these rosettes formed by these epithelioid cells, and this was a rosette forming osteosarcoma. Again, that's a situation where I feel SADB2 can be useful because you will not see an osteosarcoma that is negative. It had a small cell morphology, but you see diffuse positivity for SADB2 with this otherwise pink cells in contrast to small blue cells for this osteosarcoma, which was a small cell type perhaps. 8 years old male with a lytic lesion in the middle and distal, 1/3 of the distal of tibia. Now, if you see in soft tissue tumor, what is the diagnosis? Fibrosarcoma, yes, but you know, I can say fibrosarcoma now is a vanishingly rare tumor, and it's going to, yes, so that's what I see, that you know, these tumors still get referred as fibrosarcoma as adult, but it's going to phase out in the 6th edition because, and we do get, and it's understandable because we've always associated this herringbone pattern to fibrosarcomas, but actually immunohistochemistry changed the landscape because a lot of these tumors are actually synovial sarcomas or MPNSTs or SFTs. So fibrosarcoma as a tumor entity in adults, it's vanishingly rare, so it's phasing out. It hardly exists. It exists only in DFSP undergoing a fibrosarcomatous transformation. But in pediatric patients, we have the infantile fibrosarcomas and we have the kit-driven sarcomas. So this actually was referred to me as synovial sarcoma. And you know, and it's understandable because it's morphologically from a very renowned, famous pathologist. And then, yes, it was a very biphasic tumor. You see this epithelial areas, you see this, spindle cell areas in a herringbone pattern. And it was also positive for epithelial markers and our favorite BCL2 that we've been utilizing over the period of time, but now we've got away with BCL2 because we have the protein itself, you know, we don't need to fish out. So this came in fish as well, and this was negative for SS18 gene rearrangement. You see all the red-green split signals are fused. You don't see any split. If you go carefully, and if you know what was the site, so this tumor that I'm coming towards is a very site-specific tumor. So tibia, for some reasons, is a very interesting location for the unusual tumors. And this is spindle cell morphology, and this was negative for the SS18. So SS18 is going to cover more than 95% synovial sarcomas. It really rules out a synovial sarcoma. Now that's what I wanted, imaging. I asked for the plain radiograph, and I have to thank Dr. Manish, who referred this case from Hinduja to me. And if you show this to a radiologist, it's a no-brainer. This is an adamantinoma, and this is spindle cell adamantinoma. It was diffusely positive for P63, which is a squamous marker. So that's a pitfall that you see the spindle cell tumors, particularly in locations like tibia. I mean, I can say over a period of 18 years, I've seen 1 to 2 synovial sarcomas in bone. We've seen BCOR rearranged sarcomas, we've seen adamantinomas, very rare, spindle cell pure morphology, but I've seen synovial sarcoma, even though SPC is the most common soft tissue sarcoma in adults, it's rarest in bone, at least in my experience. So again, what is important here is that the patient doesn't need any chemotherapy. This is a case for resection which this patient had, and unlike synovial sarcoma, because it's treated like any other high-grade sarcoma in bone, so adamantinomas are malignant, they are candidates for. So it's very important that we interpret these findings in a radiological context, because you see cortical-based sizable tumor. We just completed our 12 years or more study with my student Dr. Radhika of adamantinomas. And spindle cell adamantinomas can be a diagnostic pitfall. And this comes again from a very nice study by Andrew Horvath from Stanford group and Jessica Davis, who've shown that they tried to reappraise these spindle cell synovial sarcomas and adamantinomas in bone. They found that they were associated with the major pitfalls. This led us to collaborate for going further after these publications of actually synovial sarcoma happening in bone. And I had the chance to review this article, and I didn't settle for something less. They demonstrated the SS18 rearrangement. You can see the red-green split signals. So this is a true synovial sarcoma in bone, and we had a publication of spindle cell adamantinomas that we collaborated further in IJSP that we published. So coming towards something more that is happening in the WHO classification of the, has happened in 2020 as a part of the bone tumor spectrum. Benign fibrous histiocytoma of bone has been removed. It's been brushed out because those are mostly giant cell tumor of bone. Liposarcoma of bone is removed because it's extremely rare. Hibernoma has been included. Chondroblastoma and chondromyxoid fibromas are benign tumor. Giant cell tumor is intermediate. And we've got specific mutations for chondroblastomas. So now we know, we've learned about the spectrum of the pathological feature associated with this denosumab-treated giant cell tumor of bone. Synovial chondromatosis is a locally aggressive tumor. Something which is more interesting and is expanding in terms of its spectrum is the undifferentiated round cell sarcomas, which will now become even spindle in the 6th edition because there are morphological nuances towards these round cell. Ewing's as the classic example, and the others as the, the genetically defined subsets or the variants. Atypical cartilaginous tumor or chondrosarcoma grade 1 are synonymous in the extremities. We call chondrosarcomas in the flat bones. And then there are entrants, the poorly differentiated and the dedifferentiated types of chordomas as the new entrants. Brings me to giant cell tumor of bone to share with you that it's the most common intermediate tumor that we see, composed of the mononuclear cells, which are the tumor cells, and the sprinkling osteoclastic giant cells, which are the recruits for causing bone destruction. They happen in mature skeleton and treated with curettage and cementing procedure. So mostly they are curated. It's a benign tumor, you know. They are associated with recurrences. They can metastasize as giant cell tumors only. So if you see a radiological lesion which is in the lung in an otherwise GCT, it could still be GCT. It doesn't equate to malignancy until you see malignant features, and that's the time what you call as malignant transformation. That's a classic example of a giant cell tumor of bone. You see, we had studies which were using P63 as a marker, but it's not very specific, because you can see, and this is what the specimen that we were seeing, very hemorrhagic tumors, as resections, which has changed over the period of time. And thanks to the new magic marker, the histone G34W, just like the K36M for chondroblastoma, we have the G34W with an underlying mutation. And that's helped us in separating giant cell tumor from the others. And now, in present times, a diagnosis of giant cell rich lesion doesn't suffice, because you have to tell whether it's an aneurysmal bone cyst, which is driven by USP6 and is negative, or G34W, because those are candidates for sclerotherapy options. Chondroblastoma, small size, can be candidates for radioablation in some cases, and giant cell osteosarcomas are candidates for chemotherapy and major resection. So we can't call conveniently something as giant cell rich lesion. We have to classify these, because there are treatment associated options tailored for these, and that's the marker that is helping us. And what is important, which came out of this study, was also that we had this malignant transformation of pleomorphic cells. Necrosis and atypical mitosis is a part of the spectrum, and you might not see giant cell cells, and these were called as osteosarcomas, which actually, with this mutation of the IHC, has been shown that actually those were, over the period of time, GCTs undergoing malignant transformation. And I was very fortunate to be a part of this very esteemed group in ECP 2023, and I can, when we spoke, and she's Fernanda Amari, who is the person for the discovery of these mutations with Dr. Adrian Flanagan. We're having Dr. Flanagan as part of our meeting in Hyderabad. He is, I just have to introduce, he is the person who's the first TFCP2, he is the chordoma person for brachyury, and he is the guy for the methylation. So these are the faces whom you see who've done their seminal works in these different areas, and that's the hottest. Daniel has worked on the methylation profiling on Basel from Switzerland. And that's the landscape of GCTs in terms of the diagnosis, the way it has changed. You see this marker again very nicely highlights all the tumor cells. It's sparingly negative in the osteoclastic giant cells, and there's been a lot of enthusiasm after Fernanda's study, which was the seminal publication, followed by studies from India. Dr. Shantveer had one of the publications, and we followed with my student again, Vinayak, with whom we did, looking at not only just the sensitivity and specificity, but the spectrum of GCTs. So you might have a case of this, which is a post-denosumab-treated GCT, and you don't see any giant cell, but you can see the marker is positive all over. So, it just tells us that the giant cells have gone, but the tumor cells are still there. So it doesn't equate to, tumor clearance in a post-denosumab-treated GCT, because the tumor cells are still there. That's an example of a malignant giant cell tumor. You can see these giant cells, and you see this atypical mitosis that I really value. And you can see this marker not only highlights the tumor cells, but also the pleomorphic cells. So it's all the malignant processes that are happening are associated with this giant cell transformation. It has led to expanding the spectrum of GCTs, because cartilage formation is non-equivalent to GCT, but we saw this case which had this pericellular calcification that I was mentioning as part of the chondroblastoma. It was negative for the K36M and diffusely positive for G34W. So we've seen very unusual faces, and that's why benign fibrous histiocytoma has gone away, because most of those tumors are actually a spectrum of GCT thanks to this protein that has reinforced this concept. Brings me towards the management aspect. So you've seen in advancements in terms of the diagnosis, uncovering the wide spectrum of GCT, including even bone formation that we have seen now in GCT with this G34W positive marker. So denosumab's story, I think, is not new to most of us, because we know that it appeared, these are the magic marker. This was called as a magic bullet. But didn't help in tumor curation, it helped in better surgical amenability. And this breakthrough was actually, what was behind was, so this molecule, it's not a chemotherapy, so we don't call these specimens as post-chemotherapy, it is a target that targets a rankle, I call this a dirty liaison, because this leads to this destruction of the osteoclastic giant cells, who are the recruits of this dirty liaison, or the association of the rankle ligand, causing this destruction in the GCTs, and this targets these this liaison, and curbs osteoclastogenesis, leading to rebound bone formation that you can see. As a part of this imaging also, you see a lot of this sclerosis of this otherwise very destructive, and that's how you see these post-treated denosumab specimens and the images on radiograph. I showed you an earlier example of very sclerotic tumor. Here you can see this was a very destructive tumor, very difficult to resect, but you can see there's a lot of sclerosis that is happening, and this helps in better surgical resection. On the pathology, you can see osteoblastoma-like areas, you can see fibrous areas, you can see a lot of woven bone formation that can worry you to consider that could be a low-grade osteosarcoma. And that's the one of the first publications towards what features that you can see or expect in a giant cell tumor. And you can see how difficult it can be to manage this hugely blown GCT that we had come across. Every time on the imaging that felt that it's a bad tumor, it was giant cell tumor, very, very destructive. And you can see post-denosumab treatment, it is more surgically amenable. You can see this nice calcifications because there is a lot of rebound bone formation, but still the tumor is there. You can see the giant cells and you see a lot of this bone formation mirrors towards what you are seeing, at the periphery of this. Now it is more surgically amenable than this. So that's how giant cell tumor of bone is being not only diagnosed as a part of this spectrum, but also managed with this denosumab treatment. And again, bringing you back to our publication, we had this 18 primary and 7 recurrent GCTs, one of the first studies that we were able to accomplish from our country. And we call this a pseudosarcomatous, one of the lesions, the expanding spectrum of pseudosarcomatous tumors or lesions is the post-denosumab treated GCTs. This is the additional literature that has shown up, including cases looking like fibrous dysplasia, osteoblastoma, like I mentioned, fibroma. So you have a huge spectrum, and this was it took us further towards from the clinical perspective that my oncology colleagues, they wrote up this, and then the thing that emerged was whether it is leading to malignant transformation because it is causing a bone formation. Now that has been a point of concern, whether this is triggering the malignant transformation in GCT or it's just an association. We didn't see in our series many of these post-denosumab GCTs, but this is another study that shows by Dr. Manish, a very renowned onco-surgeon, and they had this quick publication after ours showing that you can see malignant transformation, but it's still, the jury is open whether it's the denosumab is causing or it's an association. Now that's again another publication that has emerged. So there's been a smattering of literature in terms of not only the diagnosis but from the treatment perspective about how much it helps. It can help in loss of the giant cells, but it doesn't remove the residual tumor cells. And it definitely helps in enhanced progression-free survival. So like I mentioned, it doesn't cure, but it enhances surgical amenability and definitely influences. So if we can combat the recurrences, we can anticipate that metastasis will be less in those patients. So a better surgery can influence overall and also progression-free survival. Now I'm coming towards a very interesting area, and I think this monument really, I feel, exemplifies the true essence of a round cell tumor. This is Maitri Mandir from Puducherry, and we're having our next cytocon there. I invite you all to be a part of that. And that's an example, again, a morphological nuance to something as Ewing's sarcoma, which is a chemosensitive tumor. We don't use the word PNET anymore because neither Eskin Rosai. So this is all a unifying concept of something as Ewing's sarcoma. And that's a monomorphic round cell tumor. In most cases, you can reinforce your diagnosis with MYC2, FLI1 positivity, and LCA negativity, because this combination can be seen in lymphoblastic lymphomas as well. So in a clinical radiomorphological context, this is good enough. But at the same time, we've seen over the period of time, Ewing sarcoma has its phases. So it can have rosettes, it can have atypia, it can have epithelioid appearances, including an adamantinoma like Ewing sarcoma. It can have sclerosis, when desmoplastic small round cell tumor can be differential in abdomen, clear cells. And that's what I was getting reminded when Dr. I mentioned about PS. I just came across a very clear cell rich Ewing sarcoma, and it was PS positive. This was a case referred as angiosarcoma because you see a lot of blood-filled spaces, but the cells are all monomorphic round cells. And all these cases, tumors were positive for the EWSR rearrangement or the EWS-FLI1 or fusion positivity. Rarely you can see spindle cells, but that's the time I always say that you need to think towards a BCOR rearrangement if you're seeing spindle cell nuance in an otherwise round cell morphology. So if you see several faces, you have to go further. And I think EWSR rearrangement is one thing. It's not specific. It's one of the most promiscuous rearrangement, but in a context, it helps. Everything helps in a context, clinico-radiological context. Something more specific will be the fusion if you demonstrate by RT-PCR or NGS, but again, it's been seen recently by the publications of, the contribution by Andrew Falk, my morphology guru, that you see this fusion in neurocystic tumor. So this is not 100% specific. Until this time, we were always calling EWS-FLI1 equates to Ewing sarcoma, no. So it's again morphology based, it's a clinical or radiological based context in which you utilize any IHC or any rearrangement or any fusion. 27 years old male with habits, and you can see this very basaloid to epithelioid tumor, underwent a maxillectomy and supraomohyoid resection, very, very basaloid tumor. So in head neck location, very easily you will think that this is, one of the basaloid carcinomas. It was positive for pankeratin diffusely, and so it was positive for the P63, which is a marker of squamous differentiation, and you would easily call this squamous carcinoma basaloid type. Of course, the head neck people like to employ NUT in a lot of these cases, and it was negative. And it was also negative for the other round cell markers, which this tumor actually was, kind of a round to oval cell tumor. So they just wanted to rule out, and it was initially thought to be, could be a carcinoma. Until we thought that, this is round cell morphology, and let's go further, and it was MYC2 diffusely membranous positive. This doesn't equate to a Ewing sarcoma, right? Because MYC2 we know is a very non-specific marker. So these are the situations, if you know the context of the site is head neck, you're seeing a round cell morphology, which is epithelial markers positive, squamous also, and now it's MYC2 membranous positivity, you need to go further. This was EWSR rearranged. This was an adamantinoma like Ewing sarcoma is what we thought, and it was reinforced as adamantinoma like Ewing sarcoma. Now it's taken a lot of attention over the period of time by Justin Bishop was described in head neck location. If you look at the history, Julia Bridge, the bone and soft tissue pathologist, I'm not just like saying, but she actually described for the first time 2 cases in, the long bones, and TB as a location for adamantinoma. So this was actually described, and now it's been seen that head neck is a very hot site for this tumor. I had this case, and I have to thank Dr. Sanjeev Shah, who actually shared this case, of this tumor coming in the calcaneum, very unusual site for adamantinoma, because you see a lot of keratin pearls, and you will very easily think, in bone, if you're seeing a squamous differentiation, it's adamantinoma or a metastasis of squamous carcinoma, until we threw in NKX 2.2, which was positive, and also it was positive for EWSR. One we published in Scalp Radiology is this as a adamantinoma like Ewing sarcoma in the calcaneum. So we've, in our study, including 20 to 30% cases of Ewing sarcoma, which can show epithelial markers, we were able to cherry pick 6 cases of adamantinoma like Ewing sarcoma, and my colleague in head neck went further towards identifying and describing these tumors in head neck location. Now, moving towards from the unusual spectrum of Ewing sarcoma is the context of more round to spindle cells in this particular example, and maybe more epithelial to rhabdoid in this example, but you have this background round cell morphology. It's always cytomorphology that kind of gives you the clue towards these unusual, rare or ultra rare suspects that I'm coming towards. Case A was called as synovial sarcoma because you see this round to spindle cells in the bone. If you see, well, one can easily think. In case 2, I call this as a malignant tumor after ruling out the usual suspects like rhabdomyosarcoma in a pediatric patient, which this patient was. And because you see this very epithelial to rhabdoid cells, and INI was retained, so I also ruled out a rhabdoid tumor. Now we have this habit of pigeonholing this as, Ewings or Ewing-like, which we have now come up a long way of not calling all these tumors until we are assured. Because why? Ewing's is a very chemosensitive tumor, so I always say we don't want to miss or mess out on this diagnosis, right? So we need to weed out the unusual or the ultra rare And this was my learning from these two very eminent people in group. That's Lars Gunnar Kindblom, Florian Puls, who pulled up actually one of the finest papers on the BCOR CCNB3 after contributions from the French sarcoma group, Gaël Piagon, who wrote the first paper on the BCOR CCNB3 positive sarcomas, and Florian actually pulled the first elegant study with this group from RH, Dr. Sumati and Dr. Lars Gunnar Kindblom. And then this is the fusion lady whom we all know, Christina Antonescu from Memorial Sloan Kettering, who actually worked phenomenally in soft tissue tumors, including the CIC rearranged tumors or the chick rearranged tumors that we call them. So case number 1 actually was again a MIC2 positive. You get tempted to call this as, could it be a Ewing sarcoma, synovial sarcoma? And then we did, as a part of the study with my student, Dr. Priyanka Kempavi, we went further towards, cherry picking or these rare tumors with markers like CCNB3, which still is a very specific marker, but it doesn't cover the entire spectrum of this BCOR. So this was further triaged for the RT-PCR and the BCOR CCNB3 fusion, that this tumor was a BCOR CCNB3 positive sarcoma. The other tumor that I mentioned, more epithelial to rhabdoid. So this is the MIC2. If you do, it's dot-like. I don't call this positive because it's a reactivity. I use positivity only if it is cytoplasmic membranous. But these tumors can also show that. So INI1 was retained because I was thinking, it could be a rhabdoid tumor in a pediatric patient. Rhabdomyosarcoma markers were negative, so it ruled out RMS, rhabdoid tumor. And then that's the time I start thinking towards, tangentially with markers like this. Of course, I don't have the most up-to-date kind of a good marker, ETV, which is good for these tumors. So calretin and WT1 nuclear positivity hints towards that this could be perhaps a CIC. And then we went for PCR. This showed this 230 base pair positive band, which is designed for type 1, one of the type 1 and type 2 CIC or DUX4 positive tumors. So this was a CIC or chick DUX4 positive sarcoma. And that's the publication we had in IJMR. Out of 50 cases, we were able to triage 32 cases for the PCR for these two rare to ultra rare fusions, and we had actually able to have 12 cases. So they're so ultra rare, and that's what Florian's paper mentions. If you see 24 Ewing sarcomas, then you will come across a 1 BCOR CCNB3 positive sarcoma. So we had these 12 cases, including the 7 chick DUX4 and the 5 BCOR CCNB3. And the chick DUX4 are really the most aggressive tumors. They are most in adult patients, soft tissues, and BCOR CCNB3 are more in pediatric patients, bone tumors, and most likely in tibial location. So if you're seeing a spindle cell tumor in tibia in young patient, which is round morphology with these delicate blood vessels, some myxoid chains, that's a clue towards, you're towards a BCOR rearranged or a BCOR CCNB3 positive sarcomas. We saw overall these tumors don't respond very well to chemotherapy because, like I said, that, still the jury is out towards what chemotherapy works for them. Somehow the BCOR CCNB3 are known to respond better to Ewing's therapy protocol, unlike the chick DUX4, which don't respond to either osteosarcomas or soft tissue sarcoma, or because again, these tumors have to be dealt with chemotherapy. They're high-grade tumors, so they don't respond to the existing chemotherapies. But there is still, so there are a couple of studies that are working towards, otherwise these nasty chemo-insensitive tumors. So that's our further contribution towards, the BCOR CCNB3. After these 12 cases in IGMR that we published, we collaborated with my good friend Kemal from Turkey, and we had these 12 additional cases of these ultra-rare BCOR CCNB3 positive sarcomas in IGSP, and we felt that BCOR is a good immunostain, but it is not a perfect surrogate for BCOR rearranged tumors, because you can see a BCOR rearranged sarcoma which is BCOR negative, and you can see a BCOR positivity in synovial sarcomas. So we need to know what markers are surrogates and what markers are useful for triaging. So BCOR C10 clone is good for triaging cases for BCOR rearranged sarcomas, but that's not a perfect surrogate. So these are additional 5 cases of the chick DUX4 positive sarcomas that we published in the Annals of Diagnostic Pathology, and that's one of the earlier publications that we had, as a part of the round cell tumor approach, if you want to read, with Dr. Jayashree, who is our current president, Dr. Asit from AIMS, that we wrote as a part of one of the, sessions that we were speaking on the round cell tumors, including the approach, differentials, and impact on treatment. And do we have time? I can, Dr. Shruti, I'm good with time, or I rush fast with these other entities? Yes? Okay. Should I go fast, or can I drop it now? What do you suggest? Sorry? Okay. couple of slides. I think I'll just go fast then. So this is a case very unusual of 34 years old male, clinical radiological diagnosis of osteosarcoma, understandable because you see this malignant cartilage. Until you spot this squamous differentiation, again, it's very unusual. And then we did these markers, epithelial markers, with the thought of this could be perhaps myoepithelial, and it was EWSR rearranged to brachyury negative, so it kind of resembled chordoma in some parts, and this was a myoepithelial carcinoma of bone. This took us further towards having these 5 cases, or 5 cases and more now we have seen of these myoepithelial carcinomas of bone that we published in the IAPM, and this just like the myoepithelial tumors in soft tissues, and then now we've seen it in bone, and 50% of these cases can show EWSR rearrangement. They will consistently be negative or brachyury, which is a marker for chordomas, and this was our first study that I did with Dr. Jambekar, my former colleague in TMH, and we had this 51 cases showing this very high specificity and sensitivity, again with due respect to Dr. Adrian Flanagan, who actually is the chordoma person, who, the brachyury chordoma person who will be coming for this coming conference. So this actually helped us, brachyury helped in, clearing the concept of parachordomas from chordomas, because parachordomas are myoepithelial tumors. They don't show brachyury positivity in contrast to chordomas, including chordomas in extra-axial sites, or even in now bones and soft tissues we are seeing chordomas, thanks to the marker, because the brachyury again is, I feel, one of the very useful markers on the littlest tissues. It helps to identify chordomas in all shapes and sites. So this was the spectrum of chordomas we had. Classic, chondroid, you can have dedifferentiated, now you have the poorly differentiated. That's an example of a dedifferentiated chordoma in the sacrococcyx location. You can see this very typical chordomatous areas and undifferentiated areas, the concept that we have of the chondrosarcomas. And you see how the markers align towards what you're seeing. Epithelial marker is nicely positive in the differentiated, so is EMA, S100, which won't be always positive in chordomas. Brachyury, again, it's sparingly negative in those sarcomatas. So this is one of the ultra rare types of chordomas. Coming towards this very interesting case of a 46-year-old lady with this pleomorphic tumor in the paravertebral location. It was called as metastatic carcinoma because it was positive for epithelial markers. Until if you know the entity, that's how you can diagnose. And it was quite in time that this poorly differentiated chordoma spectrum was evolving, and this tumor again was brachyury diffusely positive, and it shows loss of INI1 because you see this retained expression in the endothelial cells and the lymphocytes. So this is a very rare example, including of poorly differentiated chordomas, because they are mostly in pediatric patients, clival sites. So this was a very unusual case in the paravertebral location, 46-year-old lady, and that's our largest study of the poorly differentiated chordomas, including multi-institutional contributions from several experts from across the world. Again, this is a tumor. If you know it, then you can make a diagnosis. You can see this lesion we've seen this lesion in the fingers and also in the scapula. So these tumors can be diagnosed very easily as sarcomas, including rhabdomyosarcomas, because you see these plump spindle cells, including rhabdoid forms, and occasionally in bone they can show you the giant cells. And if you see it says a lytic lesion and these express A1, A3 positivity as well, you can call these very easily as sarcomatoid carcinomas until you know, and you're throwing in markers like CD31 or now ERG. So this is a pseudomyogenic hemangiodendrotheliomas, which can happen in bone, including multifocal sites. These have been misdiagnosed as rhabdomyosarcomas in soft tissues and very conveniently misdiagnosed as giant cell tumors, or even as metastatic carcinomas because they express A1, A3 until you know the entity. And you see this morphological nuance of these plump spindle cells, very rhabdoid looking, very hardly mitosis, and a lot of this inflammation scattering throughout the tumor cells. Again, we were always trained, the strap cells equates to rhabdomyosarcomas. Just look at this example of this A1, A3, CD31 positive pseudomyogenic hemangiodendrothelioma that we published as a part of our spectrum of these two cases. And that's again, apart from soft tissue, we can see in bone, and my friend Kamal, again, we collaborated for these 5 additional cases, and now you have FOSB as a marker for pseudomyogenic hemangiodendrothelioma, thanks to Andrew Falk, who tested one of our cases for FOSB, and you can see this marker in epithelial hemangiomas, osteoblastomas, and also in pseudomyogenic hemangiodendrothelium. So I have final takeaways for you that diagnosis of bone tumors, I circle back towards radiology, is very crucial as a part of your understanding and correct diagnosis. Morphology, I always believe, is the real the real morphology is the real in time. We need to be aware of the pitfalls. There are certain immunohistochemical stains which have really taken the forward, and KIX 2.2 for Ewing sarcoma. Again, not perfect. It's a good marker, not a perfect surrogate. BCOR, FOSB. The perfect ones almost are the G34W for giant cell and K36M for the chondroblastomas. We are now seeing more different specimens like ECRTs or post-linzomab GCTs, just to see how we can do best for the patients in a collaborative way. We have certain genetically defined tumor entities with certain morphological features, and in those also morphology is the triaging. It's not only a random NGS which the oncologists feel, or the IHCs which some pathologists feel. So it's all morphology. It's all in the morphology, and we integrate ancillary tests in a clinical radiological context. We're seeing entities which with the, again, so poorly deficient chordoma didn't come like that. It was evolved with immunomorphology and radiology, because radiologists can pick up those tumors in clival sites, even though we are seeing something epithelial. So that's again one of my favorite slides. We integrate clinical details, radiology, conventional IHC. We now integrate more molecular, and I have to thank all the colleagues with whom I work in molecular, my students, Priyanka, Vinayak, with whom we pulled out a couple of studies, my mentor and friend from Germany, Ulrich Vogel, from whom I learned the basics of molecular. And thank you so much. Be happy to take questions. Yeah, sure.
Questions we can take during the lunch. As we are running short of time, I invite you all for the group photograph before we proceed for lunch. Please.
Yes, please. Everybody come. सुनो, जाने से पहले फिर पिक्चर रह जाएगी तुम्हारी. तो अच्छा, you don't want. Okay. ठीक है. आ जाओ. Rest can come.
Kind attention, everyone.
Welcome back to the post-lunch session. Without any delay, for the next session, I invite Dr. Shantveer G. Upin sir, Professor and Head Department of Pathology at Nizam Institute of Medical Sciences, Hyderabad. His specialities include surgical pathology and hematology, with special interest in bone, joint, and soft tissue pathology, IHC, thrombotic, and hemostatic disorders. Sir is one of the founding members of and the current secretary of ABSTP. Sir will discuss about the osteogenic tumors of bone. ABSTP is the Association of Bone and Soft Tissue Pathologists.
Thank you very much. So, I know this is a post-lunch session. It is usually difficult to see that everybody is attentive, but I'll try my level best so that you are interested in the topic. So, coming to the osteogenic tumors, Bharat has almost covered many of the aspects of different bone tumors, but I will be specifically dealing with osteogenic tumors. If you see bone tumor classification in WHO 2020, before I proceed, how many of you are interested in bone pathology? Not many. Because every time when I go to these sessions, I ask, but hardly few hands will be there because I don't feel many people are so much tuned to bone tumor pathology. And I was somehow forced into bone pathology when I started as senior residents almost 2002, I think. So from there, I have been doing bone pathology regularly, and now I am passionate about it. So coming to the WHO classification, if you see, the same thing goes with soft tissue as well as bone. They are categorized basically based on their biological potential into 4 categories. One is the benign. In the intermediate, we have 2 categories. One is locally aggressive, intermediate, locally aggressive. And the second one is intermediate, rarely metastatizing. And of course, the malignant one. So the 3 categories have become 4 categories. So in intermediate, we have 2 categories. One, which is only locally aggressive, doesn't have metastatic potential. The other category is you have locally aggressive tumor, which has a small amount of metastasis, less than 2% of the tumors can metastatize to distant sites. So this is how it is classified. So as benign tumors, when you say benign tumors, it means that they don't have much local recurrence potential, but sometimes if it incompletely removed, they can recur. But usually these recurrences are non-destructive recurrences, and many a times, many of these lesions can be left alone, just surveillance, or sometimes if they are causing symptoms and problems, they can be excised or curated. That is how they are managed. Coming to the next category is the intermediate locally aggressive group, which is a locally destructive tumor but doesn't have a metastatic potential, and usually they are more recurrent compared to a benign tumor. Coming to the next category, I have already mentioned, this has a local recurrence possibility, also a chance of distant metastasis like a GCT and all. So less than 2% of chances of distant metastasis, and you have obvious malignant group which has a metastatic potential apart from the local recurrence. In the malignant group, we have low grade and high grade. The low grade ones have a 2 to 10% chance of metastasis, and higher grade more than 20% chance of metastasis. So this is how basically broadly categorize the bone tumor. The same goes well with 4 categories for soft tissue tumors as well. Coming to the bone sarcoma grading, Bharat has already covered just in the context of the bone forming tumors or osteogenic tumors. Here you have to remember the morphological diagnosis carries the grading in certain tumors, especially if you say a parosteal osteosarcoma, it is always grade 1. Unless it undergoes a high grade transformation, or earlier we used to call dedifferentiation, now we call it as high grade transformation, and low grade central osteosarcoma. So when you say low grade central osteosarcoma, it's a grade 1 tumor. Parosteal osteosarcoma, it's a grade 1 tumor. Coming to the grade 2 tumor, you have the periosteal osteosarcoma. So it's a grade 2 tumor, and the rest all osteosarcomas, whatever you call, whether a conventional, telangiectatic, small cell, a secondary osteosarcoma arising in the background of radiation or other causes, or a high-grade surface osteosarcoma, are all coming under grade 3 tumors. So it is very important, especially to identify the low-grade ones. Why? One is they can mimic benign lesions, can be mistaken. I'll show you some of the examples. And second thing is the treatment differs. Bharat has already told you, the low-grade ones don't usually receive neoadjuvant chemotherapy, and usually they are surgically removed, okay? And the ones which are high-grade, they either receive neoadjuvant chemotherapy, or sometimes they are resected first and the patient undergoes adjuvant chemotherapy at the later stage. So it is very important to know about these things. Coming to certain tumors where there is a variable grading, it is not just by morphology. If you say leiomyosarcoma of a bone, you have to grade it. Here you have to additionally qualify with a grade. Same thing holds good for conventional chondrosarcoma. Chondrosarcoma, we say grade 1, grade 2, grade 3. Say their grading number is required, qualifier is required, but other tumors you can just say parosteal. You don't have to say it is grade 1, because it is already means that it's a grade 1 tumor. Same thing for a malignancy developing in a giant cell tumor, which can be a low grade 1 or a high grade 1. So this is how we need to remember. Coming to the osteogenic tumors proper, among the 3 groups, there are 4 groups, there are 3 fall into this. One is benign, that is we have an osteoma and osteodostomas, and intermediate, that is locally aggressive, but it usually doesn't have a metastatic potential, that is osteoblastoma. Of course, the malignant one is the osteosarcoma, okay? Coming to the examples, these are examples of osteomas. If you are having a lot of neurosurgeons or plastic surgeons, you may get some of these biopsies for your histopathological examinations, because they usually removed for cosmetic purpose. They don't have much problems. Usually they are removed, or sometimes if they occur in critical locations like the one which was infiltrating into the sinus and all, they may cause some symptoms. And these usually consist of a compact bone, and these compact bone, which is very dense bone, will be there. Sometimes it can be a spongiform bone also, and usually some of these may be associated with certain syndromes, okay? And more often seen in craniofacial skeleton. And that's what you find. And maybe sometimes an incidental finding detected, and sometimes they can occur in long bones as a intramedullary bone islands. A dense bone island may be there, and that may be removed, and that may show this morphology. These are benign bone forming tumors. Coming to the next group, I mentioned osteodostoma. Earlier we used to get osteodostomas for histopathological examination. It has become less because of the RFA. Now most of the time, if a radiologist is sure that it is an osteodostoma, clinical things go well with that, they usually directly go for radiofrequency ablation, and usually you may not get a biopsy specimen for histopathological diagnosis. But I do still get once in a while, because if they are presenting with atypical things. One thing you have to remember is radiologists sometimes can mistake an osteodostoma versus a Brody's abscess. Both are cortical, and they can mimic clinically as well as imagologically. So one may be mistaken for other. So that also happens in the practice. What is the difference between osteodostoma and osteoblastoma? Morphologically, if you see for a pathologist, most of them look similar, and there may be subtle differences between an osteoblastoma and osteodostoma, but morphologically they are similar for all general purpose. And it is the differentiation even on imaging and clinical grounds is based on the size. If the size is less than 2 centimeters, they usually call it as an osteodostoma. If it's more than 2 centimeters or equal to 2 centimeters, it's an osteoblastoma. The other different thing is, usually these osteodostomas are cortical based and usually affect long bones when compared to osteoblastomas. Osteoblastomas, I personally see more often in a vertebral column because we do have a good neurosurgery setup. So we do see a lot of vertebral lesions, and also other bones also we can get it. Another distinguishing feature is pain. Pain which is relieved by analgesics is a classical feature of a osteodostoma, whereas in case of osteoblastomas, pain will be there, but it doesn't get relieved by analgesics. These are some of the things which one should be aware of. And if they occur in spinal locations, they can cause scoliosis, back pain, and all other things. And sometimes what happens is these osteostomas can occur in the ends of the bone very close to the joint. In such cases, they clinically mimic monoarthritis because they produce irritation of the synovium and produce joint effusions where they are located, and the patients may present as if there is a joint pathology, not a bone pathology. Okay? So these are the examples, different examples of osteostomas, various locations I have seen, including the classical one is this, which is proximal femur cortical base lesion. Here if you see, CT brings it very nicely. Especially the CT cuts have to be taken, very thin slices have to be taken because these niduses can be very, very small, tiny. If you see this cortex is thick here and there is a lucent nidus there. Sometimes it can be targeted also. Central portion may be dense, again a lucent area followed by again a dense area. So that morphology is also possible, and these are some rare variants where it was epiphyseal in location and in a finger bone. Here you see this is a targetoid lesion where you have a central density followed by lucency and again a ring of density. So that is also a radiological finding in a osteoblastoma. And these are osteoblastomas, little bigger lesions, vertebral location. This was another which was very destructive lesion here involving the proximal femur. This is the other one which is here. Just it may be a density. Sometimes nidus may not be picked up by the radiologist. It may be just cortical thickening. So based on the imaging, it may not be possible in such situations unless they give for CT. So morphology, if you see, it will be just interconnecting trabeculae of bone, and in between these bony trabeculae, you will find a vascularized connective, loose, vascularized bland spindle cells, and some vascularity, some osteoclastic giant cells will be there. There will not be much atypia or mitotic activity in these tumors. If you go to the closer view also, if you see some osteoclastic giant cells, vascularized fibrous tissue, and interconnecting bony trabeculae. This is one of the examples I wanted to just show you. This patient was a 25-year male who presented with pain and swelling and stiffness of the right wrist of 5 years duration. He was continuously having pain, visiting several physicians, not getting relieved. Biopsy was done for this patient from the wrist joint, and it was reported as non-specific synovitis. And his pain, with all whatever antibiotics he received all analgesics, but the pain was never getting relieved for this patient. And these are the biopsy, synovial biopsy fragments which were seen. And if you see that there is a lot of crushing artifacts, there are vessels, some inflammatory cells. I'll show you closer. These are very tiny fragments. This is the synovial lining. You can see little loose fibrous tissue, some lymphoid aggregates around the vessel. Same thing, no granulomas, nothing. It was given as a non-specific synovitis. This went on for 5 years. The patient was not getting relieved of pain at all. What happened is then we found a small lesion in the scaphoid bone, and that was biopsied. And you see this is again showing edema, some inflammation. What we found was this was the nidus. You see this irregular bony trabeculae and these osteoblasts. Closer view. You see this? These are all osteoid here, and these are all osteoblasts, plump osteoblasts which are there. And this was an osteoblastoma which was causing inflammation of the adjacent joint, and every time the clinicians and even on radiologists were thinking that it was a arthritis of the wrist joint. 5 years. Once this was done, the patient was relieved. He was so happy. Even after biopsy, sometimes what happens, even just a biopsy releases the pain of osteoblastoma. You don't have to remove the entire thing. So after this biopsy, the patient was totally well. So these things can happen, especially if it presents at an odd location. So this was a case of osteoblastoma. These are the photographs of osteoblastoma. Again, similar bony tubercle, but here the cells look little busy. No, there are more osteoblasts in between, and again those loose connective tissue may be there, and osteoclastic giant cells may be prominent. This is a closer view of showing this osteoid formation, osteoclast, plump osteoblasts. Sometimes osteoblast can look very epithelioid also. And that may be their morphology in these tumors. Some mitotic activity may be seen, but usually atypical mitosis will not be there. And osteoblastomas are prone to have ABC-like changes in the most commonly, especially vertebral lesions. It becomes a difficult because vertebra is also a common site for primary ABC. So whether it is a primary ABC or an osteoblastoma with a ABC-like change, that is an issue in some situations. And osteoblastoma, as we know, it is always a problem sometimes if the differential is between osteoblastoma and osteosarcoma. It is always a problem, and here you need a lot of clinical information and imaging information, especially if you are diagnosing it as small biopsy. It becomes at times very difficult, and you have to go with permeation which may not be representative in your small biopsy which you have received, and look for atypical. If a few normal mitotic figures doesn't make it an osteosarcoma, but if you find really an atypical mitosis or a chondroid matrix is very unusual in a osteoblastoma, but it can happen. It is not that it is against, but if you find a osteoblastic looking tumor with areas of chondroid matrix, think of osteosarcoma, because usually that is more common than an osteoblastoma having a chondroid matrix. And also look for any atypical mitosis and obviously your radiological findings. These are the things you have to do. Now, we know that there are osteodastomas and osteoblastomas. We know that they are morphologically related, but now we know that they are also molecular genetically related. Both of them show FOS and FOSB rearrangement, and FOS antibody and FOSB antibodies are available. You can use it. We just started using it in our lab. So this is one of the case of osteoblastoma showing those nuclei, and usually this will help in differentiating osteosarcoma. Osteosarcomas don't show this FOSB or FOS. FOS is more common than FOSB, and FOSB is seen in a subset of cases. And if you have this antibody, this may be helpful in differentiating a osteoblastoma from a osteoblastoma like osteosarcoma. Okay, but the best thing is to test for rearrangement. If you have the IHC, you do it. Okay, we are now studying the utility of this in differentiating these two entities in our one of the student thesis. Coming to the osteosarcoma, what has happened in WHO 2020? There are certain changes that have happened. In 2013, what we used to call separately as conventional telangiectatic and small cell, they are together now kept under osteosarcoma, not otherwise specified. They used to be individually separately categorized. Earlier we used to have conventional separate, telangiectatic and small cell as types, but these three are brought under the umbrella of osteosarcoma, not otherwise specified, because they behave similarly and they have similar prognosis. And as far as the surface osteosarcomas remain as it is, that is parosteal, periosteal and high grade. They are the three surface osteosarcomas. And you have a low-grade central osteosarcoma at the top, which remains. And another thing is, earlier secondary osteosarcomas were also considered under conventional osteosarcomas, but now they have been grouped separately. And these include osteosarcomas arising in a Paget disease of the bone, radiation-associated osteosarcomas, infarct-associated, those associated with implant and all osteosarcomas, they are called as secondary osteosarcomas. One more slight change has been, instead of radiation-induced osteosarcoma, they are now called as radiation-associated. They just want radiation to be implicated directly. They just mellowed down or sobered down the terminology so that people will feel that tomorrow that radiation has resulted in osteosarcoma. So, a subtle change in the terminology which has been adopted in the 2020 WHO. Coming to the osteosarcoma, we know it's the most common malignant tumor if you exclude metastasis and myeloma, and most of us, I think, we come across osteosarcomas. But though it is the most common, it is one of the most problematic tumor as well because of its wide morphology, and by day we are getting smaller and smaller biopsies, and that makes life difficult. And especially if you are not practicing bone pathology routinely or seeing cases of bone pathology, it may sometimes difficult. And everybody has, since morning, has reiterated that radiology is very important. But once again, I want to tell you that I don't report my cases without seeing radiology. Almost 99% you can say that every case of mine, I see the radiograph myself. And my residents are supposed to bring, when they go, when the case comes, they are supposed to bring radiographs when they are coming to reporting for me. So we review the radiographs together, and then we discuss the pathology aspect. Every day we do this exercise. So radiology will be reviewed by ourselves. Though radiologist has given whatever diagnosis, but I personally take care that all the radiology cases are seen by ourselves, and also we store these images with us so that we have images from 2000 onwards, everything stored, every case images stored in our lab. So that is how we follow, and this will really help. I am telling you, radiology will help a lot. And it is like you are seeing a gross specimen in front of you. You have a small biopsy, but if you want a gross pathology, that is what is there. Radiology is a gross pathology for you without having specimens in her hand. So if anybody is interested in pursuing bone pathology, you start learning radiology. And I am sure after 10 years, you will become as good, if not better than radiologists, you will come very close to them in making a diagnosis, okay? So that's how, I just wanted to stress that. And you know that majority of these osteosarcomas occur in long bones, and distal femur, and most of the bone tumors, especially if you see around the knee, most of these tumors are located. And small proportion can affect the craniofacial skeleton, pelvic bones, and small bones of hands and feet. Majority are metaphyseal in location, but you have to remember osteosarcomas can involve diaphysis, and epiphyseal involvement, I have seen a few cases, but it is rare. And clinically they present as just a painful mass. Why it is not moving? Okay, so since morning you have seen similar images of osteosarcoma where you have a destructive lesion, usually large, because our patients come at a later stage. Most of the patients will have a huge tumors, which are very destructive tumors, and usually has a mixed lytic and sclerotic pattern. And usually most of the tumors they break through the cortex and have a soft tissue component by the time they present to us. And these are the examples of unusual locations of osteosarcoma which we have come across. If this was a chest wall mass, osteosarcoma, see the PET scan, how brightly it is taking up. This was a mandibular tumor osteosarcoma which is there here. You can see this. These are some of the gross specimens of osteosarcoma. If you can see the cut here, it is a growth plate here. It has not crossed the physeal plate. The epiphysis looks uninvolved. This is the entire tumor up to here. From here you can see the normal marrow, and this is breaking through the cortex and coming out, and this is a periosteum which is lifted, but it has not breached. So this was the chest wall tumor which I told you. These are the ribs, and this is a tumor which is protruding through the pleural surface. This is all shiny thing is all pleura which is producing this, and this is the cut section of that. So coming to the morphology, you know, we used to traditionally call osteoblastic, chondroblastic, small cell, and all those things based on the morphology of the cells. And you know that they are all grouped under conventional osteosarcoma except for describing the variants which I have already told you. The chondroblastic osteosarcoma has a typical this chondroid matrix with high-grade nuclear morphology, and always a problem to differentiate a chondrosarcoma from chondroblastic osteosarcoma. I'll tell you how it can be done. So these are the some of the images of a classical chondroblastic osteosarcoma. Some osteoid formation is also evident here apart from the chondroid matrix. This is the other areas of a chondroblastic osteosarcoma showing typical chondroid matrix, those epithelial looking cells, plump spindle to polygonal cells, showing ATPM mitotic activity. One thing is we usually, especially if it is an old patient, we think of chondrosarcomas, and usually younger patients, chondroblastic osteosarcoma. This is the beginning thing. But we have seen cases of chondrosarcoma occurring in young patients. The same is true for older patients having osteosarcoma. If not primary, they can have at least secondary osteosarcomas. So, but in general, if you are seeing a tumor in a younger patient, it's more likely to be a chondroblastic, whereas a older patient, it's a chondrosarcoma. That is one thing. And majority of the chondrosarcomas, if you see, are grade 1 and grade 2 tumors. Grade 3 chondrosarcomas do occur, but they are less in number. But if you see osteosarcoma, chondroblastic osteosarcoma always has a high grade morphology, grade 3 morphology. So if you have a grade 3 morphology, then only it is a problem. If you have a grade 1, grade 2, less likely to be a chondroblastic osteosarcoma. That is second thing which you have to consider. And third thing you have to do is, when you are looking at the chondroid lobules, if there is a piling up of the cells at the periphery, that is more likely to be a chondroblastic osteosarcoma. In chondrosarcoma, that piling doesn't happen. These are subtle things which you go on experiencing, looking at things, you will get to know. And of course, if you have a classical look for areas of osteoid matrix formation, and that is a standard thing you have to see extensively and look at the radiology findings, correlate with clinical findings, all these things come. But these are the things. And now with IDH1 and IDH2 mutations, which can be done, which we are now started doing in our lab. If IDH1, IDH2 mutations are present, then it is usually chondrosarcoma, because chondroblastic osteosarcomas do not show IDH1 and IDH2 mutations, but they may not be present in all the cases. If it is negative, it is again a problem. If it is positive, it is helpful. Okay? And another thing is, some of the neuropathologists maybe here, they do a marker IDH, but that IDH is R132H, I think. In chondrosarcomas, it can be R132H, but is more common is R132C, for which antibody is not available. So the antibody which you use for your brain tumors cannot be suitable for doing in chondrosarcomas. So now we have started doing mutation by RT-PCR in such cases wherever we have difficulty. Okay? But majority of the time, I don't require. A few situations where this age is in that range of between young and old, and morphology is not very clear, such cases, or a high-grade looking tumor without proper areas of osteoid and all, such cases, we can go for this marker. This is a classical osteoblastic morphology of an osteosarcoma. You see sheets of osteoid formation with cells within that, entrapped within that. This is other area which is almost looking like an osteoblastoma, this plump epithelioid looking tumor cells, and a lot of ATPR, mitotic activity and all. So these are some of the examples where it is an osteoblastic variant of atypical mitosis also you can make out. This is a atypical mitosis. Always hunt osteoblastic looking tumor, look for mitotic activity, areas of necrosis, permeation, and atypical mitosis. That is help in differentiation if you have a differential of osteoblastoma. Okay? Then this is a typical fibroblastic looking, almost like a spindle cell sarcoma. You have to look for areas where there is a matrix formation. And of course, these are some of the examples of small cell osteosarcoma, where the cells are very uniform, round looking, but there is a lot of matrix formation. There are areas of myxoid matrix. Here it is a osteoid matrix. Here is. They are all round cells, uniform looking, not the typical atypical cells which are pleomorphic, those cells of a routine osteosarcoma, but they are very round cell and lot of matrix formation within that. And that, the other one is again a round cell, but chondroid matrix. So that can be confused for a mesenchymal chondrosarcoma Bharat was telling about. So these things can happen. This is another case of small cell osteosarcoma. SAT-B2 Bharat was telling that it comes in various, we have already done one study and published also, but in certain context, it will be useful. So if you ask me, do you use SAT-B2? I use in certain situations. Ewing sarcoma, I have not seen it showing to be positive. So if I have a differential of an Ewing's versus an osteo, small cell osteo, and it comes positive like this, I will go for a small cell. Apart from that, we do fish and all those things different. But in certain context, it is helpful. And even in chondroblastic osteosarcoma versus a chondrosarcoma, grade 1, grade 2 chondrosarcoma, I have not found so much intensity and percentage of cell positivity for SAT-B2. But some of the grade 3, which is the differential for a chondroblastic osteosarcomas, can have, and chondroblastic osteosarcomas can have a lesser SAT-B2 also. That makes it difficult. So those things you have to remember. And this is if you want to go to the details of which entities we have studied, what is the percentage, everything. So we have done on all the variety of bone lesions, including reactive conditions, this SAT-B2, and tried to analyze where it is helpful and where it is not helpful. It was showing positive in majority of other lesions also. But if you go by the intensity of staining and a percentage of cells, you may help getting the correct diagnosis in certain situations. That you have to remember. This is another interesting case. If you see a patient has a lesion, is around 42 years, male patient who had a very destructive lesion involving the lower end of tibia, okay? And this was reaching up to the articular cartilage, end of the bone. What are the tumors that occur in end of the bone? Epiphyseal tumors. Giant cell tumor, chondroblastoma, clear cell chondrosarcoma. Agreed? Metaphyseal, most of them are metaphyseal. Diaphyseals are, you know that, they're Ewing's, adamantinoma, and some of the fibrous dysplasias and others. Okay. Metaphysis, most of the tumors. Epiphyseal, these three are very important. This was epiphyseal looking tumor, very destructive looking tumor. In a 40 years, this is the morphology. What is it? Huh? Epiphyseal, GCT. Both are GCTs. There is difference in these two. Here the cells are little, giant cells are little small. There the cells are big. Is there a difference now? See, one thing I always teach my students, in a giant cell containing lesion, don't look at the giant cells. You look at the non-giant cell component. You ignore the giant cells, look at the non-giant cell component now. What is the difference? Where are these? You see in this? All look similar. Don't look at the giant cells. That is, every giant cell containing lesion, don't look at the giant cells. Look at the non-giant cell component. Then you will not make a mistake. Okay? See the atypia here, mitotic activity. Agreed? I'm going little slow because juniors are there and it's a post-lunch session. It will be. So you see the atypical mitosis. Agreed? They look similar. If you see the giant cells, they look similar. Bland-looking giant cells. They are not atypical. They are not mitotically active. They are reactive population. They are not the neoplastic population. The neoplastic population is the non-giant cell component. Okay? So this was a GCT, that was a giant cell rich osteosarcoma, which was mimicking a GCT even on imaging because it was reaching up to the end of the bone. Age was around 40 years, which is a GCT age. Okay? Giant osteosarcomas are 20s and 30s. So you can have unusual presentations. You have to remember this. What I do now, again, just to confirm, because we know that it is definitely, we took more sections. If you see more sections, you found chondroid matrix, lacy osteoid matrix, atypical mitosis, necrosis. So you need to gross more, look at the other areas. We may have a typical areas. And if you have this marker, we do regularly for all the giant cell rich lesions in our department now. So this is a GCT, which will be positive, mononuclear. It doesn't stain the osteoclastic giant cells. It stains the nuclei of the mononuclear cells, 3.3 G34W. That is negative in that giant cell rich osteosarcoma. That is a very useful marker in this situation if you have a differential. It also helps in differentiating with other giant cell containing lesion. These are already, Bharat has shown you some of his publications. We also did a largest study on histone marker in both giant cell tumor as well as chondroblastomas. And these are our two publications on that, where we have shown the utility, sensitivity and specificity of these two markers, one for giant cell tumor, the other for chondroblastoma. So these are very, very useful and very specific marker, okay? That can be used when you have a difficulty. So this was the story of an unfortunate child, 13 years old male who presented to an outside hospital in 2009, okay? If you see, there is a very large destructive lesion, almost the entire cortex has gone in the bone here, okay? So these are the CT and MR images of this patient. What is this? Fluid levels. Why it happens? That is one thing peculiar. Have you heard, like, whenever there is a blood in any of the outside the vessel, it should clot. Agreed? But in aneurysmal bone cyst, it doesn't clot. Okay? What happens is, whenever the patient is lying on a dependent position and imaging is done, the solid portion settles down, that is the darker portion, and there will be a straight line like this, above which there is a fluid. That fluid is bright. So it gives that fluid levels. So it is usually a feature of aneurysmal bone cyst and telangiectatic osteosarcoma. Okay? These are the images of that. What happened? This biopsy was done. They reported it as aneurysmal bone cyst, and they placed this plating and did some surgery. Then he presented with 2 nodules. See this? Soft tissue nodules in that area. These 2. Then they removed this plate. This nodule is again there. That slide was sent for review for us. If you see, again, cystic spaces, blood-filled cystic spaces, separated by septae. But if you don't see the septae, and if you don't see the cells within that, you will make a diagnosis. And many of the things I am telling you, general pathology work, people who do and who are not aware of bone pathology, make mistake of an aneurysmal bone cyst. Bharat has already told you, as either osteosarcoma as aneurysmal bone cyst or either ways, and that is a catastrophic thing for a patient. And this happens. This is one area where pathologists can make a gross mistake. And this happened in this case. This same slides we are reviewing, we know that this can happen, and see those areas, they missed all those atypia and all these things here. They were just might have concentrated on those septae and these giant cells which look bland. The other areas should be looked for, these areas here. And it was telangiectatic osteosarcoma, which was the patient has to undergo entire disarticulation. That child has to undergo because of the wrong diagnosis. You see now, this is a specimen, all hemorrhagic cystic mass. And again, this, when you see this, it is now becoming more aggressive looking, very bizarre looking tumor, which was misdiagnosed. And this often happens. And especially in small biopsies, we have to be very, very careful. Here, radiologist can make a mistake and pathologist. So radiology may not be helpful. It may be sometimes misleading. So you have to be careful. Always have in that mind that am I missing a aneurysmal bone cyst for a telangiectatic or a telangiectatic for a, always have that in mind so that you look at it carefully and avoid this grave mistake. And it happens, and it is in reality, I am just telling you. These are this was a case of telangiectatic osteosarcoma, maybe misdiagnosed as ABC. That's what I wanted to highlight. And in one of the studies, they showed that almost 9 out of 26 cases were misdiagnosed and for these tumors. Coming to the next case, this was a lesion in a 32 years male, I feel. So this was a lesion which was looking very aggressive on imaging. You see, almost coming out, and even on the MRI, the lesion is infiltrating out. See this morphology? Radiologically, it is looking aggressive. Morphology? If you see, it looks like a very bland looking morphology at a scanner view, but if you see this, look for isolated cells with atypia, isolated cells with mitosis. This, especially if you have a fibro-osseous lesion looking like a lesion, then you look for this. Otherwise, you'll make, and the bony trabeculae also, you will not find those classical lacy bony trabeculae which you see in a routine osteosarcoma. It looks almost like a fibrous dysplasia or a desmoplastic fibroma or something like that. So, but always look for those isolated, scattered, atypical, hunt for them. And we now regularly do CDK4 and MDM2 on this. This MDM2 was only scattered cell positivity, but CDK4 was positive. And luckily, this image was looking more of osteosarcoma. It was not looking like a routine fibro, but these central low-grade osteosarcomas can look very benign on imaging also. So both ways are possible. It will look imaging aggressive, but bland morphology. And this, at the same time, both morphology on histopathology as well as imagologically, it may look like a benign lesion also. That makes a lot of difficulty in making a correct diagnosis of low-grade central osteosarcoma. This was a low-grade central osteosarcoma. Okay, these are intramedullary lesions. I have already mentioned they are considered as grade 1 tumors. Uncommon, 1 to 2% of all osteosarcomas, usually common in distal femur and proximal tibia, usually occur 1 decade later than the routine conventional osteosarcomas. As I have already mentioned, they can look aggressive imaging wise, but some of them can be imaging wise very well circumscribed. When they are well circumscribed, your radiologist will not guide you to say that it's an aggressive tumor. There it becomes a problem. If a radiologist say, I am looking at an aggressive tumor and you are seeing a very bland looking tumor, you are at least alerted. But when this combination doesn't happen, you will be in a problem. Okay? You have to be aware of. I have told you, it can be very hypocellular looking tumor, and sometimes it may mimic other bone tumors, like even those bony trabeculae can be curvilinear like an fibrous dysplasia, or it can be just like a parallel seams with spindle cells looking like a desmoplastic fibroma. So these are the differentials: fibrous dysplasia, desmoplastic fibroma, and a low-grade fibrosarcoma if it is there. This is another example. If you see, it is classically a surface lesion. The lesion is located on the surface of the bone. Agreed? One more thing you have to appreciate is, can you make out? There is a lucent line here between the cortex and the mass. That is also important. That lucent line you will find in a parosteal osteosarcoma. In a periosteal osteosarcoma, that lucent line will be not there because it will be directly sitting on the cortex. So if you have, it is useful, and very dense looking mass. It will be like that osteoid matrix, no? The dense cloudy mass sitting on the, and most common location are distal femurs, either on the posterior aspect or the anterior aspect. So these are the other examples which we have. See, this is a tumor sitting on the bone, but on the PET it is showing a uptake. So this almost like another bone, cortex, a bulb of cortex sitting on the, it is a CT image. So it will be very dense, radiodense, hard mass sitting on the surface of the bone. This is the classical location. You remember, a tumor sitting on the posterior aspect of the lower end of the femur in a slightly 30, 40 years of age, you have to think of this possibility. Otherwise, it may be misdiagnosed, especially. This is a resected specimen of one of the cases of parosteal. If you see, this is the cortex, and the tumor is sitting and pressing the cortex inside. Almost this has come inside, it has not yet infiltrated. So this is all the mass which was excised. And one more problem for pathologists, sometimes it can look like an osteochondroma. It can have an actual cartilaginous cap. And there it becomes a difficulty whether you are looking at an and radiologist can say it is a sessile osteochondroma on imaging. That is also a possible. So, but these cartilaginous islands are haphazard. Normally that columnar arrangement which you see will not be there. And normally in osteochondroma, what happens? You have a perichondrium, you have a cartilaginous cap, then you have bony trabeculae, and that bone cartilage junction shows enchondral ossification, and in between the trabeculae of the bone, you will have fatty marrow. Here you will not find a fatty marrow, you will find a spindle cells. When you have that morphology, you start thinking whether I am looking at this possibility. Okay? These are some clues I am just suggesting how it will help. See, these are the spindle cells. They are very bland spindle cells, almost looking like a reparative fibrous tissue in between the bony trabeculae. Okay? Again, look for any scattered atypical cells. See, this area, if you look at it, almost look like a fibrous tissue. You can't suspect a tumor in this, but there are occasional ones here. I don't expect in a normal reactive fibrous tissue such hyperchromasia of the cells. Look for subtle features like that. Okay? Again, we did CDK4. It was not very intense, but scattered cells. Sometimes it can be very scattered cells also. Now we have started doing amplification also in these cases. Okay? And this is another case. We do see quite a few of parosteals. This here, it is infiltrating into the medullary cavity. This is a excised specimen. Sometimes we used to take specimen radiographs. Sometimes before cutting and taking sections, we take the specimen and send it to radiology and take a specimen radiograph. It helps us in grossing, and sometimes we do that also. This was a specimen radiograph of the case. If you see this, Here the cortex is intact, suddenly the tumor has broken inside and it has come inside. So parosteals can also infiltrate inside the medullary cavity. This is a recent one, just 2 days back I saw. This patient was operated 3 years back. I only reported it as parosteal. Probably surgical excision was not very clean. And this patient now presented with these nodules around this prosthesis. This is a megaprosthesis. This was resected actually. And this is the solid, like almost bony tissue sitting on this prosthesis. This is a recurrent one. And whenever there is a recurrence, you also have to look for whether high-grade transformation, but it was not high-grade transformation. Again, you see, it looks like a fibrous dysplasia. This side, that Chinese letter, if you want to classically describe, this is like a fibrous dysplasia. Agree? You agree? And these are real cases. I am not making up the cases. This is just I've seen 2 days before. And these, if you see, hardly any atypia. Even those single isolated atypical cells are not there in this. What was clue is, you see this? There is, in between those cells also lacy osteoid has started forming. You may not find in every case, but this matrix is there. These are the main bony trabeculae. Here you have a lacy osteoid between this. Obviously this case was very intense positive. I didn't have a problem. The MDM2 was positive. And some of the MDM2 clones are not very good, and sometimes you are doubtful whether it is correct or not. So if you have fish, you can go for fish. We do fish for these things. I don't have the image of that. So this case was, since it is a known case, already reported earlier on IHC, again same thing, and recurrent mass. So we gave it as recurrent parosteal osteosarcoma without evidence of any high-grade transformation. Earlier we used to call as dedifferentiation. Now we need to, but better terminology is transformation, because it is osteosarcoma becoming higher grade, not osteosarcoma becoming some other tumor. So that's why dedifferentiation is not a correct terminology. High grade transformation is a better one. When it becomes high grade, again it becomes a grade 3 tumor. Agreed? Okay, this was also those cells where spindle cells, just we did SADB2, that those spindle cells were also intensely SADB2 positive. Ki67 you see, hardly anything. Hardly any proliferation, though it is an osteosarcoma which is recurrent, okay? This is another example of a surface tumor. Here it is more myxoid and chondroid looking tumor with little atypia and all, but not as atypical as a grade 3. So this was a periosteal, and periosteal osteosarcomas are grade 2 tumors, higher than parosteal, lesser than conventional. So it has that morphology. And they're usually chondroid, more often chondroid looking tumors, diaphyseal in location. Sometimes they may encircle the entire bone also. So these are the things one should be looking for. These are already given in your textbook. Just to say that the parosteal, 70% of them occur in distal posterior femur. That is one of the important location. And these can also undergo high-grade transformation, 15 to 20% of the cases. Okay? Whenever there is a fleshy area, apart from that, usually a parosteal on a gross looks very solid, bony tissue. It is very difficult to cut also. Without decalcification, you can't even see the morphology. But if you have a soft, fleshy areas, apart from this hard looking, those are the areas where you will find a high-grade transformation areas. That you should gross them so that you don't miss those things. And I have already mentioned MDM2 and CDK4 amplification. Actually, some of the people believe that even the conventional osteosarcomas which show this MDM2 and CDK4 are actual high-grade transformation of a low-grade central osteosarcoma rather than them being conventional osteosarcoma from the beginning. Okay? So if you start studying MDM2 and CDK4 in all your conventional osteosarcoma, you may find percentage of tumors which are MDM2 and CDK4 positive, and those may be actually started as a low-grade and then developed as a high-grade transformation. Agreed? So this is an example. I'll now show the recent one. This patient had in a 15 years male child, 6 years back, had an Ewing sarcoma, diagnosed and treated with chemoradiotherapy. Now came with a lesion in the proximal humerus. There he had, and now they thought that it is a recurrent tumor, and it turned out to be a radiation-associated osteosarcoma which developed in. Now it is not, this is the current one. This is not Ewing's. That was an Ewing's which we had diagnosed. It was proven Ewing's, and patient received chemoradiotherapy. Now in that same location, I have seen several of these cases of post-radiation treated for Ewing's, or in pelvic tumors, especially a female has been treated for cervix, carcinoma cervix, for radiotherapy, and there is a huge pelvic tumor, and that is an osteosarcoma. So these things are undifferentiated pleomorphic sarcoma. That is possible in this. So this is another example of patient who had a calf soft tissue Ewing sarcoma. And if you see, there is a thing here. This was here where the radiotherapy was given. Entire limb was given radiotherapy. This was the initial tumor was in this portion of the muscle, and there is some changes in the marrow. Now patient has developed one more tumor at the, and that was an osteosarcoma. So you have to remember that it is a reality that radiation-induced osteosarcomas or radiation-associated osteosarcomas do occur. So history is very important, that you have the proper history of a patient receiving radiotherapy in that field so that you can make a diagnosis. This Bharat has already told you. I will not go into the detail, especially for therapy, post-neoadjuvant therapy, osteosarcomas, you have to follow this protocol. Every case, you have to map it. This is how we do, and put them in proper cassettes, and then you assess the percentage of necrosis. So that is very important. And always try to do is, to assess the actual percentage, you try to keep your size of those blocks equal. Otherwise, what happens if you have a variable size, your percentage may not be very accurate. Try to keep as close to each other size as possible so that your percentage calculation becomes easy. That's how our residents do regularly. Now it is in and out. Every week we get several cases, and these are done routinely. And it is very important you have a proper bone cutting saw for all these things, because once they are treated, they become very dense, and it is very difficult to do it by manual methods. So this has, Bharat has already shown you examples. Entire tumor disappears, very good response. These are all things which may remain. And this is, we had done one study on post-radiation changes in osteosarcoma that we have published on this. So with this, I conclude my talk on osteogenic tumors. This is our organization where people who are passionate about bone and soft tissue, we have formed a group. Now it's a young organization, but I welcome people who are interested to join us so that we can take this organization forward. Okay? This is our website, which is live. You can go to the website and apply for it. And this is the first biennial conference we are organizing in Hyderabad. It's a one-day workshop, 1.5-day conference, where some of the good international experts and almost all of the national people who are members of this organization, as well as who have passion and interest for bone and soft tissue, will be attending this meeting. So I invite you to Hyderabad for this meeting. Thank you. Any questions?
Any questions from the audience?
Yes, please. Anyway. Yeah. What I am doing now, actually, I recently submitted my paper on this. What we did is we analyzed all, right now we analyzed almost more than 350 GCTs with this marker. And in that I found around 35 cases which were morphologically I thought GCT, but they were negative for this marker. Then what we did is we extended the marker panel. Now R is available, V is available. Especially neuropathologists use R and V. So that marker, because my better half is a neuropathologist, I borrowed that antibody from her and did the test. And I found some of them were V and R positive. V is more common. The next common is V. Then some are R, and these two, L is not available. There is L also and methionine also, M is, these two antibodies I don't have. So now I have started doing sequencing, and I have found some cases where sequencing came positive, all three were negative, only sequencing came positive for L. Sanger sequencing. So we have developed our in-house primers now. We are amplifying that portion of the H3F3A gene and sending it for Sanger and analyzing ourselves. We have already done more than 200 cases. I will be presenting in my meet now in this one. And we found we can increase from 90%, which is around roughly 89 to 90%, we are getting 34 positivity of GCT. We can increase it to 95% if you do these markers. And 5% will remain unclassified because they have wild type of G34W. That is only morphology. Even in literature, larger studies, if you see, they have reached up to 95%. After 95%, one more concept is now coming. Instead of H3F3A, they can have mutation in H3F3B. And because the protein coded is same, IHC comes positive, sequencing is negative. That is also possible. So these are the things which, since now we are starting refining those studies, this is what we have found. But definitely those, if which are morphologically GCTs but negative, we can go for extended panel and you will usually get those markers in a percentage of cases. Half of those cases you can solve. Then otherwise you have to differentiate whether it is a solid ABC, do a USP6, especially if it is in younger patient, location is like of a metaphyseal location. Think of that and rule out a USP6 rearrangement and those things. But some remain, and morphologically we say it is a GCT. Anything?
Thanks for taking up the challenge of osteosarcomas, because I think, so I have a couple of questions and comments. I very much value your point to bring out, and just goes back to show that how morphology and radiology are still important. We have got the magic marker, but it's not 100% covering. But our morphology is GCT, radiology is, and that's how you have the variations. So I think it just goes, our best friends are still radiologists. That was one point. And I had a question about two esoteric variants which are taking, of late a lot of attention. CMF-like osteosarcoma is one, which people are getting very enticed to make that diagnosis, because chondromyxoid fibroma is a benign tumor, and I think you'll be covering that. But that CMF-like osteosarcoma, I don't have too much experience, but I do see a lot of interest coming in. People are getting, because CMF can be a little locally aggressive. Yes. And now we have a marker for that. So that, your osteoblastoma like osteosarcoma, that's another unusual. I think the FOSS is helping us towards being able to know that, and off late I reviewed a manuscript from the French group, I can't disclose, but we had to take out one case out of the 3 that they had, so kind of 2 to 3. So I agree with you that spine is a location that we have also seen osteoblastomas, but we've seen them progressing to, sarcomatous transformation. And oncosurgeons always think very black and white. Oh, there was something which was missed. That's a very convenient way, even for malignant GCTs. But what is your take on about the osteoblastoma like osteosar and CMF like osteosar?
One thing is osteoblastoma, I should tell you, there are two things, because we do have a very good neurosurgery setup, so we get a lot of osteoblastomas of spine. And one more problem happens is osteoblastomas of spine, any spine tumor is difficult to operate. They never clear it. And most of them recur. Once they recur, they say that you have misdiagnosed osteoblastoma as osteosarcoma, because they think that it should not recur. They don't understand it's a locally aggressive tumor and it is a site where they cannot clear the tumor properly. And still we insist that no, still recurrence is also osteoblastoma. But some cases, I had a problem where it was looking almost like an osteoblastoma morphologically, but it was behaving like an osteosarcoma. So such cases we should be very cautious, and we have to, at that time we didn't have it. The FOSS also we have started just doing. I am yet to analyze its utility, especially because of the IHC marker. Sometimes you have to be very careful. So until we come out with substantial proof that this is the best marker, but literature says they are good marker. And also it also depends upon what clone they have used, what we are using, and all that needs to be proved. So we have started doing FOSS and FOSS-B for those things, because 70% are FOSS positive, 30% are FOSS-B positive. So FOSS negative, you should do FOSS-B also. And then if you have a fish, you can do a fish. That is the best thing to do. But there are cases, I agree with Bharat, where I have had a problem in calling it as an osteoblastoma. Then I'd say that it looks more likely, more favor, those terminologies, standard terminologies of like how say it is an osteoblastic tumor. It looks more in favor of osteoblastoma or more in favor of an osteoblast, suggested a correlation with clinical and imaging findings because, and if it has mitosis, I'll hunt for atypical mitosis. In such cases, I really, if you find, you are lucky, otherwise no. If it has a chondroid matrix, I am little comfortable because most of the literature says chondroid matrix can occur in osteoblastomas, but it's very extremely unusual. So that is one thing. CMF things, I really have people who have mistaken CMF for a osteosarcomas and other ways also. And these come for review also. So now I have, if it is a very aggressive looking on imaging of a CMF, you know, Bharat, very cookie bite, like very classical, very narrow zone of transition. If that is not there, if it is looking little aggressive, I will be very cautious in that. Now we have started using GRM1 also. We have procured GRM1. GRM1 is a marker for chondromyxoid fibroma. So that may help in situations of these. I don't know whether it is described in chondromyxoid fibroma like osteosarcoma. GRM1, we have started using it. So that may be helpful in such cases.
So I will just finally add on towards the association here. So the two leading speakers who are coming, actually, one is the histone and chordoma brachyury person, Adrian Flanagan, who's phenomenally worked. She's like, I have to say that she's coming for real. And the other is Dr. Meera Hamid, who's the grim and several mutations in bone. So I think it's an invitation for all those who are interested that we hope. And we will have some state-of-the-art presentations, as Dr. Upan mentioned, about his work in histones, and we'll see what all. And everybody who's interested, I would also appeal that to become case collectors, if not bone collectors, towards coming as a part of our association and bring it more towards what we can learn from each other. So thank you so much. Thank you.
Thank you, sir. Continuing the sessions, I invite Dr. Nishat Afroz ma'am for her talk on chondrogenic tumors. Ma'am is currently Professor, Department of Pathology at AMU Aligarh. She has special interest in bone and soft tissue pathology and is presently the executive member of ABSTP. Ma'am is also one of the founding members of the Association of Bone and Soft Tissue Pathologists. Please.
So, good evening everyone. So, it's my honor and privilege to be here in the pink city of Jaipur, and I would like to extend my heartfelt thanks to the organizers, especially Dr. Shruti Bhargav, Dr. Rai, and others who have participated in organizing this event. So, thank you so much for having invited me here. So, my topic is chondrogenic tumors, the 2020 WHO update. So I'll keep my talk to the very basic level, to the PG level. So without wasting much time, I'll just start my talk. So the last classification came in 2013, and then the latest one is of 2020 WHO classification, which classified bone and chondrogenic tumors. And since morning we have already got into our mind that the radiology, the clinical, the radiology and everything, they play a crucial role in arriving at definitive diagnosis. So without a proper clinical history like age, duration, site of the tumor, we cannot proceed ahead. So radiology is one crucial thing which we all also know. And as Dr. Shantivi told me, I am also excited to know the radiology things, to know more about the radiology things. So the diagnostic modalities include the clinical radiology, the biopsy, which can be like an incisional or core biopsy, or maybe resection specimen, and the ancillary testing in the chondrogenic tumors may be just a few ones like S100 or IDH1, IDH2 and other ISC markers. They are not needed in most of the cases, but in few problematic cases we may need to have like IDH1, IDH2 and the retinoblastoma and P53. Like in the genetic testing, we sometimes need to know the mutation status, and the loss of some gene or gene fusion can be there. So the key points in the 2020 WHO, we should know that there are terminologies which are very specific for the cartilaginous tumors. So though they use the term conventional versus non-conventional, primary versus secondary, and they have categorized the tumor into the three broad categories: benign, cartilaginous tumors, intermediate and malignant one. Now this is the small list of chondrogenic tumors which are derived from the chondrocyte or the cartilage forming tissue, and you know that there are only few entities in the benign categories. In the intermediate they have put only two, and in the malignant one you see the chondrosarcoma. There are two types, central as well as peripheral secondary, and these are the things which I am going to discuss later on. This is an important table to know about how the changes have taken place since 2013, and now they have taken. You know that in 2013 the chondroblastoma and CMF and the atypical cartilaginous tumor were put into the category of the intermediate. What do you understand by intermediate category? Intermediate means something which is locally aggressive but very rarely metastasizing. Malignant means aggressive as well as they have got enormous potential for distant metastasis. So they have changed the categories. The intermediate categories now have only two tumors: synovial chondromatosis and the atypical cartilaginous tumor. And now they have shifted the chondroblastoma and CMF into the category of benign tumors. So when we were doing the MD, we were always taught that the GCT and the chondroblastoma and the CMF, they are of intermediate category. They have aggressive behavior. Now, as we know that in the soft tissue, we know that there is atypical lipomatous tumor and well-differentiated liposarcoma, grade 1. They have been clubbed together. Just the difference is that one is occurring in the extremities, the other is occurring in the retroperitoneum. Here also, the one which is occurring in the extremities is called atypical cartilaginous tumor, though they have the morphology as that of chondrosarcoma grade 1. However, the chondrosarcoma grade 1 is totally malignant tumor because it has got more potential to metastasize as compared to atypical cartilaginous tumor. So this is the thing which the 2020 WHO has made the difference. So you should be aware of the changes made to this thing. So this is for the PG student to understand how the benign chondrogenic tumors, what are the features. See, the cartilage tumors are very few but are very problematic. They don't have very specific features to be diagnosed as like benign or malignant or intermediate. Even a perfect expert can get confused with the kind of morphology we get to see in the small tits and bits biopsy tissue. So a thorough insight of the chondrogenic tumors, what is needed to diagnose as benign versus intermediate versus malignant tumors, this is required. The first four things, without knowing the slide what is written, we should know that radiological features are of paramount importance, because radiologists tell us the extent of tumor, whether it is a well circumscribed tumor with the sclerotic margins and there is a narrow zone of transition or wide zone of transition. And the second thing which radiologists tell us is that whether the tumor is a permeating tumor, invading tumor, or just a limited tumor which is well circumscribed. So if a benign tumor For a benign tumor, there should not be any bony erosion, bony cortex breakthrough or invasion into soft tissue. Now, after the radiology things have taken up, it is there in your mind, the four things apply to each and every tumors of body. First thing, you will always look for architecture of the tumor. The second thing, on the low bar itself, you will see the amount of cellularity. For chondrogenic tumor, the cellularity matters a lot. So if the cellularity is low or pretty high or just intermediately cellular, it is of prime importance. The second thing is that when you go to high bar, you see that whether nuclear pleomorphism is there, hyperchromasia is there, atypical mitosis is there or not. The third thing is that necrosis is always a feature of malignancy in context of chondroid tumors. The necrosis is not found in a benign tumor or just aggressive intermediate category tumors. And the third important thing about the chondrogenic tumor is knowing about what type of matrix it is. Whether it is a chondroid matrix or it is a myxoid or mucoid. You need to know the difference between a chondroid, a myxoid or mucoid matrix. They have biochemical differences, they have staining differences, they have altogether they are different things. So a benign tumor will have a chondroid matrix while an intermediate and the malignant ones will have, instead of more chondroid, they have mucoid or myxoid thing. And the mitosis, you should always look for whether they are high in number or they are atypical or typical. Now, malignant chondrogenic tumors, always they have poor circumscription. They consist of malignant chondrocytes, and the bony permeation or erosion is always there. What happens in the real story? We get tits and bits of needle biopsy tissue. We cannot say that this tissue, this malignancy or this tumor is permeating or eroding the normal tissue. So what you have to depend upon is to depend upon radiological bony erosion and permeation. Otherwise, in no way you can tell that this tumor is invading the normal adjacent tissue. So keep in mind that radiological assessment is so crucial in a biopsy sample, which is a core needle biopsy or small incisional biopsy. In this section, you can see the permeation or erosion into neighboring adjacent tissue. Then again, I told you that four things to be known, that what type of matrix it is, whether it is a chondroid or osteoid or myxoid or mucoid, or you can have, then you will focus upon architecture of the tumor, then cellularity, whether it is hypocellular or moderately cellular or hypercellular. The third thing is that you will notice that whether the nuclear pleomorphism is hyperchromasia is there, pleomorphism is there or not. The fourth thing is that the mitosis and the necrosis are there or not. So these are the points which you should by heart, because this applies to each and every malignant versus benign tumor in the body. Then there are certain locations which are very specific for chondroid tumors, and you know the benign bone tumors, conventional chondrosarcoma and dedifferentiated chondrosarcomas. You know the conventional chondrosarcomas are more common and the primary chondrosarcomas are more common as compared to dedifferentiated or secondary chondrosarcomas. Most of them, they carry the same mutation in the tumors, and hence the IDH1, IDH2 mutations are not be of much help in differentiating benign versus malignant versus dedifferentiated. So you have to rely upon the morphological features, radiological features, and the whole clinical story of the patient. Now coming to the lesions one by one, I have deliberately skipped 3 lesions. I will not go into details of that is chondroblastoma, CMF and one more. So I'll be focusing more on the lesser known entities rather than those common entities. So BPOP is bizarre periosteal osteochondromatous proliferation, and sometimes it becomes a headache to differentiate it from a tumor itself. It is a proliferation which is just haphazard combination of bone, cartilage and spindle connective tissue. And this was earlier known as Nora's lesion. Now WHO has said that don't get confused, it is just BPOP. It occurs in the young age, exophytic bony lesion, and just an exophytic lesion like osteochondroma. And it can be recurrent if not completely excised. It can reoccur, and we get confused whether it is a tumor or is it just a proliferation. So this condition is also known as a blue bone condition, where you see the lot of blue bone. Then this is just like a hematomatous proliferation. There is a mixture of bone, cartilage, spindly, fibrous tissue and all, and you will not see any regular arrangement of cartilage versus bone, and there will be no spatial arrangement and orientation. So in a typical case, you will see that this is a cartilage which is having a blue appearance adjacent to the spindly fibrous tissue area which has got ectatic vascular spaces, and this is not a tumor, this is BPOP, that is bizarre osteochondral proliferation. So in a child or a young patient which has got an exophytic bony lesion which is not eroding the cortex, having blue appearance on histopathology, just think about the BPOP. Now coming to the enchondroma bone, which has stirred up a lot of research and newer insight in our current understanding of things, not because it is enchondroma, it is because of chondrosarcoma predilection it gives to patient, and also the difficulty we get under the microscope. It is really a headache if there is insufficient radiological features available to us, or you get tits and bits of biopsy. Even an expert pathologist or radiologist, if in absence of proper history and clinical context, cannot differentiate a well-differentiated chondrosarcoma versus chondroma versus atypical cartilaginous tumor. So you have to pay attention to those nuances and the finer points which differentiate enchondroma from lookalike. So always, as I said, that the 4 things matters. First, that you should know the radiology. Second, you should be under the microscope observing the architecture, cellularity, pleomorphism, mitosis, necrosis. And obviously, above all, is the permeation of the bone. If it is there on radiology, and if you could see in the resection specimen the permeation, the invasion, then it is placing the tumor, a very benign looking tumor, into an aggressive intermediate or malignant category. Now, enchondromatosis is a condition wherein you find multiple enchondromas. And there are 2 syndromes which are known to us since our MBBS days, the Ollier disease and the Maffucci syndrome. So these syndromes, why they are important? Because they predispose a patient to malignant chondrosarcomatous transformation. So when these patients are diagnosed, the patients are kept in the regular follow-up for any sudden enlargement or development of chondrosarcoma in that. Enchondromas are generally solitary central metaphyseal lesion and the tubular bones, but they also most common primary bone tumors of the hand. Also, on the contrary, they are very rare in the flat bones of the skull and other bones. What are the genetics behind the development of enchondroma, which is carried all through the intermediate category till the malignant category, that is IDH1 and IDH2 mutations, which comprises of only of the 50% of the cases. It is not there in the 100% of cases, though they are there. So they are found in 40% of sporadic enchondroma and 80% of syndromic enchondromas. And the malignant transformation is rare in the sporadic one, while in the syndromic, the incidence can be as high as 45% to 80%, depending upon the type of syndrome. Many a time the enchondroma diagnosis is a challenge because it resembles a lot to a atypical cartilaginous tumor and the grade 1 chondrosarcoma. Diagnostic challenges already discussed. So enchondromas on radiology, they have those very nice type of rings and arc calcification, and they are known for this because there is simultaneous sclerosis going on. There is a calcification, mineralization, sclerosis, all together they are happening. So they give rings and arcs or popcorn-like appearance on radiology. Sometimes the enchondroma may not display this type rings and arcs type of calcification or mineralization. They can have just lytic lesion and endostel escalloping, which is a point in favor of malignant. Like chondrosarcoma, they have endostel escalloping, which is a feature of malignancy, but enchondroma do have, of the hand and feet, they have those absence of rings and arcs, and they have this lytic type of lesion. And first and foremost thing to look for is that you have this chondroid matrix type of thing, and the chondroid matrix, they have some lacunae which has got very benign looking chondrocyte there in the thing. And one more important feature of enchondroma is that one is known as encasement. What is encasement? The chondroma lobules, the tumor lobules are, most of the time they are bound by a rim of mature bone, and they circumscribe the tumor areas. So you have, this feature is known as encasement, and this is a very helpful sign for it being a benign lesion. And you have to really differentiate it with this is a benign encasement versus bony trabecular invasion seen in the chondrosarcoma. Again, benign, the cellularity is very low, the matrix is chondroid, there is a rim of mature bone, it's a long bone. This is very easy going diagnosis. However, it is difficult to diagnose enchondroma of the phalanges because they have this type of very aggressive looking lobules. So if you are seeing this looks very much like that it could be malignant, but it is benign because the encasement feature is happening here, and you are seeing that these are encased by these mature bony trabeculae. These tumor lobules of enchondromas are having darker appearance because they are the tumor is arising in a digit or phalange, which is most of the time darker than longer bone appearance. Again, it looks like so much like a malignant, very like a scary thing, but it is totally benign, and because in the small bones they can look very hypercellular, and they can have, but you don't find any like binucleation. Occasional binucleation is okay, but nuclear atypia pleomorphism is not very evident, and the mitosis, and especially atypical mitosis, will not be there. So always remember the enchondroma of small bones are more cellular, more dark in color as compared to the enchondroma of the long bones. So there occurs also an altogether different entity, that is soft tissue chondroma without any connection with the bone. So it's a soft tissue tumor. Now coming to the next, that is osteochondroma, previously known as exostosis, now it is osteochondroma. So we know that it is most likely a tumor. In most of majority of the cases it is isolated, but in a setting of like syndrome, multiple hereditary exostosis, if it happens, it gives a predilection for chondrosarcomatous change, that is secondary peripheral chondrosarcoma. And genetically they have a mutation which is known as XT1 and XT2 mutation, which is functional mutational loss of the activity, and you need not go for mutation detection and this and that. It is just for your academic purpose. Now, secondary chondrosarcoma is a concern in exostosis when there are multiple exostosis. Hereditary multiple exostosis is a condition which gives a very high predilection rate for chondrosarcomatous change, and in that event you will find all those permeative things and other things, and the cellularity will be higher, and the pleomorphism, mitosis, necrosis things will be happening. You know, the microscopic features are very typical of osteochondroma. They have a cartilaginous cap, then you have a bone underneath that, and there is a rim of endochondral ossification. How many types of ossification you know of? PG student? Intramembranous and enchondral is endochondral, both are the same thing. Okay, where do you find the membranous ossification? Flat bones like, yes, skull or sternum or iliac bones. In osteochondroma, they do have a cartilaginous cap, then underneath cancellous bone, and there is a rim of endochondral ossification. And this bone has got very gray, glistening, and this cap is like cartilaginous cap, and this is cancellous bone marrow region. Enchondroma is a tumor of the medullary cavity. It occurs in the central location most of the time, very rarely at the peripheral, on the periphery of the bone. And you see the cellular bone marrow or fatty marrow underneath. This is a nice slide. It's just showing the cartilaginous cap and the bony trabeculae of the bone marrow. The fat spaces are there, and there is a well-aligned chondrocytes. The chondrocytes, they have a columnar type of arrangement. So when there is a chondrosarcomatous change, this columnar arrangement is lost. Cartilaginous cap and underneath bone marrow. Then coming to the main topic, that is chondrosarcomas 2022 classification. So the 2022 classified atypical cartilaginous tumor and grade 1 chondrosarcoma as a very good behaving tumors, and they do not require aggressive treatment. However, they separated ACT from the grade 1 chondrosarcoma. Just like in the similar line of atypical lipomatous tumor versus well-differentiated liposarcoma. One is occurring in the extremities, another is retroperitoneum. Here also atypical cartilaginous occurring in the long tubular appendicular skeleton, while in the axial skeleton it is known as similar histology. Same histology, everything is same, but if it is occurring in the axial skeleton, it is chondrosarcoma grade 1. If it is occurring in the peripheral long bones, it is atypical cartilaginous tumor. And what makes up this cartilaginous tumor? These are the precursor lesion for these type of entities. So primary versus secondary, central versus peripheral chondrosarcoma, you have to remember all these things. What are the differences? Primary means arising de novo without any precursor. Central means occurring in the medullary cavity in the central location of the bone. Peripheral means occurring on the surface of the bone. Secondary means occurring aftermath of a precursor lesion which has been there for since very long. And you also know the difference between a periosteal and parosteal. Dr. Shantveer has already told you what is parosteal and periosteal. Parosteal, generally they have a rim of sclerotic bone, and you have a thin line, that lucent line is there. While in the I'm telling the opposite thing. In the periosteal you have a fibrotic rim. In the parosteal it is not. Both are growing alongside the bone, periosteal and parosteal also. But one is having a rim of fibrotic bone, one is lacking. So the biological behavior of chondrosarcoma depends on, they are graded as 1, 2, 3 depending upon the cellularity, nucleus size, whether they are hyperchromatic and mitotic activity and the cellularity degree. So first thing first, whether this is a permeative bone lesion or not, whether it is hypercellular, whether it is having a pleomorphism or not, or fourth point is whether it is having excessive mitosis or atypical mitosis or not, or necrosis is there or not. So grade 3 chondrosarcoma will have, it's a very, it's a rare cancer. 1 or 2 are more common than grade 3 chondrosarcomas. They have lot of pleomorphic abnormal cells, and they have mitosis as well. So look at these X-rays. They cannot differentiate from, you see the rings and arc type of mineralization and lytic lesion combined with the sclerotic lesion and other things are there. So this is atypical cartilaginous tumor because they are occurring in the peripheral extremities. Had these been in the like iliac bones or pelvic bone or axial skeleton, this would have been chondrosarcoma grade 1. Again the same thing. Now when chondrosarcoma develops in a pre-existing enchondroma, they do not have much difference on X-rays, and you have to really bank on MRI or the CT images because they are not going to differentiate because they are looking like one tumor, but they are two different tumors. This is enchondroma giving or converting into chondrosarcoma. So you see the endosteal scalloping there in the chondrosarcoma zone, while the shallow scalloping is there in the enchondroma zone. So this is enchondroma part, this is chondrosarcoma grade 1 part, and it is also associated with cortical thinning, cortical breakthrough, and soft tissue extension, which is the hallmark of malignant transformation. So chondrosarcoma has got extension beyond its limit, and after erosion of the bone, they go into the soft tissue and other thing, and bony permeation is there on radiology and as well as in the resection specimen you have that. So there's the bone quality is different because you have seen chondroma encasement feature. Here the encasement is not like, the bone is getting permeated or eroded by the malignant chondrosarcomatous component. This is an important thing to know how to classify grade 1, grade 2, grade 3. First thing first, you see the first thing you will focus upon the cellularity. So the cellularity is hypocellular, then hyper, somewhat less cellular than this, but you see the nuclear atypia is minimal, while the nuclear atypia is maximum. In between the two is there in the grade 2, and you also see binucleated cell occasionally in this. It is very common here, and you see the nuclear enlargement is almost 5 to 10 times, and you will see multinucleation and binucleation here. A lot of things are there. So this is how you grade the chondrosarcomas. Grade 1 chondrosarcomas look very similar to the enchondromas. As already told you that they may have a peripheral rim somewhere they have, but they will eventually have extension into soft tissue, or there is a cortical breach there. So if you focus on radiological features and in the resection specimen, you will be able to see the peripheral extension into the adjacent tissue. Otherwise, the morphology wise, it is very similar to the enchondroma, the chondrosarcoma grade 1. So one more thing I used to acquire as a helpful feature, what is the tumor size. If the tumor size is beyond 5 centimeter and it has grown rapidly over a period of 2-3 months, it is more likely to be a chondrosarcoma grade 1 rather than an enchondroma which lives for years. So the history is also important. Sudden enlargement over a period of 2-3 months and the size bigger than more than 5 centimeters, somewhere it is 5, somewhere it is 8 centimeter. So if the size is more, time duration is less, and the morphology is this type, and there is also bony permeation and extension into adjacent tissue, it is going to be chondrosarcoma grade 1. rather than enchondroma or other thing. Grade 2 chondrosarcoma, they have it's a more cellular, more nuclear pleomorphism will be there, and the ATPI will be much more. It is a difficult entity. Better to classify grade 1 or grade 3 or intermediate is a difficult thing to diagnose as a novice person. For this, you need a lot of expertise. High-grade chondrosarcoma doesn't pose any much challenge to us because they are obviously malignant, cartilage-forming tumors. So it is easy. It is in an easy-peasy diagnosis. Dedifferentiated chondrosarcoma, dedifferentiation means one low-grade sarcoma is transforming into another high-grade non-parent type of sarcoma. It applies to everywhere. Like a chondrosarcoma, which has been low-grade types, grade 1, is now transforming into high-grade sarcoma, which can be osteosarcoma, it can be undifferentiated pleomorphic sarcoma or any other high-grade sarcoma which is non-cartilaginous type. They come positive for IDH1 and IDH2 antibody, but the antibody, you know that they are not, IDH1 is not R32H type, the clone is different, the thing is different. The mesenchymal chondrosarcoma is a tumor of young children and the young people, and this is a tumor which is labeled as biphasic tumor because they have two components. One is well differentiated cartilage, the other is small blue round cell type of tumor. So if a surgeon has excised only small blue round cell area, then all the DDs of small blue round cell tumor will come into play. And if both the components are present, like nodules of hyaline cartilage surrounded by round cells, then it is an easy diagnosis. S100 will come positive, and the small blue round component, you will see the SOX9 and CD99 aberrant positivity. So here you see that this is a cartilaginous area, and this is the small blue round cell type of area. So if this area has been sampled, then all the DDs of SBRCT will come into the differential diagnosis. But the SOX9 will be positive, and it is of a sort of rescue marker. And this is cartilaginous area which will come positive for S100. And there is also hemangiopericystoma like of vasculature, this and that. That is not going to help in the small biopsy pieces because these architectures are better seen in the resection specimen rather than. So small blue round cell tumor area with the hemangiopericystoma like features and the well differentiated cartilaginous area. Biphasic tumor, two components are being represented in one field, so it is mesenchymal chondrosarcoma. The last entity is clear cell chondrosarcoma. As like all clear cell, they have vacuolated bubbly cytoplasm. Some may have pink cytoplasm as well, and this occurs in the third or fourth decade. And in the genetic, the retinoblastoma pathway is affected a lot. So the microscopy, you will see the giant cell tumor-like areas and also the clear cell area. The cells have the clear cytoplasm. So clear cell chondrosarcoma is also a diagnosis of ease. It is not difficult to diagnose, but the other DD of the clear cell tumors, clear cell sarcomas or the clear cell carcinomas are to be excluded before you give a diagnosis of clear cell chondrosarcoma. If it is arising in the bone, it is very good. If you get a tumor biopsy from a soft tissue extension, you have to really differentiate from primary as well as metastatic tumors. Clear cell chondrosarcoma is S100 strongly positive. So with this, take-home points are always low-grade chondrosarcomas are very difficult to differentiate from the chondroma. If the biopsy sample is small, you have to really put everything together, like clinical, history, radiology, and this and that. Now, combination of 5 parameters like cellularity, host bone entrapment, open chromatin, mucoid matrix. I already told that as the chondrosarcoma grade progresses, you get more of a myxoid and mucoid and cystic area rather than chondroid area. Then higher grade chondrosarcoma exhibit greater cellularity. They are more cellular. They are obviously malignant. No difficulty in saying that it is not a malignant tumor. Mesenchymal chondrosarcoma has got a lot of differential of small blue round cell tumors. Now, diagnosing periosteal chondroblastic osteosarcoma, Dr. Shantveer has already told what are the finer points which differentiate between a periosteal chondroblastic osteosarcoma versus an chondrosarcoma which is of grade 1 and grade 2. Now again the same rhetorical statement, a multidisciplinary approach is crucial and always needed in every cases of bone tumor and also the soft tissue tumors. So with this I conclude my talk, and because we are pathologists, we are also learning radiology, so we are also a clinician. So cheers for all of us. Thank you for your patient listening. That's all, and I'll be happy to take any question if you have any. Thank you.
Thank you, ma'am, for this informative lecture. Now let's continue with another interesting and awaited session, the potpourri, where Dr. Shantveer sir will be showing us the interesting cases.
So, I know this is a last session, but you'll find it very useful. Some of the interesting cases we'll look at. I want your participation for these cases, okay? So let us start with case 1. So this was an 15 years female who presented with pain over the upper part of left legs, 5 months. Patient was lethargic. So now let us go to the radiology thing. So this is a lytic lesion, very well defined, like you can make out where is the lesion and where is the normal bone. So it is very defined or geographic lytic lesion, you can say, and reaching up to the articular end, okay? But the patient is 15 years and this is what it is. What is the diagnosis on radiology? I know radiologist is not there, but let us try it out. What do you think? Benign lesion. Okay, fine. So this is the morphology. What do you have? Giant cells, spindle cells. So possibility, because epiphyseal, but 15 years. ABC possibility, because there are some hemorrhagic areas and cystic things. And can it be GCT? Possible, but less likely because there is no spatial arrangement. If you see, the cells are like, spindle cells are more fibroblastic rather than plump, and the grouping of giant cells, there are collection of giant cells, there is spindle cells, like that can happen in GCT also, but usually you classically describe as spatial arrangement. You see this? I want you to concentrate on this. There is a bone, okay? What is happening? These osteoclasts are trying to eat up that bone. It is resorption, okay? You see this bony trabeculum, can you make out? Here, osteoclast is trying to eat this up, especially if you in bone marrow and Hausip's lacunae and all. So there are areas, some storiform arrangement of cells here, osteoclastic giant cells, bland, no mitotic activity, no necrosis, and this is what it is. So it's a giant cell rich lesion. ABC is one of the possibilities. So this is the histone negative because giant cell containing lesion. So serum calcium is 8.6, little on the lower end. Phosphorus is 3.3, alphos is raised, parathormone is raised, and vitamin D is low. Vitamin D low, anything? This is not just a brown tumor. This is vitamin D deficiency associated brown tumor of hyperparathyroidism. How many have seen this? It's a very rare. Though vitamin D deficiency is quite common, but brown tumor developing in a vitamin D deficiency patient is very uncommon, very, very rare. This is, I have seen only 2 cases, okay? And even in literature, it is very, very rare. Yes, tell me. Yeah, that's what I'll tell you. Very good. This lesion, there is one lesion at the upper part also, okay? That was a subtle lesion. So this patient had a subtle lesion which was missed even by the radiologist, but rest of the bones were normal. There was no other lesion. So what we did is, we called it as vitamin D deficiency associated brown tumor. 5 months later, just patient was treated. There was no parathyroid adenoma, nothing else. Patient was just treated with vitamin D. See, it started healing. You don't have to do anything at all. See, it has already healed. The lesion has healed and the values are coming to normal. So, this is brown tumor of hyperparathyroidism, non-neoplastic osteolytic lesions of bone. You know there are primary hyperthyroidism, secondary hyperthyroidism. So, this is a type of secondary hyperthyroidism. It's not due to a parathyroid adenoma producing parathormone and producing these lesions. It is a secondary hyperparathyroidism. There is also a tertiary hyperparathyroidism. I will not go into the detail because of the time concerns. We see several of these cases in our work. If this is another case who presented with a jaw lesion, lytic lesion in the mandible, sorry. If you see, this was a lytic lesion, again showing similar giant cell containing lesion. Something unusual for a routine thing, and then we got a skeletal survey done. There was one more lytic lesion here, one more lytic lesion here, small lytic lesions, and the patient had a parathyroid adenoma which was excised, and so it's very important. Actually, this was a very interesting case. Pregnant lady presented with this lesion with pathological fracture. Initially, they thought that it is a giant cell tumor, but somehow I was not convinced, because whenever I tell this non-spatial type of arrangement of giant cells and spindle cells, and the spindle cells being more fibroblastic in nature. And third thing is, if you find this osteoid with osteoclastic activity and those things, then it indicates that you are looking at some process which is not a routine giant cell tumor. And this also patient had a very high parathyroid level and serum calcium was already. So this patient initially was thought to be a tumor. They were about to operate this patient. Then we said it is not looking like a typical giant cell tumor. It could be brown tumor. These patients were not clinically suspected, believe. On pathology, we suspected this. And later on, we investigated this patient. This patient had another lesion in the lower end of the tibia, and there was shallowing of the sella. All these are findings. So these things see. And subperiosteal resorption in the hand bones, especially if you see, there will be subperiosteal resorption, and ultrasound neck showed a parathyroid adenoma. So this lady, who was a pregnant lady, was about to be operated for GCT, thinking that it is a giant cell tumor. Because of these changes, we could suggest them, and the patient did. So I was telling about vitamin D associated brown tumor. If you see literature, there are only case reports of this entity where I have seen 2 cases of vitamin D deficiency associated brown tumor of hyperparathyroidism. And these patients just require vitamin D3. And in our country, you remember, a lot of vitamin D deficiency is there, but usually don't find so many brown tumors. There may be primary hyperparathyroidism associated brown tumors, but not this. So this was a rare case of vitamin D deficiency. Differentials you know, and all these things I have shown you because of the spatial arrangement, and this histone will be positive, brown tumors will be histone negative. And again, the other lesion which exactly mimics this is the central giant cell granuloma of the jaw. Again, there you will not have metabolic abnormality. This is our case. Again, the cells will be more spindled, fibroblastic. Osteoclastic giant cells will have lesser nuclei and the smaller size. All these things will make, and there is usually non-spatial pattern of distribution of giant cells and spindle cells. This is a solid ABC, Bharat was telling. So this was a solid ABC which didn't have any cystic spaces. Again, non-spatial arrangement, bony trabeculae, and this blue bone still was present in this case. Even though it was a solid, that blue bone is present. So this is a solid ABC. And these are the examples which we have seen several cases of this. In finger bones, earlier we used to call as giant cell lesions of small bones of hands and feet, or giant cell lesions, they are now considered to be solid ABCs. So these occur in, there the differential is you can have a GCT in that location as well. Again, histone helps in the situations because histone will be negative in these lesions. So these are all differentials for a brown tumor of hyperparathyroidism. Coming to the next case, this was a 41-year-old female who presented with progressive pain in the right knee of 3 months duration, no other constitutional symptoms, no history of trauma or any systemic examination was entirely normal. So where is the lesion? The lesion is in the patella. Can you make out? There is a lesion here. I'll show you better images because you can make out? Yeah, that bright lesion here in the patella. Here also you can make out this lesion. Huh? Yeah, that is T2 bright. This is T2 bright. Okay. Yeah. Yeah, this fat will be bright and this is also there. Okay. This is T1 because the marrow fat is positive. Okay, fine. Next. Fine. This was the morphology. Outside, a biopsy was done. It was reported as osteomyelitis. This patient was reported as osteomyelitis. This is the slide. Any diagnosis? No. Bharat is not supposed to answer. This is for residents. So what are these cells? Histiocytes. Oh, clear cells. Okay, you are thinking clear cells, but it is foamy macrophage-like cells or a clear cells. What you are thinking is a lot of inflammatory cells. Again, this areas. What is this? I want you to identify this. That is M. peripolesis. So what is it? These cells are S100 positive, CD68 positive, and OCT2 also will be positive in this. So this is a Rciapm disease. This is Langerhans and CD1A because eosinophilic granuloma or Langerhans cell histiocytosis you have to rule out. This is a non-Langerhans cell histiocytosis, Rciapm disease of bone, very rare. Patella is extremely uncommon. Only 3, this is the 3rd reported case in the world. I have written it up, I am sending. Only 2 have been reported. This is.
So there's no soft tissue, it's only the
it is only in the intraosseous within the patella, isolated involvement. Very rare. And it was reported as osteomyelitis, treated as osteomyelitis.
But again on imaging, what was it called on
Imaging osteomyelitis or giant cell tumor and chondroblastomas. Because the problem is patellar lesions are very rare and patella mein commonest lesions are either giant cell tumor or chondroblastoma. So they added osteomyelitis also because pain and some inflammatory response was there on the surface. So they thought it is either of these 3.
So you brought a rabbit out of a hat.
Yes, sir. And this patient, they did a PET scan. It was PET bright, you know. Curetas and patient is doing one. Even Curetas showed this same thing. You know that this is a non-Langerhans cell histiocytic proliferation and extranodal disease is seen in more than 40% of the cases, bone involvement in 2 to 10% of the cases. So Langerhans cell histiocytosis is a differential where you will find S100 positivity, but CD1A and Langerhans also will be positive. And those histiocytes will have the typical coffee bean or grooved nucleus. Sir was showing the cytology. So this is a common histiocytic lesion which we find in the bone compared to a Rciapm. Okay? And other histiocytic disorders are Erdheim-Chester's. It is again a non-Langerhans cell histiocytosis that can have positivity for CD68, 163 and factor 13A. And these are usually 50 to 60% are BRAF positive, which that is what it is there. These are 2 more cases of isolated bone which we have published. This was the earliest, long time back I published in skeletal radiology. That was an isolated involvement in the lower end of the femur and ipsilateral fibula, 2 lesions in the same patient, no other systemic involvement. So it was initially diagnosed as MFH, but we diagnosed it as Rciapm. The patient did well and she later on after aging she died, but without any problems of the lesion. This is a recent one, International Journal of Surgical Pathology, we published. Another isolated involvement in the foot bones, and that child was from Assam. There it was treated as tuberculosis for a long time and all. That biopsy, one of my surgeons in Hyderabad went there for some consultation. Then he sent those cases to me, and then I said, this is not that. So we diagnosed it as Rciapm and then just curated it, and she's doing well. So often misdiagnosed as osteomyelitis, okay? So these are two cases of, again, bone involvement, very unusual cases of bone involvement. This is next case, 25-year-old male presenting with pain and swelling of the left shoulder. Can you make out the lesion? Yeah, this is the lesion. This patient is a lawyer actually. Very interesting case. This is the lesion. Yeah, it's the scapula, glenoid area of the scapula. This is normal. This is because of that, the head is always little irregular, that looks normal, but this is the lesion. Here it is destructive lesion. Yeah. This is three-dimensional reconstruction, so it is looking like that.
So sometimes you don't get the plain radiograph, you get
Yeah, those things will be problem. And here also, if you see MR, it is bright. This is the lesion. This head is looking fine. So outside biopsy reported as granulomatous inflammation, AFB and fungal stains were negative. And actually, surgeon, I don't know why he wanted me to see this case. So he sent frozen section actually. The biopsy was not sent. This was a frozen section. I do bone frozens for some of them who insist on doing bone. I do diagnose some cases, but I'll just show you. This is a frozen section. This is not a regular section, okay? What do you see? It was reported as granulomatous. So again, you have histiocyte looking cells, giant cells, lot of inflammatory cells, lot of neutrophils, okay? Agreed? What are these? This is giant cells which have engulfed fungal hyphae. These septate fungi. Frozen section, okay? This is a frozen section. They thought it as osteomyelitis or a tumor. The other possibility was a tumor. So this is the closer view. You see it is almost branching at acute angle. Huh? And there are septations. So, as per this, fungal osteomyelitis. Frozen, I gave the diagnosis of fungal osteomyelitis. He sent some more tissue. So, huh? This is a regular sections. These are regular sections. Again, granulomatous inflammation. One thing we have to remember is when you have a granulosuppurative inflammation, the granuloma with central suppuration, neutrophils are there. You see, then you should suspect alternative. Even tuberculosis with secondary infection can show neutrophils. But if you have a granuloma with central suppuration, few eosinophils here and there, usually you will not see in tuberculosis. So that is a clue that should be taken and do all the special stains. These are the special stains, silver methanamine stain. Actually, I asked because I had already diagnosed in frozen, I asked him to submit it for culture, both fungal culture as well as TB examination because TB also should be ruled out. TB gene expert came negative, fungal cultures became negative. Then I am telling him fungus and bone mein fungus is very rare and he says, no, I am sure I said it is fungus, there is no way it is tuberculosis, but fungal culture is negative. Then we in our department, these are the reports from outside, I have hidden the patient details which came negative. In our department we do anti-aspergillus antibody. So IHC, this is IHC with anti-aspergillus antibody which was positive because which we do for lung and all. I do have interest in lung, I have some research work going on lung, I have published on that. So I wanted to tell him that I am sure. So this, we did anti-aspergillus IHC. Typically those hyphae are all stained. So it is an aspergillosis in bone, patient doesn't have any immunosuppression, nothing, and he's a lawyer. So now he is getting treatment antifungal because the cultures can be negative. You remember this, especially tissue zygomycosis, because they are very fragile filaments. Sometimes if the tissue is crushed and all, those fungal elements fail to grow in culture. So culture negativity doesn't mean that it is not a, this one, fungal infection. So that's why we do now use some of the fungal stains as IHC antibodies one of my paper I had done only on, I had seen aspergillus and various other, this one. And now we do in lung, these antibodies, we also have pneumocystis IHC, some of the important ones which we keep as things for doing these things, okay? No, the skin is normal, nothing, only it is isolated bone lesion. It presented as a tumorous mass or an inflammatory mass of only glenoid, nothing else. No external lesions, no penetrating injuries, because you can have penetrating injuries with osteomyelitis and all, that is, you have to suspect. But this patient presented as a lesion only in the glenoid without any external things. See, this was one of the review of aspergillus published in the literature, very rare. But usually most of them have been associated with immunosuppressed state. This patient didn't have any immunosuppression, so that is the uniqueness of this case. I'll not go into the details of it. This is another example. I'll show you some examples of this. This patient was immunosuppressed. This was porotrichosis of the bone. So that's why I'm telling fungal infection also you have to suspect. Don't report everything as routine osteomyelitis or a tuberculous osteomyelitis. This is another patient who had a penetrating injury, again aspergillus osteomyelitis of the heel. Especially in our country, they walk barefoot, farmers and all, they have penetrating injuries, and these are very important. Another one, interesting one I'll show you. These are all actual cases of, this patient had a lytic lesion in the clavicle. And this clavicular lesion, what is the diagnosis? Yeah, this was a cryptococcus of the clavicle. And what is this, the first one? What is this one? This is SM, silver methenamine. This is Alcian pass staining the capsule. Alcian is staining the capsule and the cell wall is stained by pass. What is this? You have to see, sometimes cryptococcus under polarizer, you will see that martis, that is the shining ones are those. So that is also helpful in making a diagnosis, okay? Just HND stain, you just put under polarizer, they will brighten up with a Maltese cross-like appearance, okay? This is another case, very rare. I am showing all examples which you have seen. This is a rhinosporidiosis of bone. This was a finger lesion. Oh, very unusual. So this is a rhinosporidiosis. This patient was very interesting patient. This patient had a RTA. He had a fracture of the lower end of the tibia. To fix the fractures, they put a nail in the heel and give traction. With a nail inside the heel, they will tie it to the thread and throw weights beyond to make it traction. Because of that nail, he developed fungal infection. This patient, if you see a lot of inflammation, there are areas of infarction. This is inflamed area, granulation tissue and lot of inflammation. If you see this likes a bone infarct, you know. Whenever you show a necrotizing inflammation with infarct-like thing, it's an angioinvasive fungus. Angioinvasive fungus are aspergillus and zygo. See, zygomycosis. This patient developed zygomycosis because of that pin, and this patient was a diabetic. So all these things, if we are not aware, these patients will be wrongly managed. If you don't give specific diagnosis, then it becomes a problem. This is mucor. Zygo is mucor. Broad category, I am going at a higher level like entomophthalus and this is case 4, 2 more cases. 48-year-old female, pain and swelling in the right hip, difficulty in walking 1 year. Pain was insidious on onset and gradually progressing. Pain is relieving with medication. Actually, this patient, I want you to see, everybody to see this case. There is a, Bharat, your opinion on this? No, radiology you can speak, pathology you can't speak. This was a huge lesion in the pelvis. This is different. This patient had a fracture some time back. This is an intramedullary nail. It is nothing related to that lesion. Huh? These are the MR images. Okay. I hope radiologist was there. This patient was 48 years female. And biopsy was done outside. They said, in conclusion, no specific pathology found. Yeah, there are a lot of cystic bright areas, round areas. This is all that lesion, okay? This was the excised specimen which was sent for us. The surgeon thought it is hydatid because of the multiple cystic. And what is there in between? You see, this is all yellowish fat lectin, okay? Now, let me have your diagnosis on this. See this morphology, there are these cystic areas which we are looking grossly, no? Those are all these things. Anybody has an opinion on this? This is an intraosseous lipoma. That's what see, normally in a hematopoietic marrow, pelvis, you should have marrow like this. See, this should be the marrow in a normal pelvis. There is a normal residual marrow, and this is all the lipoma, and lipomas in bone can undergo stages will be there. There are stages, milligram stage 1, 2, 3, 4. So they can undergo necrosis and cystic degeneration. And they produce this multiple cystic areas, and which is very difficult to diagnose. This is all areas of fat, you see, this is all lipoma. And this areas wherever this fat undergoes necrosis, here you see, this is fat undergoing necrosis, then it dissolves and produces those cystic spaces. So that's why it is very difficult to diagnose, diagnosing a lipoma in the breast. It's very difficult, you don't know, because that's the normal content. So many of the times intraosseous lipomas are not diagnosed. That's why the biopsy it was missed. So this is nothing but a intraosseous. If you see the book, go back, see the WHO book, you will find this is a fat necrosis. You see the outlines of the fat. After some time this dissolves and produces those cystic lesions. So they stage this, radiologist stage, and radiologists can easily make a diagnosis of this. Because there will be a fat and which is suppressed on imaging. Only thing is they can mistake this for a bone infarct. The difference is in bone infarct also you can see similar morphology. There it will never produce an expansile lesion. Huh? That's what. Bone infarct will not produce an expansile lesion. The morphology will be similar. So these are areas of fibrosis, dystrophic. This is a typical area of a lipoma. See, in between those fat is infiltrating. This was the area of necrosis of the fat I was telling. This is all fatty necrosis. That is dystrophic calcification. That dystrophic calcification will produce ring and arc type of thing, and it can be confused for chondrosarcoma or a chondroid lesion. So this is a possibility. So it is an intraosseous lipoma of pelvis. Unless you are aware that it will happen.
Can those bone marrow replaced by the fat be mistaken for a plastic anemia kind of like?
If you do a biopsy without lesion is there, because normally hemopoietic marrow in a pelvis is a central portion. Vertebra in adults, pelvis should have full marrow. It will not have fat there. Unless the patient has received a radiotherapy or something, unless or hypoplastic marrow. If similar thing, I have seen couple of cases, the commonest site is calcaneum actually for lipoma. There it becomes difficult because peripheral bones don't have marrow. There you don't know whether it's a normal marrow or it is a lesion. There you have to go by radiological findings and make a diagnosis. So these are the locations. Coming to
What was it called on biopsy? And that
they said it is a normal tissue. They never thought that. They said fat and
it was reported outside.
outside on core biopsy.
And then that led to a resection based on
Because the imaging it is such a big mass and they wanted to resect. Core biopsy was done, sir. Outside it was.
They may not catch the lesion in core.
And because it is very difficult, even if it had come to us, I would have said the same thing, because lipoma diagnosing on a core biopsy is very difficult. It could have been mistaken for a normal fat and bony trabeculae. So it's a very, just wanted to tell you that how these lesions, which are not even actual tumors, can also come to you. You should be aware that you should think of these possibilities. And
So there is one lesion actually very peculiar on the neck of
this is liposclerosing fibromyxoid tumor.
Lansdale tumor.
Uh,
We've seen 2 to 3 cases of those,
Yes.
which actually are lipomas with myxoid areas and foamy tumors.
Yeah, that is also similar. What Bharat is telling, it is called as LGFMS. Those liposclerosing myxofibrous tumors. And that also, I saw 1 or 2 cases with Jambekar madam also when I was in TMH. So those also will show similar changes. There it will not be an expansile lesion. It is just a lytic lesion in the neck of the femur. And that is one lesion which can mimic this lesion.
This must be the largest lipoma in bone.
I have not seen, first time I am seeing such a big lipoma. And it was going on, the patient is having pain since 1 year, nothing much happening. This is another interesting case. Bharat knows this, 47 years male, a pain in the right hip, 6 months duration, no history of trauma, no constitution. If you see, the entire femur is involved by a lesion. And there is some break if you can make out. Okay? So there is a thinning of the cortex. The entire femur is, it's not a well-defined lesion because we don't know where it is starting, but there is some problem in this lesion. These are the imaging findings on a CT. There's a, within the medullary cavity only, it has not come out. These are the MR. MR, if you see this is hypo. This is the normal fat. Okay? This much is the lesion, almost from this level to this level. And same thing is bright. So actually this patient biopsy was done in NIMS. We diagnosed it. And this patient later went to TMH for treatment. Manish operated this case long time back. This is, I have borrowed from Dr. Jambekar madam. So this was the resected specimen from TMH. So this was totally filled with these cystic things. What is it? Hydatid. This was, madam had aspirated this thing from the cysts. So these are all squalices of the hydatid hooklets you can make out. And this is mouth with those hooklets around it. This is a histopathology. Membrane and classical squalices and all those things. So this is that membrane is showing a foreign body giant cell reaction. So osseous hydatid, we have a lot of collection of osseous hydatid, almost 20 cases we have seen of osseous hydatidosis which are there. I will not go into the details of this. These are some of the examples which we have seen of osseous acetabulum, spine. This is both femur, upper end and ilium. That was a chest wall mass. All these are histology proven. Almost 20 cases of osseous hydatidosis. Very unusual. It can mimic any tumor. None of these cases, except for 1 or 2 in 20, none of them were diagnosed on radiology. It was all pathology diagnosis. They were all mistaken either for some bone tumor, osteomyelitis, neurogenic tumor if it is in the spine, because it was looking like a cystic schwannoma. All these misdiagnosis and diagnosed only on pathology. Okay, this is the last case. This is Potter actually. I want a diagnosis from the postgraduates if they are there. 48-year male who presented with degenerative arthritis changes in the hip. If you see the shape of this, you see if you see this head, it is very rounded, normal looking. You see this side, the first is this gap is reduced because the cartilage has disappeared. The gap between the head of the femur and the acetabulum is because of the cartilage. There will be a gap there. That gap has disappeared means the cartilage has gone. So it has lost that cartilage and the shape is also not rounded. If you see, there is a degenerate. So this patient was having pain, so they took him for surgery and removed this head and replaced it with a prosthesis. And this was the specimen which we got. Diagnosis? Normal cartilage should be glistening white. What is this color? It is tar-like. What is it? See this cartilage cap, it has gone off here. There is a still cartilage here and it is totally black. Histopathology. Any diagnosis? Even it was there in the marrow and also in the synovium which was removed. This is ochronotic arthropathy, ochronosis. The cartilage becomes black because of the deposition of the homogentisic acid. This is the spotter actually. For exams, if it is there, I will give this slide for exam. They have to make a diagnosis. Okay. So these are few cases we have seen. One in the neck. This was the earliest case actually, which patient presented with cervical degenerative changes. And same morphology, that pigmented ligamentous tissue and cartilaginous tissue will be there. That time when I was senior resident, this slide is of 22 years back, okay? And so I was so excited that I diagnosed this. I went to the ward, collected the urine of the patient. We did all these tests. This was urine on standing, it becomes beer brown color. If you alkalinize the urine also, it becomes darker color. I did a Benedict's test because homogentisic acid is a reducing substance. So it will use false positive Benedict's reaction. And that was ammoniacal silver nitrate test, which will precipitate the silver, metallic silver black. So I was so excited that I diagnosed on the this one, because we didn't have history, so we wanted to prove it. So we collected and proved that this patient had a ochronosis. This is the cycle, how it, there is a defect in that enzyme, so it is accumulated. And this homogentisic acid has a affinity for this cartilaginous and ligamentous tissue, and it gets deposited there. So these are some of the other examples later we saw. They can have scleral pigmentation. This is a sclera of one of the patients which is pigmented here. Even his skin is pigmented here, you can make out, and palm pigmentation. And radiologically, one of the findings is you will have intervertebral disc calcification. So that is also seen in these patients. So that completes few of the interesting cases which I thought I should share. Thank you so much. I hope you enjoyed the slides. Fibrous dysplasia.
Because I was just wondering, it's so much like a
Ground glass appearance.
It's the rolled in membranes.
Yes.
So that's the clue.
And one more thing peculiarly about hydatid cyst in bone is, normally in other organs, hydatid cyst, daughter cyst will encyst. There is a cyst wall around and the cyst will encyst. In bone, it exists outside. So that's why, that is one peculiarity of hydatid of bone. That's why it is very spreading. Sometimes it is more aggressive than a malignant tumor to resect it out and all. It's earlier in literature, this was called as white malignancy because of those white membranous things and all. Aggressive lesions. Couple of our patients had to undergo amputation because they were recurring, and every year 1 or 2 cases, and we have collected almost 21 cases of osseous hydatid over the year. Okay? Thank you.
Thank you, sir, for sharing these interesting and rare cases. As we come to the end for the valedictory, I invite the members of the organizing committee to felicitate our speakers. First of all, I request Ranjana ma'am, the Vice President, Rajasthan chapter of IAPM, and the organizing co-chairperson for today's CME, to felicitate Naresh Rai, sir. Thank you, ma'am. Thank you, sir. Now I request Dr. Arpita Jindal, ma'am, organizing co-chairperson for today's CME, to felicitate Dr. Bharat Rekhi, sir. Thank you, ma'am. Thank you, sir. Next we have, I would invite Dr. Shruti Bhargav, ma'am, Secretary, Rajasthan Chapter of IAPM, and also for today's CME, to felicitate Dr. Shantveer, sir. Ma'am, thank you, sir. Thank you, ma'am. I now request Dr. Vandana Yadav, ma'am, Treasurer, Rajasthan Chapter of IAPM, and also for today's CME, and Dr. Kishore Khatri, sir, Executive Member, Rajasthan Chapter of IAPM, to felicitate Dr. Nishat Afroz, ma'am. Thank you, teachers. Last but not the least, I invite Dr. Shruti Bhargav, ma'am, Secretary, Rajasthan Chapter for IAPM, and also for today's CME, to deliver the vote of thanks.
Thank you, Dr. Rimjim. So good evening, everyone. And as we come to an end for this wonderful day, it is my privilege and honor to propose the vote of thanks for today's remarkable CME. So my heartfelt gratitude to our guest speakers, Dr. Bharat Rekhi sir, Dr. Shantvi Rupin sir, and Dr. Nishat Afroz ma'am, for agreeing to be part of this CME at such a short notice, sharing your expertise and insights, which has indeed enriched our understanding and perspective. My sincere thanks to everyone in the organizing committee for the exceptional teamwork. And here I would like to specially mention my gratitude to Dr. Naresh Rai sir, President Rajasthan Chapter, for his ever-ready encouragement, motivation and support even at odd hours. Dr. Anjana Solanki ma'am, Vice President, for her meticulous and timely help in spite of her hectic travel plans. And my colleague, Dr. Vandana Yadav, Treasurer, who has indeed been my right hand, not only for this event, but always, ever since we have known each other. So, and we are deeply grateful to our sponsor for today, Dr. Arpita Jindal, Chairman of Rciapm 2024, whose generous contribution has made this event possible today. My gratitude to the Master of Ceremony for today, Dr. Rimjim Shrimal, who has actually been on toes since morning to manage this event so well. Special thanks to our event management team headed by Mr. Gautam, photographer Surendra ji, and the audiovisual team. Last but not the least, a big thank you to all the delegates, without whom this CME would not have been a success. And finally, a humble gratitude to Almighty for giving me all the strength to shoulder this responsibility. And in the end, as the organizing secretary for today's CME, I accept absolute responsibility for any shortcomings that would have inadvertently happened during the event. So thank you once again, and it has indeed been a pleasure today, a memorable day for, I'm sure, all of us. So thank you so much.
Hello. I would like to thank Shruti and Vandana for actually initiating the conference, because if they wouldn't have, we wouldn't have had. So, मुझे thank करने का कोई ज़रूरत नहीं है. It's just that we organized the Rajpathcon last year, the state conference, and we had some money left. So I have been telling my juniors that please organize and make use of that money so that we finish it fast. So maybe in due course of time, in another couple of months, we'll have more CMEs. Yeah. Thank you. Thank you.